Good afternoon, everybody. Thank you for your attendance. My name is Thamer Al-Isa. I'm a consultant endocrinologist, head of division at Jabir Ahmed Hospital in Kuwait. I would like to welcome you to the oral session. I'm joined today with my colleague, Dr. Huda Izzuddin Mustafa. She's a consultant in diabetes endocrinology, director of the academic affair at the Health Plus Center for Diabetes and Endocrinology in Abu Dhabi. We would like to welcome you to the oral session. This is a session for 5 oral presentations submitted as abstracts, selected by the abstract committee in the GAED conference. And they will be presenting their data in this presentation. We will have 5 oral presentations delivered to you today. Each presentation will be 8 minutes for presentation of the data, plus 2 minutes for discussion. We would welcome your questions regarding the presentation to be written in the Q&A box. We'll be glad to present them to the speakers to get the information needed. The best of those 5 presentation orals will be selected and will be presented in awards at the end of the closing remarks in today's end of the Congress. So without much delay, let me start with our first presenter. So our first presenter is Dr. Walid Kaplan. He's a consultant endocrinologist at Tawam Hospital in Ain in UAE. And his presentation will be, or abstract presentation will be about short stature assessment and referral in the Gulf region. Dr. Walid, you have 8 minutes. You can start.
Thank you very much. I would like to thank the abstract committee for giving me the opportunity of presenting the result of our survey. It is well known that the effect of growth hormone treatment on the final height outcome is relating positively with the duration of treatment and negatively with the age of the patient. In another meaning, the younger the child at the onset of treatment and the longer the duration of treatment, the better the outcome. In spite of that, global information from growth hormone registries and large studies indicate that growth hormone treatments start later or much later than recommended, which reflects negatively on the final height. And it is thought that the delay in referring the cases from primary care physician is the main contributing factor to this delay in treatment. A group of senior pediatric endocrinologists in the Gulf region wanted to analyze this in our region. So we have created a 22 multiple choice question survey. The first part of the survey was intended to evaluate the clinical background of the respondent, to ensure the credibility of the generated information, and the rest of the survey was focused on the potential causes of delayed referral related to the assessment of short stature, perception of growth hormone indication, safety and efficacy, and the approval of treatment by insurance companies. The target participants were general pediatricians, family practitioner, and pediatric subspecialists, with the exception of pediatric endocrinologists, of course. And the survey was open for a period of 30 days. We have received 640 responses, out of which 450 have answered the whole 22 questions. And we have summarized the results in the following slides. So responses by country, you can see that Saudi Arabia has the largest number of responses, followed by UAE, Kuwait, and then Oman, Qatar, and Bahrain. More than 65% of the respondents are general pediatricians or pediatric subspecialists, and almost 80% of them reported having more than 10 years of clinical experience, which confirms the credibility of information provided in this survey. 75% of them reported working in a government hospital, and 75% of them were members of a multi-specialty group. The definition of short stature was answered correctly by more than 80% of the responses using either the height standard deviation score or the height percentile I showed in the slide. And of almost 90% of them reported using either the WHO growth chart, the CDC growth chart, or the locally generated national growth chart, and all these options are considered acceptable. However, we asked them how they measure the height of the children in their practice, and as you can see in this slide, less than 50% of them reported using the wall-mounted studiometer, either exclusively or partially, while more than 50% of them use the weight scale with the extended height measuring arm, or even 6% reported not measuring the height at all, but taking the height from external source. In this question, we have listed non-clinical conditions. 7 of them are FDA-approved indication for growth hormone treatment, and 2 are not. And we asked the participant to choose which one of those conditions would they refer to pediatric endocrinologists for growth hormone treatment. And as you can see, only growth hormone deficiency was selected with high percentage, while many of the FDA-approved indications were selected by 50% or less of the participants. And we asked furthermore, do you consider growth hormone treatment an option for children with short stature? Less than 60% responded positively. And a second question about the safety of growth hormone for children with short stature, and only 60% of the respondents reported positively about the safety of growth hormone, which leave 40% of the participants either not agreeing with the statement or not sure about them. The last question was about the insurance coverage for growth hormone. And as you can see in the slide, 44% of those working in a government hospital confirmed a coverage of growth hormone for all the cases. 25% reported sometimes coverage, while 30% were either not sure or reported no coverage for growth hormone. It's much worse for the private sector, where only 6.5% reported the coverage is confirmed always, 31% sometimes coverage, and about 52% not sure about the coverage. So in summary, the vast majority of the primary care physicians use the correct definition of short stature and the proper growth chart. However, less than 30% are measuring height correctly in their practice. 50% of them lack awareness of the approved indication of growth hormone. 60% or less consider growth hormone an option to treat short stature, and only 60% perceive growth hormone treatment as safe. And apparently treatment coverage by payer is reported by 50% or less as definite. Our conclusion that the delay in referring children with short stature could be due to one or more of the following reasons. Number one, incorrect measurement of height, which lead to missing some cases. Knowledge gap about the approved indication of growth hormone. Misperception about growth hormone safety or efficacy by primary care physicians, and lack of treatment approved by payer. We identify a significant knowledge gaps from this survey that should be addressed by a formal and structured educational effort about the assessment of short stature and the safety and efficacy of growth hormone treatment. I would like to acknowledge the contribution of my colleague from the Gulf countries, listed in the alphabetical order, and also Angie Romani, the Senior Medical Manager of the Rare Disease in Pfizer Company. Thank you very much.
Thank you, Dr. Walid, for this presentation. Appreciate the contribution. If there's any question, let's see, there might be a question. Yes, there is a question from audience, Dr. Walid, saying, was growth hormone stimulation before treatment was asked? And if so, what were the results?
Thank you. We have asked about the diagnostic workup they use, and about 60% of them, if I remember the percentage correctly, reported a growth hormone stimulation test as one of the tests.
And I'm not getting any other questions. Dr. Huda, do you want to add, do you have a question?
Thank you very much, Dr. Walid, for the well-organized and clear presentation. Of course, whenever there's a survey presented, number one question is about the survey tool, whether it's been validated or used before.
I'm sorry, can you explain again?
So it's regarding the tool, the survey tool that you have used. Has it been validated, or do you have a reference for it?
Well, we use the Survey Monkey, and again, we've come together to put the questions that their answers would indicate the potential area that we were questioning, but it was Survey Monkey that answers your question.
So Survey Monkey would do the analysis, but the actual validation of the questions is probably through peers. And
as I said in the beginning, it was the advisors from the 6 Gulf countries that we've met twice formatting the survey. We have deleted some questions, we have revised other questions to make sure that the answers are as objective as possible.
And one more question, have you noticed any knowledge gap differences amongst participating centers?
Yeah, we haven't done a sub-analysis to look at the different countries. That is something probably might be needed when we plan to do the educational campaign to address the areas that might be different in different areas.
Thank you very much, Dr. Waleed.
Sure. Thank you.
Dr. Rida, I might have maybe one or two questions. If you're considering writing up this information in terms of article and you want to do a discussion about challenges related to diagnosis and therapy, where you would find the challenges are in that part with your survey among physicians?
Well, I was surprised when the simplest thing that we were expecting to be done was not met, which is simply measuring the chart height correctly by using a wall mounted stadiometer. In my practice, I receive good number of cases that I basically sign off simply by measuring the height of the child and then find it being normal against what the primary care physician found. But on the other extreme, that they might actually overestimate the height and missing cases of short stature. This is very simple and it can be addressed and fixed correctly. However, the approved indications, we have now 8 approved indications for growth hormone by FDA, and apparently growth hormone deficiency is the only one that is known by majority of primary care physicians. So this needs to be addressed as well.
Thank you so much, Dr. Waleed. I think we're almost done with your presentation of the time allocated. So thank you so much for joining us. I would like also to welcome our also member of the oral committee evaluation, Dr. Ali Al-Karni, joining us. He's a consultant endocrinologist at King Abdulaziz Hospital, Ministry of National Guard Health Affairs. He's also going to be taking rounds and presenting the speakers for tonight. Dr. Huda, go ahead for the next talk.
Sure. So the next presentation is about the risk factors associated with progression of diabetes and neuropathy. And for that, we have Dr. Georgios Ponirakis from Doha, Weill Cornell Medicine, Qatar. So the floor is yours, Dr. Georgios. You have 8 minutes.
Hi from Qatar. I'd like to thank the committee, the Gulf Association of Endocrinology and Diabetes, for giving us the opportunity to present the work done here in Qatar. So the title of my work is about looking at the risk factors associated with progression of diabetic neuropathy. There are limited longitudinal studies that have assessed the association between risk factors and the evolution of diabetic neuropathy. Currently, there are no drugs FDA approved for diabetic neuropathy, so we're treating the risk factors that are associated with diabetic neuropathy. So the things we look at, it was to assess the association of diabetic neuropathy, painful diabetic neuropathy in patients with type 2 diabetes over 2 years, looking at risk factors including age, duration of diabetes, obesity, hyperlipidemia, hypertension, microalbuminuria, weight, and physical inactivity. That's for the baseline. And also we look at for the association of changes in HbA1c, body weight, waist circumference, BMI, lipid profile, blood pressure, albumin-creatine ratio, and the association of anti-diabetic drugs that induce weight gain and physical activity over the 2 years with changes in corneal confocal microscopy, which I'm going to explain in a moment, changes in the vibration perception threshold, and also with neuropathic symptoms. This is a 2-year prospective study involving Hamad General Hospital, Diabetes Clinic, and Weill Cornell Medicine here in Qatar. And these are the PI of this study. The inclusion criteria was patients with type 2 diabetes, aged between 18 and 70, healthy controls in the same age range with a HbA1c lower than 6%. And the exclusion criteria we included was anemia, renal failure, other cause of neuropathy other than diabetic neuropathy, including immune disease, infections, inherited disease, and inflammatory disease. We also had to exclude patients with severe dry eyes, corneal dystrophies, ocular trauma surgery preceding 6 months before the assessment for the corneal confocal microscopy test. These are the risk factors that we examined, and here's where I define how we define them. worth mentioning, for the physical inactivity and activity, we use the Global Physical Activity Questionnaire, version 2. And for anti-diabetic medications that induce weight gain, we include insulin, sulfonylurea, TZD, and for weight loss, metformin, GLP-1, and SGLT2 inhibitors. For the vibration perception threshold, we apply on the large toe, and we measure the perception to feel vibration. For neuropathic symptoms, including burning pain, painful cold, electric shocks, tinglings, pins and needles, numbness in the feet, we use the DN4 questionnaire. And we define diabetic neuropathy based on one symptom or more, and with a VPT equal or higher than 15 volts. For painful diabetic neuropathy, we use the DN4 questionnaire with a score equal to or higher than 4 points out of 10. Now, let me illustrate a little bit about the CCM. This is the device we use to examine the eyes, to look at the nerves in the cornea, and we measure the nerve fiber density, branch density, and the total length of the fibers using software for objective quantification of these parameters. There's a slight touch there of the eye. And this is how the nerves looks like in the cornea, the white lines. Okay, so we recruited 78 subjects with type 2 diabetes with a duration of diabetes 13 years, 26 healthy controls. They were age matched and sex matched. In the type 2 diabetes cohort, the prevalence of poor glycemic control was 92%, obesity was 65%, physical inactivity 58%, hyperlipidemia 22%, hypertension 21%, microbilinuria 28%. In terms of duration of diabetes, those who were had less than 10 years of diabetes were 29%. Those who had diabetes duration between 10 to 19 years, 45%, and those more than 20 years, 26%. The prevalence of diabetic neuropathy was 18%, and for painful diabetic neuropathy, 26%. Those who were on the anti-diabetic drugs were 75%, and those who were that induced weight gain, and those who were on diabetic drugs that induced weight loss were 89%. Now, looking here on our first table, where I'm illustrating the demographics, clinical characteristic and neuropathy measures. When we look at the baseline data and we want to compare between healthy controls and type 2 patients, there was significant difference in HbA1c, lipid profile, body weight, and BMI. And when we look at the neuropathy measures, starting with the corneal confocal microscopy, we can see that there was a significant lower nerve fibers in branch density and fiber length in the type 2 cohort compared to healthy controls. And with the vibration perception threshold, patients with type 2 had a higher vibration perception threshold compared to healthy controls. In the next column, where we look at the changes over the 2 years, we notice that there is a moderate improvement in HbA1c in type 2 patients. There is also an improvement in LDL. There was a slight reduction in body weight in type 2 patients. And when we look at the corneal confocal microscopy, the corneal nerve morphology, we see that there is a significant reduction in the branch density here and in the fiber length. Not so much, there was a reduction, but not significant in a fiber density. There was no change in the vibration perception threshold, but there was an improvement in the neuropathic symptoms within these 2 years in type 2 patients. Now, next thing, we look at the association of the risk factors at baseline with the baseline neuropathy measures. And we see that the corneal nerve morphology had no association with any of the risk factors at baseline. Duration of diabetes and physical inactivity was associated with higher vibration perception threshold, and AIDS and anti-diabetic drugs that induce weight gain were associated with more neuropathic symptoms. Next, looking at the changes in the neuropathy measures, whether they had any association with the risk factors, our data shows that physical inactivity was associated with changes in the fiber density, with reduction in fiber density, and with reduction in fiber length. That is, after we adjusted for all the co-founding factors that were associated with the neuropathy measures. Duration of diabetes was associated with reduction in branch density. We didn't find any association within the 2-year period of any risk factors on vibration perception threshold. What we noticed that patients who were at baseline having painful diabetic neuropathy based on the DN4 questionnaire were associated with an improvement in neuropathic symptoms at follow-up. And just to illustrate better the association of physical activity, inactivity, or activity with changes in neuropathy measures, first of all, we see that in healthy controls between baseline and 2-year follow-up, there was no significant change, either in fiber density, branch density, or fiber length. When we look at those who were physically inactive in type 2 patients, we see that there was a significant reduction in all parameters, in the fiber density, branch density, and in the fiber length. Whereas those who were physically active, we noticed there was no significant change in the fiber density and in fiber length, but there was a significant reduction in branch density. And this graph illustrates, again, this change, the association of physical inactivity and activity. So the black bars illustrate the healthy controls. The red bars illustrate those who were physically inactive, and the blue bars, those who were physically active in the type 2 cohort. And looking at the fiber density, we can see there's only significant reduction within 2 years in those who were physically inactive. The same with the branch density and fiber length. Whereas with those who were physically active, only with the branch density we found a significant reduction. So to conclude, there was a modest improvement in HbA1c, body weight, and LDL cholesterol in type 2 patients in our cohort. No change in the prevalence of diabetic neuropathy or painful diabetic neuropathy or vibration perception threshold within the 2-year period. However, there was a progressive nerve loss, reduction in branch density, fiber length in physically inactive patients. And so physical inactivity may limit the progression of diabetic neuropathy. That's our conclusion. And I'd like to thank our sponsor, Qatar National Research Fund, who sponsored our study. These are the investigators, all of them who were involved in this study. Thank you very much for your time.
Thank you very much, Dr. Georgios, for the interesting presentation. I'm sure this will attract some discussion. Let me just start by asking you a few things. So are those assessment methods for DPN are done routinely or are just done for the study case?
For the study case, yeah. Well, something that Dr. Imad will present later, they start applying the vibration perception threshold, looking at patients who are at risk of developing diabetic neuropathy in Hamad General Hospital, but not the CCM, not the corneal microscopy. Yeah.
Dr. Tamer, if you have any other question, because we're quite short in time. Otherwise, I have other question if you would allow.
I think we're running out of time, so we can give equal time with every presentation. I think Dr. Ali can present the next presentation. Thank you.
Great. Thank you.
Well, good afternoon. Do you hear me well? Thank you. It gives me the pleasure to present the third abstract, Prevalence and Predictors of Hypogonadism Recovery in Men with Macroprolactinemias Treated with Dopamine Agonist, presented by Dr. Aisha Al-Khazemi, consultant endocrinologist in Saudi University.
Good afternoon. I would like to thank the abstract committee for giving me the opportunity to present this work on behalf of my colleague who participated in this study. The work was led by Dr. Khalid Dahmani, and it's an honor to present it during this prestigious meeting. It is about the prevalence and the predictors of hypogonadism recovery in men with macroprolactinoma treated with dopamine agonist. These are the outline my presentation. We know that hyperprolactinemia is common. It forms about 50% of all the pituitary tumor the functional type. Prolactin is an anterior pituitary hormone, which has a main principle of physiological role and action in initiation and maintenance of lactation. Besides the other causes of hyperprolactinemia, we know that drugs, chronic illness can affect the prolactin level. Here, I'm focusing on macroprolactinoma related to the pituitary tumor. We know microprolactinoma, less than 1 centimeter, is common in women. Macroprolactinoma, more common in men, more than 1 centimeter in size. The reason that men usually present late because of their subtle presentation of erectile dysfunction and hypogonadism. And when the issue comes to infertility, they come usually late. So for that reason, they present with macroadenoma. The common presentation of macroprolactinoma in men, either due to the tumor mass effect that cause visual field defect and headache, or a symptom related to hypogonadism, as I mentioned earlier, decreased libido, erectile dysfunction, and infertility. What is reported in the literature that hypogonadism in patients with macroprolactinoma in male, it forms about 75% at the time of the diagnosis, either due to prolactin level effect on gonadotropin releasing hormone suppression, causing hypogonadism, or direct effects of the tumor on gonadotroph cells, causing destruction of the cell and causing hypogonadism. In different studies, the report of hypogonadism, the prevalence of hypogonadism at a presentation at the time of diagnosis was variable between 50 to 93% most of the time. The goal when we treat male patients with hyperprolactinemia related to macroprolactinoma is to restore eugonadism status in those patients by normalizing prolactin level and tumor mass reduction. We have noticed that even it was published before in a small number of studies, if you can see here, the number of the patients included in those studies is small, that the prevalence of hypogonadism at the time of a presentation is it's variable between 50 to 90%, and those with persistent hypogonadism actually between 40 to 60%. So the reason we are presenting this is to find out the prevalence of hypogonadism in our area, a region of hypogonadism in male patients with macroprolactinoma, and the predictors of recovery, because it's very important to early identify patients who are likely to recover from hypogonadism to avoid unnecessary testosterone replacement, and also to identify those patients who need testosterone replacement earlier to avoid complication related to hypogonadism. So as I said earlier, data are limited regarding the prevalence, especially in our region, the prevalence and the predictors of persistent hypogonadism after treating patients with dopamine agonist. Most of the studies that were published, there were small numbers of studies with small number of patients, and they were involved, they were single center study. So we decided to do a multi-center study to evaluate the prevalence of hypogonadism in men with macroprolactinoma treated exclusively with dopamine agonist, and also to determine the predictors of recovery of hypothalamus pituitary gonadal axis following dopamine agonist therapy. So it's a multi-center retrospective study of male patients with macroprolactinoma treated with dopamine agonist between 2009 to 2019, so over 10 years. The participating centers in the Gulf region, 2 centers from United Arab Emirates, Tawam Hospital and Dubai Hospital, and 3 centers from Saudi Arabia, King Fahad Medical City, King Saud University Medical City, and National Guard Hospital. The cases were identified based on ICD-9 and 10 codes. So macroprolactinoma cases were considered in male patient with macroadenoma and prolactin level more than 2,000 international units per liter, with radiological and biochemical evidence of response to dopamine agonist. Patient with microprolactinoma patients with macroprolactinoma requiring additional therapy like surgery and radiotherapy, or those patients presented with clinical apoplexy were excluded from the study. We collected the baseline data, the age of the patient at presentation, year of diagnosis, presenting symptoms related to macroprolactinoma in terms of mass effect, or symptoms related to hypogonadism like infertility, erectile dysfunction, and decreased libido. Tumor site at presentation based on the radiological imaging, type of dopamine agonist used, bromocriptine or cabergoline, duration of therapy in years, tumor size post-therapy, and also hormonal profile post-therapy during physician assessment of the patient and during follow-up period. So there were 101 patients included. 24 patients were excluded from the study because those patients had surgery, either they had surgery, had clinical apoplexy, or we didn't have enough data about their clinical information or presentation. 85 patients were included in the study. Looking at the result here, so clinical characteristic of the patient. So the median age of the patient at the presentation was 33. And the tumor side median at the presentation was 2.7 centimeter. So we classified different size of the tumor and the number of the patient based on the tumor size. Most of them actually between 2 to 3.9 centimeter in terms of the size of the tumor at the presentation. A duration of the therapy were calculated in years. Median was 6 years. Most of the patients we used, they used cabergoline during as a medical therapy for the hyperprolactinemia. 2 or 3 patients used bromocriptine. Commonest presentation was headache, the main presentation, 75% of the patient, followed by erectile dysfunction, 55%, then decreased libido and visual disturbance. So regarding the hypogonadism at the time of a presentation, so the prevalence was 75.6% at the time of the diagnosis in terms of the hypogonadotropic hypogonadism at the presentation, followed by growth hormone deficiency, which was 35%, and then hypothyroidism 14%. So we were evaluating the other pituitary hormonal deficiency during assessment of patients with macroprolactinoma. Regarding the median level of prolactin at the time of presentation, it was 20,000. Maximum was 500,000 in terms of the level if we look at the minimum and maximum range of prolactin level. Regarding the testosterone at the time of presentation, median level was 4.4. And it can be low between 0.5, upper limit was 28 for some patients. What about the factor related to hypogonadism recovery? We found out that 65% of those patients with hypogonadotropic hypogonadism at a presentation recovered their gonadal axis, where 35% actually still having persistent hypogonadotropic hypogonadism. If you see here in terms of the prolactin level at the time of presentation, those who recovered, the median level at the time of presentation was 18,000, lower compared to those who didn't recover. So the higher level at the time of presentation, 63,000 here, as you can see here, compared to the lower level at the time of presentation, predicts the recovery of hypogonadotropic hypogonadism after medical therapy. Even looking at the testosterone level, those who recovered hypogonadotropic hypogonadism after medical therapy tend to have higher level. The median was 4.6 compared to those who didn't recover after giving them medical therapy. If you look at the other axis, like there was higher chance of recovery of growth hormone axis and and thyroid axis if they actually recover their gonadal axis. Even if you look at the tumor size, those patients who recovered their gonadal axis tend to have a smaller size of the tumor. It was between 2 to 3.9, so it's in general less than 3 centimeter. Compared to those who didn't recover the gonadal, the hypogonadism, they tend to have a larger tumor size of 4 centimeter and more. So this is actually the largest. When we look back at the literature, we found that this is the largest study to include larger number of the patients to assess the prevalence and recovery of hypogonadism in men with macroprolactinoma treated with medical therapy. The prevalence, as I said, of hypogonadism at presentation 76.5, and recovery, the percentage of recovery after medical therapy was 65%, similar to what have been published in different studies. If you look at this table, you can see different studies published by many authors over the last 15 years, and the recent one by Sihambi in 2020. They included small number of patients compared to our study. And if you look at the
time is completed. We are up to the time, please.
Okay, so compared to the percentage, hypogonadism was 75%, similar to almost similar to the other studies, and the persistent and recovery of hypogonadism was 65%, almost similar to what have been published, but there was variability in the percentage because of the co-founding factor affecting hypogonadism at that time. Looking at the tumor size, we found that tumor size 3.9 centimeter and less is a good predictor of recovery of hypogonadism in patients with macroprolactinoma. Here at the time of recovery, we found that the patient recovered their gonadal axis almost within 48 months, almost within 24 months, and the latest was 48 months. This, the strength of the study, it was the largest one to include larger number of patients treated with dopamine agonists, and confirm what have been published before in the smaller number of patients that the prevalence of hypogonadism is almost between 65 to 90%, and recovery is about 40 to 60%. As I said, we defined the predictors that was not identified before. The predictor of recovery, tumor size, the smaller size, higher recovery rate, and also the baseline level of prolactin. The lower the level of prolactin at the presentation, the higher chance of recovery. Our limitation is this retrospective study, non-systematic evaluation of prolactin level and other hormone. We didn't have data about the time of the hormonal evaluation, was it in the morning during the day or late during the day? And also we didn't consider the confounding factor that affects hypogonadism besides prolactinoma, like diabetes, comorbidities, or all other patients, and also different assays on different centers. So it was there was variability in the term. So in conclusion, 65% of men with macroprolactinoma recovered their gonadal axis after treating them with medical therapy. Predictor of hypogonadism recovery, smaller adenoma size, lower prolactin level, higher testosterone level at presentation, and lower rate of hypogonadism on a presentation related to hypogonadism recovery. So we need further prospective study to evaluate this and assess the tumor size as a cutoff point to predict recovery, and also identify confounding factors that affect hypogonadism in those patients. I would like to thank my colleague, the primary investigator, Dr. Khalid Zatmani, who read this work, and also my colleague from Gulf country, from United Arab Emirates, Dr. Musa Al-Malki from Saudi Arabia, Dr. Ma'abber, Dr. Aladdin Bashir, and Dr. Sadiq. Thank you so much.
Well, thank you, Dr. Aisha. I think we are passing the time allocated, so we'll skip the discussion for the interest of time. Thank you.
We go back for our next presenter for the next presentation, Dr. Ahmed Al-Ghamdi. Dr. Ahmed is a consultant endocrinologist at King Fahd Medical City in Riyadh in Saudi Arabia. His presentation is going to be about the thyroid one-stop clinic for newly referred patients with thyroid nodules. Dr. Ahmed, you can start your presentation.
Thank you very much. Thank you, Dr. Thamer, and thank you for the committee to choose my abstract for the oral presentation. Thyroid one-stop clinic is an emerging new approach in providing an integrative diagnostic and therapeutic care for thyroid nodules patients that has been shown to save cost and time compared to the conventional approach. What do we mean by conventional approach? 5 visits, at least in our institute. The first visit, the patient will come to the clinic, will be assessed and examined by the primary doctor, and the second visit, blood test and ultrasound thyroid would be done. Then the patient will come for the third time to the clinic, and the doctor will see the results for the blood test and the ultrasound. And they will order, the doctor will order the ultrasound fine needle aspiration, usually through the interventional radiology department. Then the patient will come for the fifth time to the clinic for the definitive management plan. The Thyroid One-Stop Clinic that was initiated in 2017, the pathway of it is as follows. The patient would arrive to the clinic, TFT will be done. Usually it would take about 1 to 2 hours duration to result. And then based on the TFT, if the TSH is low, usually we will repeat or we will send the patient to the nuclear medicine, but the approach would be aborted. If the TSH is high or normal, then bedside ultrasonography for the thyroid would be done. And based on the thyroid nodules criteria, the ultrasound FNA would be conducted. And then cytology assessment usually will be done also inside the clinic by the DIFQIC initially, and then later sent to the laboratory for the PAP stain. And final decision would be taken for the thyroid nodule based on the assessment of the cytology. So the aim of this study is to measure the effectiveness of this approach in terms of the time and cost reduction compared to the conventional way that takes usually, as we said, 5 visits, in addition to the assessment or measure the safety of this new approach. The study was a prospective study that involved the comparison between these two arms, the Thyroid One-Stop Clinic and the conventional. It carried out at KFMC Thyroid Clinic in Riyadh in period between 2017 and 2020. The inclusion criteria for the patients, they were adult, age 18 or more. The TSH, as we mentioned earlier, would be needed to be normal or high. There will be need for the ultrasound for the presence of thyroid nodule or nodules that are applicable for FNA according to the ATA and or the ACR TIRAS criteria. And finally, the consent. The exclusion criteria would be pediatric age less than 18 because we don't treat pediatric patients. Suppressed TSH less than 0.35 in our institutional laboratory, and cooperative patients, or if they are on active anticoagulant medications. The primary outcome from this is to measure the total amount of time taken from the first visit to the final diagnosis and decision. The second primary outcome was the cost spent by the patients, and it was estimated at the end of their journey based on a questionnaire. The secondary outcome, biopsy disclosure time, we mean the time from the FNA to the final or to the clinical decision. The secondary outcome, the patient experience overall satisfaction rate, and that's also assessed through the, so the secondary outcome was the patient experience of overall satisfaction rate. That's usually also assessed through the questionnaire. And the third secondary outcome was the severe complication rate that is assessed at the end of the procedure clinically. The statistical analysis was done through the SPSS software, and we used, as we all know, the t-test for the continuous variables, while the chi-square test for the categorical variables comparison. The statistical significance was set to be less than 0.05. This is the baseline characteristics. So the age, there was no significant difference between the age in two arms. The gender, or for females, percentage also was not significant. The number of visits, 5 versus 1. Number of patients according to the place of residence from the central region, we mean Riyadh and Riyadh City and Riyadh region. There were 66% versus 75 in the Thyroid One-Stop Clinic. North region, there were 20% in the conventional arm, while 10% only in the Thyroid One-Stop Clinic, and the South was 13 versus 15%. So here are our results. So the time taken from the first visit till the decision, the conventional clinic, and I have to say also that those patients were taken from all the clinics. I mean, they were randomly assigned from all the clinics, all consultants in the institution taking care of endocrinology and dealing with such thyroid nodules issues. So the time taken was 138 days, the mean in the conventional group, while in the thyroid one-stop clinic was 2.5, because we need also to count the dates for the pap stain that's sent to the laboratory for the final diagnosis from the pathologist. And it was clearly significantly different. The estimated cost by the patient per patient was in Saudi Riyal was 3,566 in conventional group versus only 408 Riyals in the as I mean in the thyroid one-stop clinic. If you can see also, if we fragment the estimated cost per patient per place of residence per patients according to the regions of Saudi Arabia, we can see always that there is like statistically significant difference. If we take Riyadh city, the same city we are, Riyadh region, north of KSA, also the south of KSA. The secondary outcome was the biopsy disclosure time. That was 20 days, plus minus 2.5 as standard deviation in the conventional group, and only 2.5 plus minus 1.7 in the thyroid one-stop clinic, which is statistically significant. The overall experience satisfaction rate was 51.25% in the conventional group, while 100% satisfaction rate in the thyroid one-stop clinic. The severe complications rate were alhamdulillah 0 in both arms, and then I don't know if you can see the last row that I was mentioning about the Bethesda score category, for both groups, specifically the non-diagnostic, which is category 1, that was 5% in the conventional group, while thyroid one-stop clinic 7%, which is not statistically significant. So here we just put this bar chart for the place of residence and the mean cost in Saudi Riyals. And as shown earlier, there is like difference according to the region. And you can see the same difference happens with a very reduced amount of cost spent. Here is the satisfaction rate, and it's the mean, as we mentioned, about 51%, while it's 100% in the thyroid one-stop clinic. Here, just I want to show you that the Bethesda results from both groups, the benign, were like the majority 63 in the one-stop clinic, 73 in the conventional clinic. BTC is almost the same, and non-diagnostic also not significantly different. So here, this study is actually the first conducted study of its kind in Saudi Arabia, and I can say also maybe in the Gulf. There was only one report in the literature by Dr. Patel from Melbourne, Australia, where he is a surgeon and he is doing FNA for his patients. So he reduced, and his group actually reduced the times of patients' visit from 3 to 2. Then their median ultrasound FNA to the definitive management plan was 14 days from 41 days. So the efficacy of the patient is like efficacy of the approach is as shown is like very effective and safe. While the main limitation here in the this approach is the practicality, which means that this approach needs well-trained staff, needs well-equipped clinics, needs also the policies in the institute to be like well built to make the to increase or enhance the streamline of the work for the patients and make the those days like to be reduced significantly, as well as the cost accordingly. So in conclusion, I would say that the thyroid one-stop clinic approach significantly shortens the journey taken by the newly referred patients with thyroid nodules, is extremely cost-effective, and significantly improves the overall patient experience and satisfaction. However, this approach is always multidisciplinary for that would take care of the patient-centered care actually, and requires qualified care providers as well as well-equipped clinics. Thank you. And at the end, I want also to thank my group that worked with me on this approach over the past 3 years. Pathology, nurses, and like they are long list and deeply from the heart, I thank all of them. Thank you very much.
Thank you, Dr. Ahmed, for presentation. We appreciate your presence with us here. For the lack of time, unfortunately, we need to move on to our last presentation. Dr. Huda?
So the last presentation here, we're having the prevalence of diabetic peripheral neuropathy in the Arabian Gulf region. And for that, we have Dr. Imad Burma, who is a consultant endocrinologist at the King Fahd Medical City in Riyadh, who also works in the obesity and endocrine metabolism department. So Dr. Imad, please, you can proceed with your presentation.
So I would like to thank the organizing committee of this prestigious conference for giving us an oral presentation. I'm presenting on behalf of the group that has conducted this study from Saudi Arabia, Qatar, and Kuwait. And basically, we know that diabetic peripheral neuropathy is a devastating complication of diabetes that leads to painful diabetic peripheral neuropathy and diabetic foot ulceration, which are both basically unwanted morbidities. When we talk about diabetic foot ulceration, 1 in 4 of these patients are at risk of amputations, and they have 2.5 increased risk of mortality. And there has been studies done in the Gulf region with regard to the prevalence. Basically, it is in the MENA region regarding the prevalence of DPN, which has widely ranged from 17 to 53%. And for painful DPN, also widely ranged from 18 to 65%. This was mainly due to different patient characteristics, but also different methodology used in the diagnosis of DPN. And we know that identification and treatment of risk factors are really very important step in delaying the development as well as the progression of DPN. So the objectives of this study was to establish the prevalence and risk factors of DPN, that refers to diabetic peripheral neuropathy, painful DPN, and diabetic foot ulceration, here referred to as DFU. That was in patients with type 2 diabetes in secondary care health centers in Qatar, Kuwait, and Saudi Arabia. So this was a trans-Gulf study. And it was a multi-center study, as you've seen the centers, which is a cross-sectional, which has a cross-sectional design. And it was conducted in the period between June 2017 and May 2019. And the lead PI is Professor Riaz Malik, who's a world-renowned expert in the field of neuropathy. He's done a lot of clinical investigation and care for these patients. Also joined by Dr. Georgios Ponirakis, who just presented the second study, I think. The second center was also in Qatar, in Hamad Medical Corporation, Dr. Tariq Al-Hadi, and the third center was from Kuwait, Dr. Iba Al-Uzeri, and my humble self was from King Fahd Medical City, of course, with my other colleagues, Dr. Nadi Johani and Dr. Wael, and Dr. Ishwana. Regarding the inclusion criteria for the study, it was type 2 diabetes, adults with age 18 to 85 years of old, excluded type 1 diabetes, and importantly, all other causes of neuropathy, such as vitamin B12 or folate deficiencies, secondary to malignancy, or other causes of neuropathy. And we use the vibration perception threshold through the use of the neurophysiometer, which is a well-validated tool against nerve conduction studies, as well as nerve biopsies in the diagnosis of abnormal VBT. And it is just shown here by Professor Riaz Malik, which is used by actually by placing the probe in the pulp of the like toe and then measuring the vibration thresholds 3 times, and we take the average from both feet. The normal is less than 15 volts, and the impaired VBT is 15 or more, with those who scoring 25 and more are at high risk of DFU. The neuropathic symptoms that were captured were burning pain, painful cold, electric shocks, tingling, pins and needles, and numbness. the diagnosis of DPN was made in the presence of at least one neuropathic symptom or more, plus impaired VBT, that's more than 15 volts. Painful DPN was diagnosed using the well-validated DNR4 questionnaire. A score of 4 or more would diagnose patients with painful DPN. And DFU was diagnosed as basically a break in the skin, as shown here in the slide. So it is a break in the skin of the foot that involves the epidermis and or part of the dermis. And again, important definitions before we go to the results: poor glycemic control, A1C more than 7%, hypertension, systolic blood pressure 140 or more, all on antihypertensive medications, hyperlipidemia, total cholesterol 6.2 or more millimole per liter, and or triglycerides more than 2.3 millimole, or on statin or fibrate. BMI more than 30 would define obesity, and physical activity was self-reported here and was basically defined as walking for more than 30 minutes a day, at least 3 times a week over the year preceding the study. Smoking or smokers were defined by smoking at least 1 cigarette or more per day, or like every day for the year preceding the visit. And vitamin D normality was defined as more than 30 nanogram per ml, with mild deficiency defined as 20-29, moderate 10 to 19, and severe less than 10 nanogram per milliliter. This is the baseline characteristics of the study population. The first column here is the whole cohort from the 3 Gulf countries, and it is more than 3,000 patients with type 2 diabetes, quite a large number. Here is the demographics of these patients. The age is 57, mean diabetes duration is 14, very long duration. Females constituted 46% of the cohort. And basically, sadly, more than 70% of these patients has poor glycemic control, 75% hyperlipidemia, 65% hypertension, 56% obesity, 33% only were physically active, and around 22% were smokers. Systolic blood pressure was controlled. Mean hemoglobin A1C was around 8.2, and basically the lipid profile looks basically okay for this cohort. There are some inter-country differences here. As you can see, there are more patients from the Saudi Arabia cohort, which is around 760, who had poor control and hyperlipidemia. And we see the numbers from Kuwait is 1,100, and we can see that they have higher rate here of, I think, smokers here and physical inactivity. And basically, the cohort is generally well matched in terms of, the capture of these data. Now we go to the first graph, which showed the outcomes of interest. Here, the prevalence in the y-axis, and we go first with the prevalence of DPN. The gray bar shows the cohort from the 3 countries merged together, and it is 33%. While we see differences here, the lowest prevalence was reported in Qatar, 23% in red, while Kuwait had the highest, 40%, and Saudi Arabia in the middle, 35%. There are significant differences, of course, between the countries and Qatar. When we looked at the high risk of diabetic foot ulceration, again, for the total cohort in gray, 52% was the prevalence for this outcome. Again, there were variations between the 3 countries, with the highest reported in Saudi Arabia at 59%, followed by Kuwait, 54%, and then Qatar, 40%. Regarding the diabetic foot ulceration, it was a bit lower than actually the general reported in the world, which is usually 6% or more. So here we see the overall is 2.9. The overall prevalence is 2.9%, which is the same number that's reported from Qatar, with Kuwait being slightly less at 2.6%, and Saudi Arabia slightly more at 3.3%. Lastly, the prevalence of painful diabetic peripheral neuropathy, again, for the whole cohort, 43%, with highest number reported from Kuwait at 51%, followed by Saudi Arabia, 39%, and then Qatar, 37%. Sadly, 50%.
We would need to conclude soon. If you can just wrap up your presentation.
Sure. So unfortunately, more than 50% of these patients were undiagnosed. When we look at the risk factors for DPN, it was basically defined here as age, longer duration of diabetes, poor glycemic control, hyperlipidemia, obesity, physical inactivity, as well as cigarette smoking. Females were less likely to develop DPN. For the painful DPN, we see again poor glycemic control, longer duration of diabetes, physical inactivity are actually known risk factors for this condition. When we look at the risk factors for the DFU, these are the presence of DPN, hypertension, as well as vitamin D deficiency. So in conclusion, DPN was reported in 1/3 of the cohort, and 1 in 2 of these patients had high risk for diabetic foot ulceration, and alarmingly, half of them were undiagnosed. Painful DPN again was reported in 1/3 of these patients. Also, 50% of these were undiagnosed. And the risk factors for DPN as well as painful DPN are poor glycemic control, longer diabetes duration, increasing obesity, hyperlipidemia, and lower physical activity. Females had a lower odds for DPN, but higher odds for painful DPN. And for increased risk of DPN, the risk factors are DPN, hypertension, and vitamin D deficiency. And thank you. And I'm sorry for passing my time. I would just like to acknowledge my co-authors who contributed to this study and the funding that were received from Qatar National Research Fund, King Fahd Medical City, and Pfizer Gulf. Thank you.
Thank you very much, Dr. Imad. I really appreciate all the speakers, all the time and effort spent in this discussion and preparation and presentation. I'm sure that a lot of you would like to hear more and discuss more about their presentations, but because of the short time allowed for each presentation, we can't do that, unfortunately. We will all be hearing about the results of the abstract presentations towards the end of the Congress today. And I hope that you will, have all your presentations written in a manuscript and submitted in peer-reviewed journals for a better discussion and sharing of the knowledge. Thank you all for your participation. I'll hand over to Dr. Tamer.
Thank you so much, Dr. Huda. I really appreciate the efforts of the oral the abstract committee first, led by Dr. Khalid Al-Dahmani, and also in the oral abstract committee with Dr. Ali and Dr. Huda. Thank you for all the presenters for the hard work in developing this manuscripts and results. We're really grateful for sharing that with us, and thank you for being here with us. Hopefully, we're wishing you the best, and for the audience, we wish you to stick around. We'll have a great symposium, and then the rest of the Congress we hope you enjoy. Thank you so much for being with us. Thank you.
Assalamu alaikum. Good evening. I'm going to basically be discussing the Sanofi-Solimic study. I have no disclosures. The objective of my presentation is going to be discussing the challenges regarding premixed insulin, exploring the range of evidence for fixed ratio combination, insulin glargine in combination with lixisenatide, iglar-lixi, in terms of better efficacy and safety versus premixed insulin, and conclusions. So as we all know, guidelines for injectable therapy are quite clear. Due to the progressive nature of type 2 diabetes, many individuals not controlled with oral anti-diabetic drugs will require advancement to injectable therapy. So we have initial injectable therapy in the form of GLP-1 receptor agonist, basal insulin, combination injectable therapy, premixed insulin. EASD generally recommend GLP receptor agonist as a first injectable option. Basal insulin or combined injectable therapy can also be considered as first injectable therapy depending on patient profiles. NICE recommend premixed insulin as an initial injectable in those with HbA1c of more than 9%. As we all know, intensification of injectable therapy is in most instances required. And then in that case, we combine basal insulin with GLP-1 receptor agonist or vice versa. Fixed ratio combinations of basal insulin plus GLP-1 receptor agonist basal plus prandial insulin, that is basal plus and basal bolus regimens, and premix insulins. Premix insulins are efficacious at the expense of weight gain and hypoglycemia risk versus basal insulins, as we all are aware. People with type 2 diabetes, uncontrolled on basal insulin, who switch to premix insulin in randomized controlled trials, we can clearly see HbA1c reductions after 24 or 26 weeks, anywhere from 0.8 to 1.9%, reaching a p-value of less than 0.01, but this comes at an expense, which is greater body weight increase. And we can clearly see with premix insulins, the weight gain could be anywhere from 0.8 kilogram to 5.4 kilograms, and with basal insulins from 0.1 kilogram to 3.5 kilograms. And not only that, it is again associated with increased hypoglycemia risk, premix insulin more so in terms of 3.4 to 8.2 events patient per year versus basal insulin from 0.7 to 5.4 events patients per year. I'll be talking about the UK Thin database, a retrospective UK cohort study, which looked at the effectiveness of premixed insulin to achieve glycemic control in type 2 diabetes. Adults with type 2 diabetes, HbA1c of more than 9%, inadequately controlled on more than or equal to 2 oral anti-diabetic drugs. They were switched from OADs to premixed insulin, 974 eligible participants. The primary outcome was probability and incidence of achieving glycemic control, that is HbA1c of less than 7.5% over 24 months post-premix insulin initiation. Sensitivity analysis included incidence of improving glycemic control, that's more than 1% HbA1c decrease or more than 2% HbA1c decrease over 24 months post-premix insulin initiation. The key results were as follows. Probability of achieving glycemic control HbA1c less than 7.5% following premix initiation was low, less than 20%. It was highest at 3 to 6 months, 18.2%, plateaued after 15 to 24 months. Incidence of achieving HbA1c of less than 7.5% or improving more than 1% or more than 2% HbA1c decrease from baseline glycemic control following premix initiation plateaued after 24 months. IDMPS observational study results and conclusions. We can clearly see that the HbA1c was 8.4% with basal compared to 8.8% with the premix insulin. Proportion of patients with HbA1c less than 7% was 17.5 in patients who received premix insulin versus 20.8% those who received basal insulin. More patients experienced hypoglycemia in the premix insulin, 32.5% versus 19.8% in the basal insulin. In conclusion, approximately 80% of adults with type 2 diabetes in the IDMPS database treated with premixed or basal insulin did not achieve adequate glycemic control. The incidence of hypoglycemia was high, indicating there is an unmet medical need to improve clinical outcomes in IDMPS countries. Barriers to optimal use of insulin, as you all are aware: fear of hypoglycemia, fear of weight gain, multiple daily injections, complex regimen. And these are further compounded by the use of premix insulins. So greater risk of hypoglycemia versus basal insulin, greater risk of weight gain, multiple daily injections, increased self-monitoring requirements. Therefore, the greater likelihood of barriers to optimal use of premix insulin may suggest that the efficacy observed in randomized controlled trials is difficult to achieve in real-world practice. Advancing therapy in suboptimally controlled basal insulin-treated type 2 diabetes, clinical outcomes with iGlarlixy versus premix by ASP30 in the Solimix randomized controlled trial. Population included adults with type 2 diabetes, failed to reach glycemic control with basal insulin plus 1 or 2 oral anti-diabetic drugs. Head-to-head randomized controlled trial comparing iGlarlixy versus by a premix insulin by ASP30, the Solimix study. It was an open-label, randomized, active-controlled, 26-week parallel group multi-center study comparing efficacy and safety of iglorlixi versus premix insulin analog BIASP-30. This study will be the first to assess the comparative efficacy and safety of advancing basal insulin therapy by switching to twice-daily premix insulin regimen or by switching to a simpler once-daily fixed-ratio combination such as iglorlixi. This was the study design. Adults having type 2 diabetes above the age of 18 years, inadequately controlled by basal insulin, combined with metformin plus minus SGLT2 inhibitors, HbA1c of more than 7.5% and less than 10%. 443 patients were randomized to receiving iglorlixi once daily, and 444 patients were randomized to receiving BIASP 70/30 twice daily. And it was studied till week 26. Two primary efficacy endpoints were looked at: non-inferiority of iglorlixi to BIASP-30 in HbA1c reduction from baseline to week 26, non-inferiority margin of 0.3%, superiority of iglorlixi to BIASP-30 in body weight change from baseline to week 26. Key secondary efficacy endpoints: superiority of iglorlixi versus BIASP-30 in the proportion of participants reaching HbA1c target less than 7% without weight gain at week 26, proportion of participants reaching HbA1c target less than 7% without weight gain at week 26 and without hypoglycemia less than 70 milligram per deciliter during the treatment period, HbA1c reduction from baseline to week 26. Other secondary efficacy endpoints that were looked at was the proportion of participants reaching HbA1c target less than 7% at week 26, change in total insulin dose from baseline to week 26, change in fasting plasma glucose from baseline to week 26. Safety endpoint hypoglycemia was thoroughly studied. It included, but not limited to, any hypoglycemic event, ADA level 1, blood glucose less than 70 milligram per deciliter and more than 54 milligram per deciliter, ADA level 2, blood glucose of less than 54 milligram per deciliter, ADA level 3, severe hypoglycemia requiring assistance. Serious adverse events of special interest were looked into as well. Patient-reported outcomes was also looked at. Treatment-related impact measure diabetes, TRIM-D scores, patient and physician rated global treatment effectiveness evaluation, GTEE scores. We'll just look into the baseline characteristics of the Solimix study. So if you look at the two groups, the iglorlixi group and the BIASP-30 group, they were well matched. Age was 59.8 years. Female, there was a very good representation of females, 50%, BMI of 30, duration of type 2 diabetes of 13 years, HbA1c 8.6%, average basal insulin daily dose was 0.4 unit per kilogram. That means they were pretty much on adequate dose of basal insulin. SGLT2 use at screening was 23%. So very well matched groups. If you look at the background OAD use percentage of participants, as expected, 76% were on metformin alone, 23% were on metformin plus SGLT2 inhibitors, less than 1% on metformin plus other and SGLT2 inhibitors alone. If you look at the prior basal insulin at baseline, from 42 to 49% were on insulin glargine 100 unit per ml, 22% were insulin glargine U300, 23% were on NPX, 7% were on insulin detamere, and 4% were on insulin degludec. Both primary efficacy endpoints were met. So iglorlixi was non-inferior to BIASP-30 in change in HbA1c from baseline to week 26. Just to remind you, the mean the baseline HbA1c in the two groups, the iglorlixi and the BIASP-30, was 8.6%. At week 26, the iglorlixi group achieved HbA1c of 7.3%, and the BIASP-30 group achieved HbA1c of 7.5%. The LS mean change in HbA1c from baseline to week 26% was 1.3% in the iGLAR-LIXI group versus 1.1% in the BIASP 30, resulting in an LS mean difference of 0.2, thereby achieving non-inferiority and superiority with a p-value of less than 0.001. iGLAR-LIXI was superior to BIASP 30 in change in body weight from baseline to week 26. Just to remind you, the baseline body weight in iGLAR-LIXI group was 80.7, in the BIASP 82.2. At week 26, the weight in the iGLAR-LIXI was 80.2 versus 83.4 kilogram in the BIASP 30. Therefore, LS mean change in body weight from baseline to week 26 was 0.7 kilogram reduction in weight in the iGLAR-LIXI group versus a gain of 1.2 kilogram in the BIASP 30, resulting in a LS mean difference of 1.9, thereby achieving superiority. HbA1c target achievement without weight gain and without hypoglycemia was significantly greater with iGLAR-LIXI versus BIASP 30. So significantly greater proportion of participants in the iGLAR-LIXI group compared with the BIASP 30 group achieved HbA1c of less than 7% without weight gain at week 26, 27.5% in the iGLAR-LIXI group versus 12.4% in the BIASP 30. HbA1c of less than 7% without weight gain at week 26 and without hypoglycemia during the treatment period, 19.4% in the iGLAR-LIXI group versus 7% in the BIASP 30 group. HbA1c of less than 7% alone, 42.2% in the iGLAR-LIXI group versus 31.8% in the BIASP 30 group. Greater reductions in fasting plasma glucose and lesser increases in total insulin daily dose were observed in iGLAR-LIXI versus BIASP 30. So there was a 1.07 LS-me reduction in the fasting plasma glucose in the iGLAR-LIXI group versus 0.16 millimole per liter reduction in the fasting plasma glucose in the BIASP 30 arm, resulting in an LS mean difference of 0.91. And in terms of total insulin daily dose, there was an increase of 10.6 units in the iGLAR-LIXI group compared to 22.9 units in the BIASP 30 arm, resulting in an LS mean difference of 12.2 units. So clearly less total insulin dose was needed in the iGLAR-LIXI group. Reduced incidence of hypoglycemia, which is again very important in terms of safety and patient outcomes over the 26-week treatment period with iGLAR-LIXI versus BIASP 30. Incidence of anytime hypoglycemia, any hypoglycemic event, the incidence was 31.2% in the iGLAR-LIXI group versus 42.4% in the BIASP 30 group. ADA level 1 hypoglycemia less than 70 and more than 54 milligram per deciliter. The incidence was 25.8% in the iGLAR-LIXI group versus 38.5% in the BIASP 30 group. ADA level 2 hypoglycemia was 6.3% in the iGLAR-LIXI group versus 12.9% in the BIASP 30 group. Relative odds reduction, 38% of any hypoglycemic event in the iGLAR-LIXI group, ADA level 1 hypoglycemia, 45% reduction in the iGLAR-LIXI group, and ADA level 2 hypoglycemia, 55% relative odds reduction was seen in the iGLAR-LIXI group. So conclusion, iGLAR-LIXI demonstrated lower incidence of any ADA level 1 and ADA level 2 hypoglycemia compared with BIASP 30. Only 3 ADA level 3 hypoglycemic episodes were reported, 1 in the iGLAR-LIXI group and 2 in the BIASP 30 group. Reduced rate of hypoglycemia was seen in the iGLAR-LIXI group, ADA level 1 and ADA level 2, compared with BIASP 30. There was 33% relative rate reduction with iGLAR-LIXI versus BIASP 30 in terms of any hypoglycemic event ADA level 1 hypoglycemia, 29% relative rate reduction with iGLR-LIC group versus BIAPS 30 group. ADA level 2 hypoglycemia, 60% relative risk reduction with iGLR-LIC versus BIAPS 30 group. So the SOLIMIC study looked at the nocturnal hypoglycemia as in an post hoc analysis endpoint. Nocturnal hypoglycemia, as we all know, is very important. 2 nocturnal hypoglycemia intervals were utilized for the SOLIMIC trial. Between bedtime and waking, more representative of clinical practice, as we all know, between midnight and 6 a.m., often used in randomized controlled trials as reducers confounders. Hypoglycemia endpoints, ADA level 1 less than 70 and more than 54, ADA level 2 less than 54, ADA level 3 severe. ADA level 1 hypoglycemia, we can clearly see incidence of ADA level 1 hypoglycemia was lower with iGLR-LIC versus BIASP 30 between midnight and 6 a.m. and was similar between bedtime and waking. And you can clearly see the lower incidence of level A hypoglycemia between midnight and 6 hours with line of unity moving in favor of iGLR-LIC. Incidence of ADA level 2 hypoglycemia was lower with iGLR-LIC versus BIASP 30 for both nocturnal hypoglycemia intervals. You can clearly see the endpoint moving away from the line of unity in favor of iGLR-LIC during the both nocturnal intervals between bedtime and waking and between midnight and 6 hours. Key results in terms of efficacy. Compared with BIASP 30, iGLR-LIC demonstrated non-inferiority of HbA1c reduction, superiority of HbA1c reduction, superiority of body weight change, greater proportions of participants achieving HbA1c less than 7% without weight gain and without weight gain and hypoglycemia. Benefits observed with iGLR-LIC were accompanied by a smaller mean daily insulin dose at week 26 in the iGLR-LIC group compared with BIASP 30. In terms of safety, rates and incidence of hypoglycemia were lower for iGLR-LIC than BIASP 30. Proportion of participants with adverse events was slightly higher with iGLR-LIC, basically the GI intolerance, than BIASP 30 due to higher incidence of GI adverse events. Serious adverse events and study discontinuations due to an adverse event were low and similar for both arms. The overall safety and tolerability profile of iGLR-LIC and BIASP 30 were comparable with those reported in previous studies. No unexpected safety signals were identified. Conclusion: result from this first trial comparing a fixed ratio combination of basal insulin and GLP-1 receptor agonist iGLR-LIC with a premixed insulin BIASP 30 provide evidence for the better efficacy and safety of iGLR-LIC with a simpler regimen compared with premixed BIASP 30 in adults with type 2 diabetes advancing their treatment from basal insulin plus 1 or 2 oral anti-diabetic drugs. iGLR-LIC may facilitate optimal advancement of therapy in people inadequately controlled on basal insulins by providing better glycemic control with weight benefit and less hypoglycemia than with premix BIASP 30. Thank you for your kind attention. And if you have any questions, I'm more than happy to answer. You can write them down in the Q&A chat box.
Thank you very much, Dr. Zinat. Thank you.
Assalamu alaikum. Good afternoon, everybody. I hope everybody is enjoying the Congress. I'm Yusuf Saleh. I'm the immediate past president for GAED, Gulf Association of Endocrinology and Diabetes. It gives me great pleasure to welcome you all to the GAED middle presentation for the year 2021. And this prestigious presentation has been given this year to a very distinguished speaker from the United States, and I'm really pleased and honored to present Professor Dawson Hughes. Professor Dawson Hughes graduated from Tufts University School of Medicine, where she completed her house training at the same university, and then subsequently she finished her fellowship training in endocrinology at Harvard Medical School. She is a very distinguished well-known authority in the world in the field of bone and mineral metabolism. She has more than 425 peer-reviewed journal articles, book chapters, and reviews. And she received many awards for her research and scientific leadership, including the International Osteoporosis Foundation President Medal and the IOF Award for Scientific Achievement. She is currently the General Secretary of the International Osteoporosis Foundation, and she is the past president of the National Osteoporosis Foundation. She is the founding director of the Center of Advancement of Science and Space, and this is a board which directs research and technology development on International Space Station National Laboratory. Her interest is mainly calcium, vitamin D, protein, and the acid-base balance of the diet, influencing age-related bone and muscle losses. She is one of the most highly cited researchers and one of the top 1% in her field. And we are really pleased and honored and engaged to listen to her presenting on year in vitamin D. Professor Miss Dawson Hughes.
Hello, greetings from Boston. It's a pleasure to be with you today to address the year in vitamin D, and it has been quite a year. I will be showing you my disclosures here, and then moving on to the objectives of the presentation. We will discuss the impact of vitamin D on muscle performance, on risk of falls, what have the recent mega trials added, and we'll explore the possibility of a alternative pathway by which vitamin D may influence falls, and wind up with a very brief rundown of some of the other important outcomes in these mega vitamin D trials. So we know that there are age-related changes that occur in muscle. We lose our muscle fiber number that goes down, and we lose it disproportionately in the type 2 fiber category. These are the fast twitch fibers that affect our ability to catch ourselves were we to fall, to start to fall. And moreover, we lose stem cells for the type 2, these so-called satellite cells, which fits together with the fact that we have fewer of these cells. So what does vitamin D have to do with this, if anything? Well, interestingly, Bischoff Ferrari some years ago looked at the vitamin D receptor number in human muscle biopsy specimens, and saw that as a function of age, there were fewer and fewer of the vitamin D receptors, suggesting a role for vitamin D here. We've had, over the years, many studies and meta-analyses looking at the effect of vitamin supplementation on muscle strength. In this example, a very fine meta-analysis by Charlotte Bodar. Interestingly, the study that was very influential in the conclusion that vitamin D supplementation improves strength was the study by Sato, which has since been retracted. Without that study, it's questionable whether this meta-analysis would have shown an association of supplementation with improved muscle strength. We also have the older study that's a classic, often cited study of the same vintage, roughly, by Michael Pfeiffer, showing that body sway was greater in deficient individuals, and that treatment with supplementation would lessen the sway. And sway is a predictor of falls. It's a balance test, obviously. So this brings me to what's new this year in the area of vitamin D and muscle performance. And it was just published, it's out online in JBMR by Bislev and colleagues, very fine investigators, looked at 54 randomized controlled trials. And these trials, some of them used daily, some bolus dosing, some were months in duration, others years, some with calcium, others without it. And they looked at a bunch of these muscle performance tests that were published in the individual trials. So I'm going to take you through the results of these tests rather quickly, because they all will drive home the same point. Here's the time up and go, impact, not significant. Supplementation, no impact. Knee flexion, commonly measured, similarly, no significant impact. The SPPB, the short performance, physical performance battery used in elders, and it was null. The trial level vitamin D and the chair rise tests, often done in a number of these trials, null. Overall, the 6-minute walk, which is an endurance, not a type 2 fiber sort of test, and it was null as well. Now, these labs concluded that that the statement, the commonly made statement that vitamin D protects muscle health, lacks clinical evidence, and adverse events may even be present. She also commented that despite enormous efforts in randomized trials, we have only good evidence that D combined with calcium plays a role in the prevention and treatment of osteoporosis. In other words, fracture prevention. An invited commentary to this very recent publication by Roger Bouillon and Dan Bickley, they agreed with these conclusions. So now let's move on to what the recent mega trials have added to the picture of whether vitamin D affects fall risks. Here's one you're familiar with, I'm sure, the VITAL study in over 25,000 older adults. They were not selected on the basis of their fall risk. They were replete in vitamin D at baseline, shown as here in orange, the 30.8 nanograms going to 41.6 on treatment with 2,000 units of D per day. So that increment did not influence fall risk at all in these participants, as you can see in the graph. There's been another rather complex study. It's with a so-called adaptive design, the STURDY study by Larry Appel, who's a fine investigator. They tested they had 4 arms in the original randomization. The plan was to treat with the control dose of 200, 1,000, 2,000, or 4,000 units a day in a randomized manner for 2 years, and then to pick the most promising dose at that point to go forward for 2 additional years to see if they could get a sustained or a benefit of that. And you see, we will look first at the adaptive phase, and the result is shown here. It turns out you see the 200 unit doses in the dashed line. 2,000 units actually significantly increased falls in that 2-year adaptive period. The 4,000 unit dose was similar to the 200, and the promising looking dose was 1,000 units a day. So what the investigators did was to transition those individuals in the 2,000 and 4,000 unit groups to 1,000 units a day. They kept the 200 unit group intact, but added more people to it, recruited some new people for the 200, and they carried on for 2 additional years, comparing in a larger sample size, the 200 versus 1,000 units. And here's the result of that confirmatory phase. You see the 200 and the 1,000 unit doses had the same amount of falling. In other words, the hazard ratio, while it was 0.94, the confidence intervals were wide and widely straddled 1. So they could not demonstrate effect. I should point out that this population was recruited because of their recent fall history. They were all over 70 years of age, and so they were a very high risk for falls population. Then we have just published a few weeks ago, the long-awaited D Health Australia study. 21,000 adults aged 60 to 84, selected out of the general population of elders, were randomized to 60,000 units of D3 per month versus placebo and followed for 4.3 years. This was a rather pragmatic trial. They didn't have visits and so forth. It's rather like the VITAL study. And in 16,000 of the participants, they were randomly selected for an annual survey of falls by a mail-out questionnaire. The study did not have visits, didn't have blood draws in everyone, but they did look at the intra-trial 25-hydroxy-D level in a small subset, but adequate, of 450 per group, and found that the placebo was at 31 nanograms. That's almost identical to the starting line of the VITAL study, and it's certainly in the replete category. And the 25-hydroxy-D level reached on supplementation 46 nanograms per mil. So here is the results. The upper red rectangle shows the main results in all 16,000 people, and it was not significant with an odds ratio of 1.02. Down below in the rectangle, you see body mass index. It turns out that the subset of people with a BMI less than 25 kilograms per meter square had more falls than those higher weight, higher BMI participants. There was also a hint that that the low D people would benefit from supplementation in the lower part of that rectangle, but it was not significant. So another null trial in people who were adequate at baseline. That result is quite similar. You know, the Australia D used 60,000 a month. That takes us back to the old Bischoff-Ferrari study of 2016, testing that same dose in group B compared with 24,000 units a month, which would translate roughly to 800 units per day. And she saw more falls in that 60,000 unit dose. However, her individuals, their average BMI was 26, so over about half of them approximately were under 25, presumably, and these were people at high risk for falling, selected because they had had a fall in the last year. So the 60,000 units, it does not look safe in high risk for fall elders. It may be okay in those who are not that size or at that level of risk, but I wouldn't bet on it. In the Bischoff-Ferrari trial, the 25-hydroxy-D levels were at baseline in the high teens nanograms per mil. The 800 unit equivalent dose in the lightest bars brought the levels up to about 38 or so nanograms per mil. And so we're looking at more falls at 38 than there were at 21 nanograms per mil. And of course, even higher levels were achieved in that third group. So there's one other classical fall study to try to relate these new trials to. This was done by Smith and Gallagher It's smaller, but it was carefully assessed falls, 146 Caucasian and 91 African-American women, and their recruitment eligibility or enrollment eligibility required that they be insufficient under 20 nanograms per mil. So they used multiple doses, but I'd like to focus your attention on the right-hand panel of the slide where we are looking at 25-hydroxy-D levels achieved on treatment and proportion of fallers. And you could see that in the dose range, in the 25-hydroxy-D range of 32 to 38 by one assay or 35 to 41 by the other, there were the lowest number of falls, and there were significantly more falls as 25-hydroxy-D levels rose above around 40, 41 nanograms per mil. So here's a summary of this confusing picture. We're trying to get at a couple things here. One is there a range of 25D that we should stay within to minimize falls? Or is the problem that we're using intermittent bolus doses versus daily doses? And it's really, I think I can't quite sort this out from what we have here, but here's a try. So the fall risk level increasing is represented by the yeses in the far right-hand column. The new studies are in orange. The classics we just looked at are in white. And you can see that you get more falls in high-risk elders in the Appel study at 2,000 and 4,000 units. D-health, you in a normal average risk population, you get more falls if your BMI is less than 25 on that dose shown 60,000 per month. Bischoff-Ferrari saw that that you got it in more falls in everyone if you're at high risk for falling and older with 60,000 a month. And Gallagher, as we've just reported, showed that levels above 41 are suspicious for more falls. So my takeaway is that you don't want older adults, whether they're at high risk for falls or not, exceeding a 25-hydroxy-D level of about 40. And you don't want them in the insufficient and deficient range either. So until we get a better handle on this, I would say the safe territory is the 20 to 40 nanogram per mil range as a treatment goal. That's just my opinion. It's not a guideline. We know from earlier trials that de-dosing in the lower dose ranges in response and showing risk of falls is summarized here in a 2009 meta-analysis. And it looks from this just visually as if you're in the 700 to 1,000 unit range, you're benefiting. And if you're lower than doses than that, you're not. At that time, there were no high dose trials to complete the picture on the right. Let's move now. I'm going to briefly address something that's been intriguing to me recently, and that is the possibility of a different pathway. We have looked at this classic pathway shown on the right, and we're not seeing the benefits of treatment with D on muscle outcomes and not consistently on falls. We do adhere to the left-hand axis, which fits with available evidence beautifully that you get decreased absorption, increased PTH, turnover, and fractures. I'm wondering whether PTH elevation in response to D insufficiency may be a direct, have a direct effect on muscle strength and therefore on falls. So let's look at a little bit of evidence that support this maybe wild hypothesis. And that is that in rats, stimulation with the intact PTH or the active 1 to 34 amino acid fragment increases muscle proteolysis in rats, and they've shown this proved it in several different ways. But so there is a rat precedent for this. There's also a paper, the senior author was Gerald Auerbach, the famous endocrinologist. This was in the mid-1970s. They had reported muscle findings in 16 patients with primary hyperparathyroidism. And these included, out of the 16, there were 13 that felt they had no stamina, 12 generalized muscle weakness, poor tests with proximal muscles, aching muscles, unsteady gait, and so forth. A subsequent study by a British surgeon looked at some actual knee extension measurements in patients with primary hyperpara before and then 7 months after successful parathyroid surgery. And there was a 8% improvement in their muscle strength at 7 months later. And the degree of change or improvement was correlated with the circulating calcium concentration prior to surgery. In other words, those with more severe hyperpara had a more robust recovery than those with milder, suggesting a direct effect. Then the Bislev earlier in 2019 did a cross-sectional study in 104 healthy older women, all of whom had low 25-hydroxy-D levels. She divided them into two equal groups. Well, they turned out to be equal. She divided them according to whether the circulating parathyroid hormone level was above normal or within the normal range. So in the picture here, you see the clinical characteristics of the two groups, the secondary hyperpara shown first, and then the normal PTH levels. And importantly, the 25-hydroxy-D level in the two groups was similar. So we're not looking at different degrees of D insufficiency. They were all insufficient, but equally so in the two groups. And of course, the parathyroid hormone levels were higher because that's how they were selected. Now let's look at what she measures then, and that is knee flexion, strength, and maximum force production at 90 and 60 degrees. And in these measures, those with secondary hyperpara, the higher PTH group, had poorer performance, as indicated by the bolded p-values in the final column there. So there was a muscle performance difference. And there was also more sway in the semi-tandem stance shown on the left in the higher PTH groups. So there was probably an effect on balance and as well as on muscle strength. And last, a lovely study by Phil Sandbrook, who was doing an observational study in over 600 ambulatory elders in intermediate care hostels and nursing homes in Australia. And he was assessing falls. And the setting is relevant here because staff in these institutions were actually documenting falls. We were not dependent upon men and women in their mid and late 80s to remember whether they'd had a fall or two falls or what. And so high quality, 73% had D level, 25 D levels below 15.6 nanograms per mil. So it was a D deficient group, right for us assessing the question here. And 274 of the elders, over a third of them, fell over this 10-month intervention or observation period. Here are his findings from a multivariate analysis. He looked at the association of 25-hydroxy-D with falls, and after adjusting for PTH, it was not significant. Similarly, he looked at PTH, and after adjusting for 25-hydroxy-D, which of course was similar in the two groups, found that it was the predictor, not 25-hydroxy-D. The model was also adjusted for other comorbidities and balance and so forth. So this is our strongest signal, actually, that PTH may be driving the bus here for falls, since we are finding that 25-hydroxy-D isn't making that much difference. This needs confirmation. It is unclear at this point whether this is real or not. So I want to now at the end give you just a few highlights of the primary endpoints of these mega trials that have been published recently. These are not musculoskeletal endpoints, but they're nonetheless important in relation to chronic diseases. Here's the vital study cancer outcome. You know the story of the over 25,000 people. The hazard ratio for incident cancer was 0.96 with a wide confidence interval. After taking out those who developed the cancers in year 1 or year 2 of this 5-year study, it was similarly null. There was a flicker of hope for the vitamin D intervention, and that was that cancer deaths, a secondary endpoint, were reduced with the vitamin D supplementation of 2,000 units a day. What about cardiovascular disease? That was the co-primary along with cancer in the vital study, going down on the left-hand column to the hazard ratio of 0.97, wide confidence interval overall, no impact on cardiovascular disease. And it's similarly no impact for those small subset who had insufficient D levels at entry into the vital study. Similarly, on the right-hand panel, we have the VITA study from New Zealand, hazard ratio 1.02 for cardiovascular disease or mortality, cardiovascular mortality, and 1.0 for those with an initial low D. So all the observation studies suggesting that higher D was protective were basically looking at people who not only were taking care of their vitamin D status, but other health needs at the same time that were not adjusted for. The Do Health study out of Switzerland involving 5 countries in Europe, testing 2,000 units a day, similar intervention to to the VITAL study. The people had a 22.4 nanogram starting level of 25-hydroxy-D. Look at the SPPB scores, 12 out of a possible of 12. I think they recruited a bunch of Swiss mountain climbers. These people were very fit elders. And the vitamin D outcomes, there were 6 primary outcomes, and none of vitamin D had no significant effect, had a significant effect on none of these outcomes. So disappointingly null. I'm going to wrap up with the looking at another outcome, which is type 2 diabetes. The D2D trial, which I have been heavily involved in, was testing 4,000 units per day of D3 versus placebo on conversion to diabetes based on American Diabetes Association criteria in a bunch of recruits who were classified as pre-diabetes, so high risk for conversion, people over 2,400 of them. And we found that vitamin D lowered risk by 12%, but it was not statistically significant. This result is very similar to that of the European study by Gorda, showing the same kind of range of decrease. Well, that's not nothing if it's true, but we can't tell. We wondered in looking at this whether the people who achieved a higher 25-hydroxy-D level may have benefited more than those who did not. And so we looked at this question in the D2D cohort. In the upper panel, we show the participants who had been assigned to the 4,000 units of D. We sorted them by the category of intra-trial mean levels of 25-hydroxy-D. We had measured at 0, 1 year, and 2 years. Took the mean in the trial and looked at outcomes having adjusted for age and sex and the usual cast of players. And you'll see highlighted in yellow there that those individuals treated with D who achieved a level of 100 to 124 nanograms per mil, that would be 40 plus nanograms per mil, these are nanomoles, sorry, and had a decreased risk of developing diabetes, 0.48. And if they got even higher, greater than 125 nanomoles, their risk dropped down to 0.29. And we adjusted again for any change in weight during the trial, and it didn't alter the result. If anything, made it a little better. The same trend is seen in the placebo group shown in the lower panel here. We had only 22 people in that group who achieved the high levels. So it was really hard to tell, but the same general flavor is present in the placebo group. So we are wondering and want to try to demonstrate that treating to a target level for diabetes to prevent diabetes in high-risk people may be beneficial. Of course, we'll have to demonstrate too whether it's safe, having looked at the falls data that we just reviewed. So this observation in D2D is consistent with the diabetes prevention program observation that the hazard ratio conversion in this observational study and in addition to the diet modification, the higher the D level shown on the x-axis, the lower the hazard ratio, even out at levels in the range in which we saw decreased conversion. So it's plausible, it fits with this other amounts of data, and it requires further investigation. I'd like to conclude with comments that supplementation of replete older adults, as we've seen in the recent mega trials, does not improve muscle performance or reduce fall risk. Supplementation to a level greater than 40 or equal to 40 nanograms appears to increase risk of falling in frail older adults and possibly in the general older population, although that is less firm. A low daily dose of 700 to 1,000 units together with adequate calcium intake reduces risk of falls and fractures in deficient older adults. An elevated PTH level may increase risk of falling independent of vitamin D, but more evidence is needed to confirm that. Vitamin D supplementation in replete adults not only doesn't improve musculoskeletal outcomes, it doesn't improve any others either, as far as we can see at this point. So the take home is the optimum 25D level to minimize diabetes risk may need to be higher than 40, but as I said, this requires verification and also assurance that treating to higher levels is safe in terms of risk of falling and other outcomes. So thank you very much for your attention.
We do thank Professor Miss Dawson Hughes for a wonderful talk that covers many of the advancement in knowledge regarding vitamin D that happened over the last year and many new studies that has been shown by her. We do not have the luxury of time to have questions. Middle presentation usually are finished without question. On the behalf of the Board of Directors of the Gulf Association of Endocrinology and Diabetes, I would like to present this middle presentation certificate to Professor Miss Dawson Hughes and thank her for sharing her expertise with us in this Congress. I do thank the 515 people who are with us attending this presentation, 519 now, and wish you a fruitful presentation and knowledge and academic achievement in the subsequent presentations of this Congress. Thank you very much.
Good evening, everybody. Thank you for involving us. We are now in the session, Adult Clinical Practice Symposium, Lipidology, and I'm happy to be with my colleague, Dr. Abdullah Al-Futaisi, who's we're gonna tackle this session today. Thank you for involving us, and we have 4 excellent lectures coming on. Dr. Abdullah.
Thank you, Dr. Walid, for your presentation. It's my pleasure and honor to introduce Dr. Ray Kosik. He's the president of European Atherosclerosis Society. He's the professor of public health and honorary consultant cardiologist. He's the director of Imperial Center for Cardiovascular Disease Prevention, deputy director of the Imperial Clinical Trial Unit, and he's of the Commercial Trial Imperial College of London. Please, the floor is yours, Dr. Ray. He's going to talk about heterozygous familial hypercholesterolemia, an update. Please go ahead. The floor is yours.
Well, thank you very much. It's a great pleasure to be here at the Gulf Association of Endocrinology and Diabetes and to be with you at least virtually in 2021. My name is Kosik Ray. I'm president of the European Atherosclerosis Society, and the title of my talk today is Familial Hypercholesterolemia from Screening to Treatment. These are a list of my disclosures that you can see here. By way of background, I just really want to remind you that familial hypercholesterolemia is a genetic condition. It's in fact the commonest monogenic disorder that is affecting mankind. It's autosomally codominant, and what it results in is lifelong elevations in LDL cholesterol from birth. So it's got nothing to do with diet and lifestyle, essentially the mechanisms by which you remove LDL cholesterol are defective. Now, the global prevalence of this was estimated at being between 1 in 200 to 1 in 300, but we now know based on systematic reviews and meta-analyses that we've done, published more recently in Circulation, that the global prevalence is 1 in 311. We also know that FH is widely underdiagnosed and undertreated. And we do know that diagnosis, particularly early, and treatment of familial hypercholesterolemia, treating cholesterol, is known to reduce the risk of cardiovascular consequences of familial hypercholesterolemia. And this is particularly important. We established about 5 to 6 years ago the Familial Hypercholesterolemia Studies Collaboration. I'm pleased to say that many of the Gulf countries have participated in this. And this paper was published in The Lancet with this global collaboration in 2021 to coincide with FH Awareness Day, FH Awareness Week, and also the World Heart Day. What do we find? Well, we've established a network of countries across the world representing all geographical regions, 66 countries. To date, we've received more than 66,000 individual participant data in individuals with familial hypercholesterolemia, either through a clinical or a genetic diagnosis. We have children, we also have homozygous FH. The first thing to say is that on the left-hand side, you can see the age of entry into the registry, but also the age of diagnosis. And I want to show you at the bottom, now, this is a condition that is prevalent from birth. We are only diagnosing about 1.5 to 2% of cases before the age of 18. And that is really very bad. That is too late to start making these diagnoses, because the average age at which we're diagnosing patients is somewhere between the age of 40 and 50. It's about 46 years is the median. So if the global average is 46 years, it means we've just missed 46 years of cholesterol exposure for the vast majority of our people with FH. What else are the consequences of this? Well, look at age of diagnosis and look at prevalence of hypertension, diabetes, for example. These all increase the older you are. So the older your age of diagnosis of FH, the more likely it is you're going to find additional risk factors. What do additional risk factors do? They increase the risk of cardiovascular disease. So getting diagnosis early, before the age of 20, is absolutely essential, because then we have more time to change exposure to LDL, but we also have an opportunity to reinforce behavior and diet and lifestyle. So we can avoid things like hypertension, diabetes. If you look, for example, at the distribution of obese and overweight individuals, that also increases with age, and there's geographical distributions. The second thing is, we often have healthcare systems that focus on the index case, and that's important because we often need to find that first person to be able to find those additional family members. But look at non-index cases. This means a patient presented, let's say, with an MI, that had a high cholesterol, I suspected FH, I screened the family. And then I found non-index cases of FH, meaning I found them through cascade testing. In non-index cases, the prevalence of coronary disease or premature coronary disease is much, much lower. So this shows you the importance of cascade testing, but it also starts to suggest to you that actually, maybe we should move away from cascade testing to universal screening of cholesterol, because if all I do is find people earlier, there's going to be less disease. So that's another important key finding. The next thing to consider is, what do I do when I find FH? Well, when you find FH, we are, as you would expect, treating people with statins. But remember, most people have an LDL receptor mutation. They have one defective gene, one normal gene. Therefore, it won't function as well as in other individuals in terms of response to treatment. So we need combination treatment. But look at the use of ezetimibe. Only 24% of people were using ezetimibe, for example. Look at the use of MABs. It was only, PCSK9 inhibitors were only used in 3% of individuals. And if you look at multi-drug combinations, it's actually really low. But what we find is, for goal attainment, for example, these are the proportion of people achieving goals. We should be achieving, if I miss a diagnosis of FH and I'm only diagnosing people at the age of 46 and I've missed 46 years, they will have more subclinical disease. So at that point, I have to treat them more aggressively. But look at how well we're doing with goal attainment. It's really very poor. Less than 3% get to below 1.8 millimoles or 70 mg per deciliter. I'm more likely to get to goal with 2 or 3 drug combinations. And the key treatments, really, combination therapy with statins and PCSK9 lowering therapies, because you're making more LDL receptors and you're keeping them alive longer. Now, is there any rationale for early screening? Well, yes, there is. This is Dutch data, the Luric paper from a few years ago. They followed up parents and children with familial hypercholesterolemia. The parents were identified because they had a myocardial infarction or coronary disease. So they're the index case. So even when you start statins, you're starting people with disease, medication. So many more of those will have recurrent events. But the children are event-free, and they're being started on treatment before the age of 20. So if you look, for example, at patients with FH and their unaffected siblings, there's 150 milligrams per deciliter difference in LDL cholesterol. As children grow up, naturally diet and other factors kick in, and their LDL cholesterol will go up from 98 to 121. But in the people with FH, we've brought LDL down from 230 to 160, and you can say that's not ideal. But what we've done is we've reduced their LDL by about 70 to 80 milligrams per deciliter, and we've importantly maintained it for a long period of time. So what that does is it reduces the likelihood of carotid intermediate thickness, for example. The people that were non-FH patients, of course, there's going to be some progression, but the difference is actually not as marked as you might imagine because you've started treatment early. And what that translates into in children with FH is basically we don't see much in the way of cardiovascular disease simply because of the fact that we've started treatment earlier. This is some work that we have in review, looking at people in general practice where they had a diagnosis of FH, they may have been unlikely to have FH, or the LDL is high and they could be potentially FH, but no one's made that diagnosis. Now, the important thing is that people with a diagnosis of FH will have recurrent events. But in terms of their survival, an early diagnosis means that their survival looks very similar to non-FH cases. Why? Because they're getting treatment, they're behaving with their lifestyle. In contrast, people who could have FH, but nobody's started to talk to them about it, they're carrying on with the same behavior, non-adherence to medication, all of those usual things, they lose 18 years of life. So really, this is conclusive evidence that we've got to start screening and identifying FH very early on in life. Now, we don't have many trial data and body count studies in FH. It's unethical. So what's the best data that we have? Well, we can go back and we can look at studies like WASCOPS, where there were a few people who had LDL above 190. So they had an FH type phenotype. Some of these people had other forms of vascular disease, and we excluded those individuals. And you can see this. There's 1,000 people had strokes or TIAs and so forth. That left 5,500 from 6,500. Just under 3,000 LDLs were less than 190, and then we had 2,500 with LDLs above 190. So let's call that primary severe hypercholesterolemia. This is the trial data of statins showing benefit, and on the right, placebo would be showing benefit. And what you basically see is that both the lower and the higher LDL groups benefit similarly, even with a modest reduction with pravastatin at a dose of 40 milligrams. This is coronary disease, this is major atherosclerosis events, 27, 25% relative risk reduction over 5 years. Now, in WASCOPS, there was a 15-year open label extension. So we can test the effect of further and earlier LDL lowering for longer and see what the effect is. Now, if those randomized patients continue onto their treatment, and even if placebo are offered medication, what you basically can see is that those people that you start treatment on early, when you add another 15 years of exposure to beneficial treatments, now you start to see mortality benefits, 28% reduction in CHD death. You now see 25% reduction in CV death, and you now see 18% reduction in all-cause mortality. So this piece of data was heralded in both the European guidelines and in the ACCHA guidelines as closing the remaining evidence gap. And this has really changed the level of recommendation. So if you see a patient with an LDL above 190, yes, of course, investigate them for FH, but you should offer them treatment irrespective of whether you're going to add in lifestyle or not. That means drugs. Now, is it possible that those people with more advanced disease do better with statin or cholesterol lowering therapy? Well, to investigate that, we did exactly the same type of analysis in the 4S trial. So a randomized trial of statins versus placebo. The whole population had coronary artery disease, but we broke the population down into those with LDLs above and below 4.9. And then we could separate the coronary disease patient population down into 4 groups. So the numbers get smaller as you do this. So what were we looking at? Well, everybody's got coronary disease, and we've got 2,000 patients with an LDL above 4.9. Some, that coronary disease was late, and there's no family history. So that's one group. Then there's a group with a family history, but their own disease is not premature. And then there are some people with premature disease, but no family history. And there's a small number with premature coronary disease themselves and with a positive family history. And remember, they've got an LDL above 4.9. So they've got 3 things that by Dutch Lipid Network criteria would suggest that they are likely to be an FH patient. These are the relative benefits for all-cause death, cardiovascular death, coronary disease death, and major coronary events, just by LDL levels above and below 4.9. So the people with higher LDL levels seem to get slightly more benefits in relative terms, and that may be related to the fact that, as you know, if your LDL level is higher, the absolute benefit, or the relative benefit rather, depends upon the absolute reduction in LDL. So if you start with a higher LDL, you'll get a bigger absolute reduction in LDL, and therefore you might expect slightly greater benefits. And that's what's suggested here using CTT. But if you now break patients down by FH phenotype, so here we have non-FH, then we have LDL above 4.9 only, above 4.9 with a family history only, above 4.9 and premature disease only, or what we call the FH phenotype. Now, for the same, because these are people getting the same amount of LDL reduction, but there's a group of people with the FH phenotype getting really quite marked 80% or so reductions in all-cause mortality and also in major coronary events. So that's telling you perhaps that if we identify the right patients, their main driver or vulnerability to LDL, if you change that course, you might have a bigger treatment effect. And these are absolute benefits. So the group of patients with the FH phenotype get much bigger absolute reductions in clinical events. So that's just statins alone. Can we do better? Well, in the future, we will not be relying on monotherapy. We'll be looking at combination therapies. Statins, as you know, help us make more LDL receptors, but these are destroyed by PCSK9 lowering, by PCSK9. So targeting PCSK9 lowering therapies with the monoclonal antibody or reducing synthesis of PCSK9 in the liver through an siRNA-based approach can give you essentially about an 80% or so reduction in LDL with combination therapy, because each one gives you about 50%. You start with 50%, an additional 50% is a total of about 75 to 80% lowering of LDL. And in this meta-analysis comparing different PCSK9 lowering therapies, what we were able to show is that irrespective of genotype, siRNAs and monoclonals had very similar effects on LDL reduction. Now, if they have similar effects, if PCSK9 lowering, irrespective of how you do it, has a similar effect on LDL lowering, we can combine the data and ask a second question. Does PCSK9 lowering depend upon genotype? And the answer is no, it doesn't, because all of the genotypes behave similarly within the limits of the numbers that we had. So this means that you can choose different treatments that suit availability, cost, patient preference. So starting with screening and finding people earlier. Remember, we've only found 5% of the global population. We need to start them on statins and certainly ezetimibe, but we will be able to add in PCSK9 lowering therapies, whichever one you want that you can afford, that the patient chooses, but we can get significant reductions in LDL and we can normalize their exposure and risk. So in conclusion, this compelling data that identifying elevated LDL cholesterol early in life and cases of FH can have health benefits. Late diagnosis is associated with worse outcomes. Late diagnosis is also associated with cardiovascular risk factors and comorbidities. So it's not rocket science. We need to find FH before the age of 20, because then we can normalize everything. You're going to need combination therapy. And you have to start thinking about combination therapy at the outset. So when you see these patients, if available, start with at least statins and ezetimibe and look to add in a PCSK9 lowering therapy early. So you just need to go on and do it, is the take-home message. Thank you for listening.
Thank you, Prof, for your quick and very meticulous update in the approach for heterozygous FH. We're going to move on with next. Al-Wali, Dr. Khalid Al-Wali is known in the region for his specialization in the lipidology. He's a senior consultant, a medical biochemist and lipidologist, head of clinical biochemistry department in lipid unit, Sultan Qaboos University Hospital. And also he's vice president of Oman Society for Lipids and Atherosclerosis. They have a long history in the training and studying basics in biochemistry and lipidology. Started from Oman in his basic medical degree, then in Miguel University, where he worked between 2004 and 2009. He worked with Professor Jacobs Jensis, one of the biggest lipidologists in the world. He's get his degree in biochemistry and lipidology from Canada, and then he moved on to have the lipidologist board from United States. So Dr. Khalid, he's one of the best people to talk to us about hypertriglyceridemia, which is one of the very common problems in our area. Dr. Khalid.
Good evening, everybody. Thank you very much for the kind introduction. And I would like really to thank the organizing committee for the kind invitation. It's really an honor, and it's my pleasure to be part of this event. My talk today will be about the hypertriglyceridemia, its association with the atherosclerotic cardiovascular disease, and I will talk about the new approaches in management and treatment of hypertriglyceridemia. These are my disclosures. So when we talk about atherosclerotic cardiovascular disease, it is very well known that reducing the LDL cholesterol by statins would significantly reduce the cardiovascular risk. However, it has been seen in many trials that even in patients treated with statin, there is still a substantial residual risk remains. In many studies has been also seen that even with a high dose statin, in one of the meta-analysis of many randomized controlled trials of statin, it revealed that the risk of major cardiovascular disease are still unaddressed. And also when we talk about the triglyceride and the non-HDL cholesterol, it has been seen in many trials that sometimes we can reach the LDL cholesterol goal, but we don't reach the non-HDL cholesterol. And in this meta-analysis that examined 8 trials of statins, they have seen that in patients reaching the LDL cholesterol, there is still with those a high proportion of patients, they don't reach the non-HDL cholesterol. And those who do not reach the non-HDL cholesterol, there is a very high significant cardiovascular risk. And in this meta-analysis, if you see from the graph, the last 2 rows, you see those patients with LDL target less than 100 milligram per deciliter, but still they have a higher non-HDL cholesterol. They have a high risk 1.32 compared to the reference population, those who have lower than 130 milligram per deciliter. So they have seen that among statin treated patients, the on-treatment levels of LDL cholesterol, non-HDL cholesterol, and ApoB were each associated with a risk of future cardiovascular events. However, they found that the strength of this association was greater for non-HDL than for LDL cholesterol and ApoB. And then in another study where they have assessed the proportion of individuals with diabetes and cardiovascular disease to see those who would attain the non-HDL cholesterol target less than 2.6, they have found that non-HDL cholesterol goal attainment is really less in people with diabetes and cardiovascular disease. And this is attributed due to the high triglyceride and high triglyceride-rich lipoproteins, which carries a remnant cholesterol. Then the question for many years, are triglycerides associated with cardiovascular disease? And if it is really associated, is it independent or really dependent risk factor? And is it only an association or is it really a causality and a causal factor? And then I've shown you earlier that in patients with diabetes and cardiovascular disease, the higher the triglyceride, the higher the risk. However, in this meta-analysis of 61 studies, the median follow-up was 12 years, and they have excluded the studies in patients with cancer, diabetes, cardiovascular disease. And again, they have found that the higher the triglyceride level, the higher the cardiovascular disease mortality and also the all-cause mortality. And if we look into more details, what is triglyceride and what is triglyceride-rich lipoprotein? So these triglycerides are carried by what is called triglyceride-rich lipoproteins, the VLDL, VLDL remnants, and chylomicron remnants. And they also carries not only the triglyceride, they carry what is called remnant cholesterol or triglyceride-rich lipoprotein cholesterol. And if you see from this graph, the higher the triglyceride level, the higher the remnant cholesterol. And how can we measure the remnant cholesterol? So we take the total cholesterol, we subtract from it the HDL, that would be the non-HDL cholesterol, and then we subtract further the LDL cholesterol, and that will give us the remnant cholesterol, or what we call the triglyceride-rich lipoprotein cholesterol. And we have evidence from Copenhagen heart study that remnant cholesterol is strongly associated with the risk of myocardial infarction, the same way as with the LDL cholesterol, if not even more than the LDL cholesterol. But surprisingly, from that study, from the Copenhagen heart study, which examined almost 83,000 individuals, they found also that the remnant cholesterol is also strongly associated with all-cause mortality more than the LDL cholesterol, as you can see from this graph. Another study was published last year where they have looked for triglyceride-rich lipoprotein cholesterol, small dense lipoprotein cholesterol, and incident cardiovascular disease. And if you see from the graph, they found that triglyceride-rich lipoprotein cholesterol, the same as for small dense LDL cholesterol associated with myocardial infarction and cardiovascular events. However, they found that the triglyceride-rich cholesterol associated strongly with even peripheral artery disease more than the small dense lipoprotein cholesterol. So these remnant cholesterol, triglyceride-rich lipoprotein cholesterol associated with cardiovascular disease, associated with cardiovascular disease mortality, all-cause mortality, and peripheral artery disease events. For many years, the focus was on LDL, and after the LDL trials, they started to concentrate on HDL, and they were trying to see, will the increment in HDL cholesterol would result in a reduction of cardiovascular events? Unfortunately, from these many trials, they were all negative trials, and we failed really to see that increment in HDL cholesterol by pharmacological agents would result in a decrease in cardiovascular events. And then the question raised in 2015 by Peter Levy, should we swap the CISO, I mean the triglyceride on the CISO, because I mean, should we really now concentrate more in triglyceride-rich lipoprotein more than HDL? And should we focus on triglyceride-rich lipoprotein cholesterol as a treatment target for cardiovascular risk reduction? It was also seen very clearly from the article published by Chapman and colleagues that triglyceride, HDL, and non-HDL cholesterol are associated with cardiovascular disease. However, when the triglyceride was further adjusted for several risk factors for HDL and non-HDL, you would see the attenuation on the risk for cardiovascular disease. And now the questions raised by many researchers, if you really adjust a triglyceride for non-HDL, are we adjusting the risk factor for itself? And that's why we would see the attenuation of the risk estimate. Because you can see if you adjust for non-HDL, and non-HDL would capture really the LDL, and also it captured the triglyceride-rich lipoprotein cholesterol. So if we adjust the triglyceride for non-HDL, maybe we are really adjusting the risk factor for itself, and that's why we will see attenuation of the risk. Now also we have seen from many recent genetic studies that support causality of triglyceride-rich lipoproteins in cardiovascular disease. And if you see that many they studied the lipoprotein lipase, mutations in lipoprotein lipase, mutation on those what we call them the inhibitors and activators of lipoprotein lipase. And on those studies, they have found that if you really suppress the lipoprotein lipase activity by a mutation in lipoprotein lipase or one of its inhibitor or activator, that would result in a higher triglyceride-rich lipoprotein. And those genetic studies, they found that it is really associated with cardiovascular disease. So if we look into the lipoprotein lipase, it is really the one that's responsible to digest and to remove the triglyceride from triglyceride-rich lipoprotein and transfer it into IDL and LDL, those to be catabolized and internalized by the liver. However, we have inhibitors and activators of this lipoprotein lipase, and any mutation that is a gain of function mutation of those inhibitors on the right side, that would result in a lower activity of lipoprotein lipase, and that would result in a high triglyceride-rich lipoprotein and a high risk. On the other hand, on the left side, apolipoprotein 5 is an activator of lipoprotein lipase, and any gain of function mutation that would result in a higher activity of lipoprotein lipase and a lower level of triglyceride-rich lipoprotein and a lower cardiovascular risk. In this study, actually, it was, very clear that in those genetic studies, if you see number B, the remnant cholesterol, so those genetic mutation that would lead to an increase by 1 millimole of this remnant cholesterol, then that would result in a higher risk of cardiovascular disease. And in another interesting publication in 2019 by Brian Ferrance, they showed clearly that there is an association of triglyceride lowering LDL variants and LDL cholesterol lowering LDL receptor variants with the risk of coronary heart disease. And they have shown clearly that those variants with a higher activity of LDL receptor or with a higher activity of lipoprotein lipase would result in a lower risk for cardiovascular disease. But more interestingly, what they found that a reduction in the number of particles by measuring the ApoB, whether it was a triglyceride-rich lipoprotein particles or the LDL particles, if you reduce these particles by the same amount measured by the unit difference in ApoB, that would result in the same reduction of cardiovascular disease. And this study is also highlighting that the reduction of triglyceride-rich lipoprotein is really as important, if not more, than the LDL particles. Another interesting finding from the Copenhagen Heart Study, where they found that triglyceride-rich lipoproteins promotes inflammation much more than does the LDL particles. They measured the C-reactive protein, and they found that the C-reactive protein higher with a higher level of triglyceride. The same for LDL, it's high with LDL, but if you see the graph for the LDL particles, it really plateaus at certain level. So triglyceride-rich lipoprotein particles, they promote inflammation much more than does the LDL cholesterol. Another interesting study on the same area was published this year in the triglyceride and residual atherosclerotic risk, where they have found that in individuals with low to moderate cardiovascular risk, that hypertriglyceridemia associate with subclinical atherosclerosis and vascular inflammation, even in participants with normal LDL cholesterol. And this was the PISA study. That's the progression of early subclinical atherosclerosis. So they studied 3,754 individuals between the age 40 and 53 without prior cardiovascular disease, with low to intermediate cardiovascular risk. And they have found that the higher the triglyceride level, the higher the subclinical atherosclerosis. So what they have done, they have measured the index of inflammation by the fluorodeoxyglucose, the FDG, in multiple arterial zone. And what they found on those people with high triglyceride level, they have high inflammation index. So we have from this study, from PISA study, and from the Copenhagen study, now we have evidence that triglyceride-rich lipoproteins also promotes inflammation, and the higher the triglyceride, the higher the earlier subclinical atherosclerosis and inflammation. And now it's really very clear, it is not only the LDL particles, but also the triglyceride-rich lipoprotein particles that promotes the formation of foam cells and increase the level of inflammation at the arterial side, and through the leukocyte recruitment and increasing the inflammatory markers. Now, when we talk about the treatment of hypertriglyceridemia, for many years, we have now the most three important treatment for triglyceride, whether it was mixed dyslipidemia or isolated hypertriglyceridemia. So we have statins, omega-3, and fibrates. These are the three most commonly used. Sometimes also niacins can be used. So statins, yes, they are used to reduce the LDL cholesterol, but also they can reduce the triglyceride by 10 to 40%, and this is by reduction of the cholesterol and the triglyceride-rich lipoprotein particles. However, omega-3 and fibrates are more stronger in terms of triglyceride reduction, and they can reduce the triglyceride by 20 to 40 and sometimes 50% reduction. Now, the most important question, this reduction of triglyceride, will it be translated into a reduction of cardiovascular events? For LDL cholesterol, if you reduce LDL cholesterol in statin trials, in ezetimibe, PCSK9 inhibitors, yes, that would be translated in a reduction in cardiovascular events. What about triglyceride? So if you see the fibrates study, many fibrate study has been done. And when you look at the entire cohort, then you will not see any significant or statistically significant relative risk reduction. However, in some subgroup analysis and pre-specified also group analysis in the field and ACCORD trial, they have found if you concentrate in population with high triglyceride and low HDL, then there is a statistically significant relative risk reduction in cardiovascular disease. And now fibrates are also really used after statin for treatment of hypertriglyceridemia. Yes, there are some side effects and some interactions with the statins. And now we have another new, more selective PPAR alpha modulator, that is the bimafibrate. It's very efficient in reducing the triglyceride, and it has really lower side effects, lower interaction with the statins. However, till now, we don't have a study to tell us, is this reduction in triglyceride and non-HDL by bezafibrate will be translated into a reduction of cardiovascular events. So we are waiting for the prominent study, and we are expecting that the results will be ready by mid of next year, 2022. And we hope that it will be a positive trial and that we would see a reduction in cardiovascular events. And for bezafibrate, the type of population they are studying is really patients with diabetics and with diabetic dyslipidemia. So this is really the target group that we think they would benefit more from bezafibrate. What about omega-3? So many studies has been done on omega-3 previously with a lower dose, but the recent 2 studies, they used a high dose of omega-3. They used 4 grams per day. The strength trial, they used a combination of EPA and DHA, and reduced, they used only EPA. The strength trial, unfortunately, it really failed to show a positive results in terms of cardiovascular events reduction, and it was terminated. However, in reduced trial, they used only EPA, and it was really a positive trial, and they found that there is a reduction in triglyceride and increment of HDL, a reduction in non-HDL cholesterol, and that was translated in almost 25% relative risk reduction in cardiovascular events. So it was really a positive study. Now I'll talk about the treatment or the highlight of treatment of triglyceride. I will not actually talk in details about the guidelines, because I know the next talk will be about the guidelines, but I would really highlight the triglyceride treatment in the recent guidelines. So if you see in 2019, the European Society of Cardiology and the European Atherosclerotic Society guidelines, they now introduced a new risk category. They call it very high risk category. And then the level, the target for LDL was 1.4 millimole per liter. And in their guidelines, they highlighted the importance for non-HDL ApoB and triglyceride. For non-HDL cholesterol, they also mentioned that it should be a secondary goal. And then they have set the target to be 0.8 millimole per liter or 30 milligram per deciliter above the target for LDL cholesterol. They also highlighted the importance of ApoB as a secondary goal if it can be measured in your institution. For triglyceride, they highlighted the importance of triglyceride, but they did not specify a treatment goal. But they mentioned the level of 1.7 to indicate a lower risk, and if it is more than 1.7, then it indicates a high risk, and we need to look for other risk factors. They also have written a clear recommendation for drug treatment for patients with hypertriglyceridemia, and they have stressed the point that in patients with high cardiovascular risk, you should start with the statin, optimize the statin, and then if triglyceride high, then you can start the purified or the EPA, that's the IBE, omega-3, 2 grams twice a day, that's total of 4 grams. But also they mentioned for primary prevention that fenofibrate or bezafibrate that can also be considered in combination with the statin in those primary patients who meet the LDL cholesterol goal but still have high triglyceride level above 2.3. The American Heart Association 2019 also, they have concluded that prescription of omega-3 at a dose of 4 grams per day are an effective and safe option for reducing the triglyceride as monotherapy or as an adjunct to other lipid-lowering agents. Another excellent and very well-written guidelines that was published last year, where they talked more in detail about the triglyceride. It was the American Association of Clinical Endocrinologists and the American College of Endocrinology. And their algorithm, now we started to see that they put the 4 targets really together. And this is the first time we see that the targets not only for LDL and non-HDL and ApoB, but also for triglycerides. So if you see, there is now a target in their guidelines for the triglyceride. The same as for European Society of Cardiology and European of Atherosclerotic Society, they put the target for non-HDL to be 30 milligram per deciliter above the target for LDL, and for ApoB the same. But now in these guidelines, they've mentioned that the triglyceride target should be really less than 150 milligram per deciliter. And in their algorithm, they highlighted actually also the role of IBE, and they stated clearly that on those patients with hypertriglyceridemia, if they have a cardiovascular disease or diabetes mellitus, we should start with a statin, optimize and intensify the statin, and then if triglyceride is still high, then you give IBE 2 gram twice a day. That's a total of 4 gram. And for severe hypertriglyceridemia, also they highlighted the importance of starting diet, statins, and fibrate from the beginning, and also to combine with omega-3 if these are not successful to bring the LDL to bring the target within the recommended level. Again, another new update this year, it was from the American College of Cardiology, and then their consensus decision pathway on the management of atherosclerotic cardiovascular disease risk reduction in patients with persistent hypertriglyceridemia. For patients with persistent fasting hypertriglyceridemia, they categorize the patient into 4 categories. Category number 1, those with atherosclerotic cardiovascular disease. So this is for secondary prevention. And category 2, those with diabetes but without cardiovascular disease. Category 2, those adults without cardiovascular disease and without diabetes. And the 3 category with triglyceride more than 50 but less than 500. And then the 4th category for severely elevated triglyceride and risk of acute pancreatitis. And again, the same for European guidelines and for the American Association of Clinical Endocrinology. They highlighted also the importance of ruling out secondary causes, optimizing diet and lifestyle, and bringing the LDL cholesterol within the target. And then if the triglyceride is still high, then also they recommend the same as the other guidelines to start with and to consider the IBE. The same also for the diabetes mellitus, to start with the IBE. But for those patients with a severely elevated hypertriglyceridemia, then you start from the beginning, the diet, statin, fibrates, and also combination with omega-3 if really needed. So to conclude my talk, now we really see that there is now the evidence are accumulating that triglycerides and triglyceride-rich lipoproteins are causally involved in the pathogenesis of atherosclerotic cardiovascular disease, and conditions associated with high triglyceride level have high atherogenic risk. And this is related to the fact they also have a high concentration of atherogenic cholesterol, that's the remnant cholesterol, and also high ApoB particles. Now, we highly recommend that non-HDL cholesterol, ApoB, and triglyceride should be really considered as a treatment goals for those patients with persistently elevated triglyceride. And we have seen that fibrates and fish oils appears really to have cardiovascular benefits in patients with high triglyceride and low HDL. However, we believe really the ongoing trials will better define the optimal therapy beyond statin for patients with high triglyceride and low HDL cholesterol. That's the end of my talk, and thank you very much for listening to my presentation.
Thank you, Dr. Khaled, for your quick summary and update on hypertriglyceridemia. We're going to move on to the next session. We're happy to have Dr. Nasreen Sayed from Bahrain. She's going to talk to us about update on recent dyslipidemia. Dr. Nasreen is very well known to us in the Gulf. She's consultant endocrinologist and lipidologist, Gulf Medical and Diabetes Center, president of the new Gulf Association of Clinical Endocrinology and Diabetes, and she had been graduated from the Arabian Gulf University College of Medicine. She had training in internal medicine in Sinai Grace Hospital, Wayne State University, Detroit, Michigan, in the United States, fellowship in training in endocrinology and diabetes in the Cleveland Clinic Foundation in Ohio. She had American board certified in clinical lipidology and fellow in American College of Physicians and fellow of the American College of Endocrinology. Dr. Nasreen will talk to us about the update in recent diabetes guidelines.
Thank you very much, Dr. Walid, for this kind introduction. Good evening, everyone. It's a pleasure to be with you. So I think I would like to thank the previous speakers, Professor Ray and Dr. Khalid Al-Waili, for their excellent talks. Some of the slides, for those of you who have attended Dr. Khalid Al-Waili's presentation, is going to be probably some of them repeated here. So this is going to be on update on recent dyslipidemia guidelines with great emphasis on the clinical implications. And these are my disclosures for the talk. So just an outline on what we're going to be talking about today. So first, we're going to start with the link of the LDL cholesterol and cardiovascular risk. I'm sure Professor Ray and Dr. Khalid covered that very well. A quick glance at the latest lipid guidelines, and then followed by a more sort of a depth look at the 2019 ESC guidelines, and finally, the clinical implications of the latest guidelines. So, you know, most of the studies, whether animal studies, lab investigations, genetic studies, or even RCTs, showed a clear link between LDL cholesterol as a risk factor for CHD. But like Dr. Khalid Al-Waili presented elegantly, non-HDL is equally important and is being the center of attention in most of the guidelines, of the recent guidelines. Non-HDL actually represent the cholesterol content of all ApoB-containing lipoproteins. So we're talking about the chylomicron, remnants, and the VLDL, IDL, and the large biunit LDL, including the LDL cholesterol particles. And the importance of the non-HDL is actually when you have triglyceride levels of 200 milligrams and above. And this is typically what we see in the region with metabolic dyslipidemia or diabetic dyslipidemia, where you have high triglyceride levels, low HDL, and normal or high LDL cholesterol level. We tend to neglect and calculate the non-HDL. It's a very simple calculation. You just need to subtract the HDL cholesterol from the total cholesterol, and you get the non-HDL cholesterol. That's very important to detect all these residual risks apart from the knowing your LDL cholesterol. Now, going back to the clinical trials that we have, we know that statins are the primary sort of lipid-lowering agent and the first-line lipid-lowering agents used in most of the clinical trials and endorsed by guidelines. And we know that there is a linear relationship with the lowering of LDL and reduced cardiovascular outcomes, mostly in statin trials. And this was seen in primary as well as secondary prevention trials. As you can see that the lower you achieve the LDL, the better you get the outcome. And some of these trials were actually not pure statin trials. They were in combination with ezetimibe, such as the IMPROVE trial. All of them showed that lower is the better, with better evidence of outcome. Now, looking at all these statin trials, whether primary or secondary prevention, you can see across these different statin trials that the benefit that you're achieving in terms of cardiovascular risk reduction, it ranges between 13% to 37%, meaning that there is still a 60 to 80% residual risk. So it seems that we're not doing a good job according to the previous trials. And the theory behind that, and with some evidence that we have, this could be that we are not tackling other residual risks like the non-HDL, the triglyceride, like Dr. Walid, Dr. Khalid showed us just shortly. And also maybe the LDL levels that we were achieving in these trials were not low enough for us. And that really brings us to the looking at how important it is to go with a very low LDL level, and is it safe? And if we look at the different Mendelian randomization studies or the prospective cohort studies, randomized controlled trials, all of them showed that when you achieve really low levels of LDL cholesterol, it's not just the amount of the LDL cholesterol, it's also the magnitude of exposure to lower LDL cholesterol, you will have the lowest possibility or probability of cardiovascular event. And added to that, as presented in the 2019 European guidelines, they showed you that all these CTT meta-analysis of the statins, the IMPROVE trial, also the PCSK9 inhibitor trials, such as 4-year Odyssey, showing the evidence for the evolocumab and alirocumab, all of them showed that the lower we go with the LDL, the better is the cardiovascular outcome. And going below even 30 milligrams per deciliter was pretty much very safe in these trials. So looking at a quick glance at the guidelines and recommendations that we have the ACC-AHA. Now, ACC-AHA went through different sort of stages of modification of their guidelines since the release in 2013 and dividing the group of patients into 4 groups. There have been some adjustments to the guidelines, even the recent ones back in 2019 and 2020. Basically, they're sticking to the 4 groups, the clinical atherosclerotic cardiovascular disease. The second group is primarily FH patients. The third group, diabetic patients. And the fourth group are patients with high calculated risk, which is 7.5% and above. Now, very important that the ACC primarily focus on intensity of statin therapy and the LDL reduction, percent reduction, while as you can see the European guidelines and the National Lipid Association guidelines, they have sort of different sort of categorization of risk, ranging from very high to high, moderate and low risk. And these guidelines actually look at the target LDL cholesterol levels and absolute values. And you can see that the target sets for the LDL cholesterol is it's very stringent now, according to the latest guidelines. For the very high risk is below 55 milligrams, and according to the NLA still at the below 70 milligrams. And all these trials look at statins as the first line therapy, and commonly, usually the second line agent to be added is ezetimibe. Showing the ACE guidelines, the American Association of Clinical Endocrinology guidelines, like Dr. Khalid just showed you, the categorization of the risk is a bit different. So they are looking at extreme risk, very high risk, high and moderate and low risk. So the extreme risk patients are those with progressive atherosclerotic cardiovascular disease, even after achieving LDL below 70, and those with established cardiovascular disease, but in patients with high risk, like for example, diabetes, CKD, or FH. And also patients with history of premature atherosclerotic cardiovascular disease at young age, like below 55 in males and below 65 in females. Like Dr. Khalid presented elegantly, the targets set here is not just looking at LDL, but equally looking at the non-HDL, and the ApoB lipoproteins. Again, very strict targets here, below 55 for the LDL, below 80 for the non-HDL, for the extreme risk category. Now, looking at the ACC-AHA, going through the phases of modification, there is a great emphasis and more detailed sort of elaboration in the recent updated guidelines. So in addition to their well-known category of the clinical evidence of atherosclerotic cardiovascular disease, they emphasize on another category, which is a very high-risk atherosclerotic cardiovascular disease. And these are patients who come with multiple major events, or one major cardiovascular event, or who have multiple risk conditions. So what are these multiple risk conditions? Age above 65, FH patients, prior CABG or PCI, diabetes is considered among these risks, hypertension, CKD, current smoking, and persistent high LDL despite lipid-lowering therapy, and finally, history of congestive heart failure. For these patients, they have set a threshold of LDL 70. So if your patient is at LDL 70 or above, you need to be really aggressive and consider maximum tolerated statin in these patients, and very much consider non-statin therapy in these patients. So ACC was not previously looking at non-statin therapy in their initial 2013, but now there's a great emphasis on non-statin therapy, including ezetimibe and PCSK9 inhibitors. Now, looking at the other general guidelines, so one of them is the guidelines or the consensus clinical recommendation that we have published for the lipid guidelines in the Middle East pertaining to the Gulf region and Middle East. This was published back in 2015, and we are publishing another one coming soon, hopefully by end of this year. Again, very important for you to understand the guidelines or the recommendations pertaining to our region. So, of course, we can invite you to look at all these guidelines and other guidelines at our website, the GAED.info clinical guidelines. You can see all the guidelines related to lipids or other guidelines, so you can have them for the review. But there is one upcoming updated guideline very soon, end of this year. So looking into more depth on into the 2019 European guideline that sort of form a platform for the updates that we are getting in other guidelines like the ACC and so on. So again, this is a popular slide that most of you have seen. We are categorizing the risks into very high risk, and these very high risk, remember, these are patients with established cardiovascular disease, FH patients with cardiovascular disease or other major risk factor, severe CKD, diabetes and target organ damage, or diabetes with more than 3 major risk factors, or early onset of type 1 diabetes. And remember, the risk score used in the European guidelines was the score risk calculator. So more than 10% was considered very high risk. In these patients, the target LDL is now below 1.4 millimole or below 55. While the high risk category is a score risk above 5% or below 10%, also markedly elevated single risk factors, or FH patient without major risk factor or moderate CKD, so GFR between 30 to 59, diabetes without target organ damage, or diabetes duration more than 10 years with other additional risk factors. So these are high risk, and the target is below 1.8 or 70 milligrams per deciliter. While the moderate risk factor is a score between above 1% and below 5%, and young patients like type 1 diabetes below 35 years or type 2 diabetes below 50 years, or with a diabetes duration less than 10 years without other risk factors. For these patients, you need to achieve LDL target below 2.6 millimole or below 100 milligrams. And the low risk is, of course, LDL cholesterol below 3 millimoles per liter. In addition to that, a very important recommendation by the European guideline is that for patients with evidence of atherosclerotic cardiovascular disease who experience a second vascular event within 2 years, the LDL goal should be as low as below 1 millimole or below 40 milligram per deciliter. So this was another addition very important to the guidelines. So how you should be going through the decision making and choosing your lipid lowering therapy, and most of the guidelines agree with that now, and giving a great consideration for combination therapy. So you need to know your baseline LDL to start with, and then you need to know which each class of lipid lowering in terms of percent reduction that you can achieve. So look at the moderate intensity statin that unfortunately most of us are using in the clinical practice. It just gives you 30% reduction, while the high intensity statin gives you 50% reduction. And when you have a combination of high intensity statin plus ezetimibe, you achieve 65% reduction. PCSK9 alone gives you 60%, but if you combine PCSK9 with moderate intensity statin, you achieve 75% reduction. And if you have the three of them together, you achieve 85% reduction from the baseline LDL. So that absolute LDL reduction that you achieve and you reach to that relative risk reduction along with the baseline risk, you will reach to your absolute risk reduction in your patient. So the guideline recommends that you need to categorize your patient. The first thing you should tell yourself, is my patient in the very high risk, or moderate or low risk category? And based on that, you would decide whether there is indication for drug therapy or not. And after that, if there is indication for drug therapy, of course, don't forget lifestyle intervention, very important. But the first line is high intensity statin or maximum tolerated statin based on your baseline LDL cholesterol. So, and if you achieve the LDL goal, that's great. If not, the guidelines recommend adding ezetimibe. If you achieve your goal, that's great. If not, then the guidelines recommending adding PCSK9 inhibitor. Now, there is a great evidence for PCSK9 inhibitor in secondary prevention for very high-risk patients and also as primary prevention in FH patients. But the guidelines are telling you, you can consider PCSK9 inhibitor in primary prevention in those without FH, like diabetes, CKD, and so on. And very important also, the guidelines emphasize you can consider PCSK9 inhibitor class if you have statin intolerance. So if you have statin intolerance after a re-challenge, you can consider ezetimibe. And if still not tolerated, you can consider PCSK9 inhibitor. And that was mentioned in the guidelines. What about type 1 diabetes? Statins are indicated in type 1 older than 30 years or have had diabetes for more than 10 to 20 years or have established nephropathy or have other CVD risk factors. Elevated triglyceride, I'm just going to go through this quickly because Dr. Khalid Al-Waili presented that. The cutoff, the threshold at which you should consider is the triglyceride 2.3 millimoles or above 200 milligrams. You should be considering medication. Omega-3, which is the icosapent ethyl at a dosage of 4 grams per day. So this is very important. We're talking about not over-the-counter omega-3. The study looked at specifically APA that showed the positive cardiovascular outcome evidence. As Dr. Khalid Al-Waili showed, the primary endpoint, a reduced trial for the icosapent was 25% relative risk reduction, 58% were diabetic patients enrolled in trial, and 26% relative risk reduction in secondary endpoint when comparing icosapent ethyl to the placebo, and that's why it was indicated and recommended by the guidelines. The guidelines also give you a choice of using fenofibrate and bezafibrates in patients with high triglyceride, emphasizing the importance of these agents, especially in diabetic or metabolic dyslipidemia who have high triglyceride level, low HDL, and normal or high LDL cholesterol level. CKD patients or guidelines place them in the extreme, very high or high risk category. Statins are still the first choice in these patients. Combination with ezetimibe PCSK9 inhibitors can be used. And the dose modification is very important in kidney patients. Just remember that atorvastatin does not require much dose modification. Fluvastatin, the same thing. Pravastatin, the same thing. Ezetimibe also does not require dose modification. For the triglyceride, gemfibrozil does not require dose modification. And omega-3 fatty acids, they don't require dose modification. Similarly for PCSK9 inhibitor class. Now, very important to know the implications of the guidelines, the latest updated guidelines. And very interesting to present is the Da Vinci study. Now, Da Vinci study was a cross-sectional observational study of lipid-modifying therapy use in secondary and primary care. And the aim of the study was to present or show a contemporary information on the LDL goal attainment across different European countries. So this was over Europe only. Now, the study was conducted based on the 2016 guidelines of the European guidelines, and it was ended before the release of the 2019 guidelines. But what they did, they just published the post hoc analysis of the data that they have and applying the 2019 guidelines to see and compare with the 2016 guidelines. So again, the Da Vinci looked at the goals to comparing the 2016 with the 2019 guidelines. As you can see, no change in the low risk. The moderate risk risk, of course, you can see it was below 3, now it's below 2.6. For the high, very high, and second CVD event, of course, the 50% reduction was maintained, but the great emphasis, and it was previously or, but now it's and a target. As you can see, the high risk was changed from below 2.6 to below 1.8, and the very high risk from below 1.8 to below 1.4. There was no data available or recommendation available regarding the second CVD event, but now it's available and should be 50% reduction and below 1 target. So when we compare the percentage of patients who attained the LDL goal in the Da Vinci study, comparing the 2016 in dark orange bars versus the 2019 light orange bars, you can see that a lower percentage of patients at different classes of lipid lowering classes were able to achieve the 2019 guidelines. It was difficult to do that. And when we look at this slide again, the proportion of patients achieving the goal, comparing the 2016 with the 2019 guidelines, the 2019 is like the shaded bars. You can see again, less patients were able to achieve the targets when we apply the 2019 guidelines compared to 2016. And when we look at the proportion of patients receiving lipid lowering therapy, so let's take, for example, the moderate risk category. 60% of patients were receiving moderate intensity statins, so the orange is moderate intensity, and 16.9% receiving the high intensity statin, 9.8% only receiving ezetimibe, and 1.6% only receiving PCSK9 inhibitor. And look at the shocking result for the high risk. High risk, 63% receiving moderate intensity statin, only 18.9% receiving high intensity statin, 4% receiving ezetimibe, 0.5% receiving PCSK9. And the most shocking is the very high risk category. You have only 36% receiving the high intensity statin, 9% only receiving ezetimibe, and 1.2% receiving only the PCSK9 inhibitor. And that's a very fresh data from the Da Vinci. Also, looking at the mean LDL cholesterol in patients with stabilized lipid-lowering therapy. In primary prevention, we could accept that. The mean was like about 2.5. But look at the established secondary prevention across the different sort of secondary prevention. Look at the LDL. The mean LDL achieved in these patients on lipid-lowering therapy was around 2 millimole, or even a little bit higher than 2 millimole, showing that we are failing to achieve these guidelines and targets. So the conclusion of the Da Vinci study shows that among patients receiving lipid-lowering, fewer than half of the very high risk primary and secondary prevention patients achieved the 2016 goals, with approximately 1/5 only achieving the 2019 goals. Even with optimized statin usage, the prevalent gap between guideline recommended LDL goals and their implementation in clinical care will require greater utilization of non-statin in combination with statin for patients at highest risk. So what do we learn from the Da Vinci study? First, clinicians need to change their thinking with respect to how they manage high and very high risk patients in routine practice. Second, with even more stringent LDL goals introduced in 2019 guidelines, goal attainment is even lower, as we know. Failure to optimize the use of high-intensity statin therapy is one of the factors for failure to achieve the targets. It is, however, clear that 2019 guidelines for high and very high-risk patients is largely unattainable on high-intensity statin monotherapy. Such patients also require combination therapy. Now, a practical message from the Da Vinci is to assess risk. Just look at the risk. And if your LDL goal is below 1.8, consider early, and I highlighted early. Early meaning that as soon as possible. Your first step when you decide on lipid-lowering therapy, consider using combination therapy with ezetimibe as suggested by 2019. However, keep in mind, the Da Vinci study also demonstrates that very high-risk patients, around 4 in 5, will likely require PCSK9 inhibitor combination therapy, potentially without the ezetimibe step. Now, this was the data, a fresh data, a post hoc analysis for the Da Vinci study applying the 2019 guidelines. What about our region? That was for the European countries. What about our region? It would be very interesting to see what's going on in the Gulf region. And to answer this, we have an ongoing, a fascinating project, the Gulf Achievement of Cholesterol Targets in Outpatient Study, or the Gulf Action Study, Identify and Act project. That is a very, very fascinating study that has already started. The objective of the study is to up-to-date comprehensive assessment of the current situation of the dyslipidemia patterns and management in the Arabian Gulf region, develop a quality improvement initiative to enhance the achievement of the LDL targets in patients who did not achieve them based on the latest ACC or European guidelines, determine the perceptions and beliefs of the treating physicians as well as patients in the Gulf region regarding dyslipidemia. And for that, they're going to have a sub-study looking at physicians separately and the patient's perspectives separately. And finally, determine the presence of subclinical atherosclerosis in patients without evidence of cardiovascular disease by coronary calcium score, other imaging modalities, and blood levels of biomarkers and of inflammation. The results of the study is expected hopefully to be released by 2022. And I think that would add a very, very informative sort of information about the status of how we are implementing the guidelines in the region and compare it to what the European have found. So in summary, looking at all the guidelines and particularly the most updated from 2019 and on guidelines, we know that LDL goals were lowered for moderate to high cardiovascular risk patients. For patients with atherosclerotic cardiovascular disease who experience a second vascular event within 2 years, an LDL goal of less than 1 or less than 40 milligram may be considered. In high and very high risk categories, at least 50% reduction in LDL levels from baseline, a proxy for the use of high-intensity statin was added. The latest guidelines recognize the high and very high risk of certain primary prevention patient groups, including those with diabetes or familial hypercholesterolemia without established atherosclerotic cardiovascular disease or with chronic kidney disease. While statins are first-line treatment to lower LDL cholesterol, the guidelines also recommend combination with non-statin LDL lowering therapy to achieve the stringent new targets. And you might need to consider combination as early as possible in your high-risk and very high-risk patients. And with that, I would like to conclude and thank you very much for your listening.
Thank you, Dr. Nasreen, for your elegant and clear and concise, and you have simplified actually the guidelines. Thank you very much. The last speaker for the lipid session is Dr. Lee Kaplan. He is well known to you. He already gave nice lectures in the past 2 days. He's just briefly, he's the director and founder of Obesity and Metabolism and Nutrition Institute at Mass General Hospital. He's associate professor of medicine at Harvard Medical School. He's the past president of Obesity Society. His research interest is in gut microbiota and regulation of energy balance and metabolism. His graduate both in medicine and his training all has been done at Harvard Medical School. He's also he has an important course in obesity. It's called the Blackburn course, which happens in June each year. And that's highly recommended course for people who's interested in obesity. So Professor Kaplan, go ahead and start your lecture, and the floor is yours.
Good evening. I'm going to talk to you tonight about the disease called non-alcoholic fatty liver disease, or NAFLD, and in particular about the pathogenesis and treatment of the more progressive form of this disorder called NASH, or non-alcoholic steatohepatitis. Now, non-alcoholic fatty liver disease is the most common disease worldwide, and it's especially prevalent in advancing or modern societies, but it really is present in parallel with obesity and diabetes in virtually every country in the world. It's characterized by hepatic fat deposition and is frequently progressive, leading to inflammations, liver cell damage, fibrosis, and over several decades to cirrhosis in some of the patients. It's not related to alcohol consumption, so it has to be distinguished completely, although some of the histology looks similar. Now, the prevalence of NAFLD and NASH is shown in this map from the World Health Organization, and what you can see here is that in the Middle East, where you're all located, has one of the highest rates in the world. Nearly a third of patients or of people actually in the Middle East having NAFLD in some form, either in the mild form, just steatosis, or the more severe form. If you look at people with diabetes, you can see here that the prevalence of NAFLD in diabetes is enormous, with 2/3 of people with diabetes in the Middle East having NAFLD, and some of those, perhaps as many as 25%, having NASH. Now, what are the definitions? Well, hepatic steatosis is just excess fat deposition in the liver, and we sometimes call it bland steatosis because there's nothing more than fat. When non-alcoholic fatty liver disease is the full spectrum of diseases with fat in the liver, and NASH is non-alcoholic steatohepatitis, which is hepatic steatosis, fat in the liver with features of inflammation and fibrosis, and you need both to have the diagnosis of NASH. NASH is associated with progressive liver disease. So once you get NASH, you know that you're on the pathway toward progressive liver disease. As I'll show you in a minute, the people with bland steatosis alone, most commonly don't actually progress to NASH or further. But the number that do progress to NASH will then follow a pathway over several decades, all the way on the way to cirrhosis. Now, NAFLD and its complications are shown here. Here's a normal liver. If you have metabolic dysfunction, you can get isolated steatosis, or you can get NASH. If you get NASH, you'll see progressive fibrosis leading to cirrhosis. And it's a little bit debatable as to whether isolated steatosis can turn into NASH, or whether you develop steatosis or NASH at the moment that the fat starts to collect in the liver. There's probably a little more evidence that you either go down one pathway, the one on the top, or the pathway on the bottom, rather than interconverting between these two pathways. Now, in addition to the progression towards cirrhosis and liver failure, one of the other complications of NAFLD is hepatocellular carcinoma, and the other is cardiovascular disease. We don't yet know whether the cardiovascular disease comes from the liver disease, although there's some evidence that liver disease can contribute directly to cardiovascular disease, or whether the cardiovascular disease is just a component of so-called metabolic syndrome or metabolic dysfunction that occurs in the presence of fatty liver disease, because fatty liver disease occurs in people with metabolic dysfunction. Now, there's a histological scoring system that allows us to assess the severity of NAFLD. And there are two separate scores. The first one is the NAFLD activity score, or NAS, and it's a 0 to 8 score. Steatosis can give you anywhere from 0 if you have no steatosis up to 3. Lobular inflammation is on a scale from 0 to 3. And hepatocyte ballooning or cell injury is on a scale from 0 to 2. And you just simply add up those 3 subscales to get the total, which can be as high as 8. There's a fibrosis staging that goes from F0, meaning no fibrosis, all the way to F4, which is cirrhosis, and I'll show you in the next slide how that goes. So the fibrosis stage is dependent upon where in the lobule of the liver you'll see the fibrosis. So of course, the liver is fed by vessels on the edge of this lobule here in the portal zone. You can see that the portal, the ramifications of the portal vein shown here in blue on the edge of this diagram, and the hepatic artery shown in red on the edge of this diagram. feed into the liver, and then the blood flows across the lobule and drains through the central vein shown in blue in the middle of this diagram. The central lobular or perisinusoidal region of the liver is zone 3, portal is zone 2, and in between is portal is zone 1, and in between is zone 2. So in fibrosis stage 0, there's no fibrosis, only fat in the liver. In fibrosis stage 1, there's perisinusoidal or zone 3 fibrosis, or there's a small amount of zone 1 or periportal fibrosis, but not fibrosis in both places. In F2, there's fibrosis in both places, both perisinusoidal and periportal, zones 1 and zone 3. For F3, you see bridging fibrosis, where it goes from the perisinusoidal region to the periportal region through zone 2, and that's called bridging fibrosis, and that will be called F3. And finally, F4 is cirrhosis, where you have a much more severe form of fibrosis that actually chokes off some of the functional hepatocytes so that the liver begins to have liver failure on top of the severe fibrosis. Now, the clinical implications of NAFLD and NASH are that it's undiagnosed in most cases, even though it's highly prevalent, particularly in patients with type 2 diabetes. And only about 40% of people with any degree of severity of NAFLD have elevated transaminases. So whether you have just bland steatosis or you have cirrhosis or anything in between, a minority of people have elevated liver enzymes. So that's not a very sensitive test for looking for it. But the epidemiology is sensitive, as I've already indicated, particularly severe obesity or type 2 diabetes. Now, it can progress to cirrhosis and liver failure, as we've already talked about, and it's already the second most common cause of liver transplantation in the United States and in Europe, and is continuing to grow, and so is likely to become the most common cause of liver transplantation in most parts of the world where transplantation is routinely done within the next half decade. It's associated with hepatocellular carcinoma, which is one of the most common, if not the most common, solid organ cancer in the world. And it's associated with up to double the risk of developing cardiovascular disease, which is the major cause of death of people with NASH. So although people with NASH do die of liver failure or hepatocellular carcinoma, far more common is dying in an accelerated way from cardiovascular disease. Damage to the liver from NAFLD is often synergistic with other forms of liver injury. So if you have NAFLD and then you get viral hepatitis, or you get autoimmune hepatitis, or if you use alcohol or drugs that cause liver injury, those causes of liver disease are likely to be worse if you have underlying fatty liver disease. So as I indicated, advanced fibrosis is associated with increased all-cause mortality and increased cardiovascular mortality. And if you look at the advanced fibrosis, which is stage F3 or F4 fibrosis, you can see there that in this Kaplan-Meier curve that there's a drop-off in life in advanced fibrosis, specifically from cardiovascular disease. Now, you can see that here. If you look at all-cause mortality, advanced fibrosis is associated with more than threefold increase in all-cause mortality. And as you can see here, that most of that or much of that increased mortality is from cardiovascular disease. Now, the severity of liver fibrosis staging predicts mortality. So if you look at all-cause mortality, there's a linear relationship between increased stage as you go from F1 to F4 and all-cause mortality. If you look at liver-related mortality, you see that there's a big bump in mortality between fibrosis stage 3 and 4. There's still an elevation in fibrosis stage 2 and 3, but it really goes up substantially in stage 4. So what that tells you is that the substantial increase in cardiovascular mortality is particularly notable in fibrosis stages 2 and 3, where it is by far the majority of the total mortality. as compared to stage 4, where liver mortality also plays an important role. Now, in terms of clinical screening and diagnostic strategies, remember to consider liver disease in every patient you see with obesity and type 2 diabetes. The severity of that liver disease is going to vary from patient to patient. And we'll go through an algorithm which is just in press now from the American Gastroenterological Association. And this algorithm was developed by a consensus group representing multiple specialties in the United States. And we'll come back to that in just a moment. Liver enzymes can be used to aid routine screening, but they're not the be-all and end-all because they're not sensitive enough to find fatty liver disease in an unselected population. The risk scores, and I'm going to talk about one of them called FIB-4, are predictors of fibrosis, but they're not measurements of fibrosis. So measurements of fibrosis have to be done in different ways. And ultrasonography is a sensitive tool to assess steatosis, but it's not at all useful for staging or assessing progression to NASH or beyond NASH. Elastography, and one of the forms of that is made by a company called FibroScan, is a very sensitive and specific tool to assess the degree of liver fibrosis by measuring the stiffness of the liver. As the liver develops fibrosis, it becomes stiffer, and you can use this type of test in order to assess the degree of fibrosis without needing to do a biopsy. And unfortunately, there's no good non-invasive tool to assess inflammation or cell injury. So that has to be done by biopsy if we're going to be assessing it. And right now, most clinical trials use a biopsy as part of the evaluation so that we have a good sense of inflammation and hepatic injury. Now let's look at this algorithm, which is, as I mentioned, is in press from the American Gastroenterological Association. The first thing you want to do is you want to identify patients at risk. And so you have if you have two or more metabolic risk factors, components of the metabolic syndrome, or just diabetes alone, or steatosis on any imaging modality. So that could be by ultrasound, by CAT scan, by MRI. Those are patients that should be considered at risk. Step 2 is to do a history and the laboratory test, assess for alcohol use, do a CBC, do a comprehensive metabolic panel. And what you're basically looking for is to get to step 3, which is non-invasive testing for fibrosis. However, if there's an elevation of the liver test, of the transaminases, you want to take a side trip just to make sure that there are no other liver diseases that either are causing the liver injury or are coexisting with fatty liver disease and will influence the way you treat the patient. So step 2A in evaluating for other forms of liver disease is really straightforward. You can do this in collaboration with colleagues who are hepatologists, or you could do it yourself. Get a sense of how much alcohol the individual is drinking, do hepatitis C, antibody and RNA testing, consider serologic testing for hepatitis B if the patient's at higher than average risk for hepatitis B, and consider other serologic testing looking for autoimmune hepatitis and hemochromatosis, alpha-1 antitrypsin disease, and Wilson's disease, not listed here, in younger patients only. If the test results are consistent with the presence of other forms of liver disease, then treat the patient as though they have those other forms of liver disease. And if that means referring to a hepatologist, then this would be an indication to do that. Now, if they're negative for other forms of liver disease, they go back to the main algorithm that I talked about, and that's step 3, non-invasive testing for fibrosis. And so the first non-invasive testing for fibrosis is a serologic test or a group of tests called the FIB-4. And FIB-4 is a calculated value. You can go online and just do FIB-4 calculator, and you'll get a FIB-4 calculator. There are several of them on the web. And it's based on the patient's age, their AST level, their ALT level, and their platelet count. And if that level is low, less than 1.3 as shown here, the patient is low risk, and you don't need to do anything further except repeat the non-invasive testing in 2 or 3 years and start all over again. If the FIB-4 level is high, over 2.67, then that's a high-risk patient and probably is progressing and therefore probably needs to be evaluated and perhaps treated in some degree by a hepatologist. In the middle, which is where you'll see a lot of your patients, between a FIB-4 of 1.3 and 2.67, is somebody with indeterminate risk. And because the risk is indeterminate, we're not sure of what the risk is, we move to the second phase of testing, which is liver stiffness measurement, or FibroScan is the one that's most common. And so again, if the liver stiffness measurement is less than 8, it's low risk. You go back to the low risk and you just repeat all the studies in about 2 or 3 years. If it's high, above 12, then you should refer to a hepatologist because this person has progressive liver disease. And if again it's indeterminate, between a liver stiffness measurement of 8 and 12, you should consider referring to a hepatologist for liver biopsy to really assess. And this is the one group that makes it through 2 stages of indeterminate risk that needs to be referred specifically for a biopsy. Now, the current treatment of NAFLD, once you assess that the patient has NAFLD, comes in 2 strategies. The first is to treat the liver disease, but our opportunities for treating liver disease, this kind of liver disease directly, are very limited. We have vitamin E, which shows a histological benefit in NASH without type 2 diabetes, but doesn't show a benefit in those patients who had type 2 diabetes. And pioglitazone, which shows a histological benefit in NASH and may even be better in patients with type 2 diabetes because of the improvement in insulin sensitivity that is associated with the thiazolidinediones. Now, the other approach, which is more common today, is treat the underlying obesity, because if you get a patient to lose a substantial amount of weight, they are likely to improve their NASH. As I'll show you in the next slide, at least 7 to 10% durable long-term weight loss appears necessary to improve histology and liver tests. So weight loss is associated with remission of steatohepatitis. Here's a study of about 300 adults with NAFLD. The average NAFLD score, the NAS, was 4.8, which is sort of in the middle between 0 and 8. But 61% had F0 fibrosis, which means 61% had no fibrosis, which makes this a very mild form of NAFLD as a group. So not only 39% of patients here had NASH in this whole population. The intervention was 52-week lifestyle-based therapy with a calorie reduction diet and extra exercise. And the average weight loss was 3.8% in this group. 30% of the patients in this group lost more than 5% of their weight, and the average reduction in NAS score was 1.58. And what you see here is if you look at the weight loss against the remission of steatohepatitis, the remission of NASH itself, back toward NAFLD, you see that if the weight loss was over about 7 to 10%, you saw a substantial portion, over 2/3, achieving remission of their steatohepatitis. Now, the other way that it's been looked at, of course, is metabolic and bariatric surgery. And the 2 most common forms of surgery, as you well know, are gastric bypass and sleeve gastrectomy, which are both recommended for patients with a BMI over 35 and a major obesity complication, including NASH. That's one of the complications. The cutoff points for the recommendation for surgery are lower in East Asians and South Asians, as you may well be familiar with, but we'll use 35 for everybody else in the world. And one nice study has demonstrated that bariatric surgery improves several aspects of NAFLD. And there are a number of other studies that do that, but not as well as this one does. And this is a small study, 65 patients with advanced NASH, either F3 or 4, or NAS score 3 or 4, meaning that they had to have at least moderate NAS, meaning moderate inflammation and fibrosis, but they had to have a fibrosis that was in the bridging fibrosis or cirrhosis category. And the intervention was gastric bypass or sleeve gastrectomy, and the average time to follow up was 6 years. So we're looking way down the line after they've had their surgery. The average weight loss at that point was 23%, and the average decrease in the NAS score was 3.12, or about twice as much as in the previous lifestyle-based study that I just mentioned to you. And what you see here is that at baseline, the NAFLD activity score was everybody was in the NAS 3 to 4 range, and nobody was in the steatosis or NAS 0 to 2 range. But after 6 years later, after they had had the bariatric surgery, you can see here that 97% were in the steatosis NAS 0 to 2 range. So therefore, there was an improvement in the characterization of the NASH itself, independent of the fibrosis. Now, the predictors of improvement of high activity NASH were shorter diabetes duration and greater weight loss, not terribly surprising. If there was no severe fibrosis, meaning it was only F3, then about a third of those patients, up to a third of those patients, had a normal follow-up biopsy, meaning they had no fibrosis. So the fibrosis, even at starting at stage F3, went down to normal in about a third of the patients. Now, if you look at the fibrosis, you can see that everybody was either F3 or F4 at the beginning of the study on the left here. And you can see a substantial number became F0 or F1 after the surgery. Some of the patients, of course, about 45% remained at F3 or F4. 3% were at F2, and another 50% or so had come down to F0 or F1. So a substantial improvement. And again, predictors of improvement in fibrosis included younger patients, improvement in type 2 diabetes, longer time until follow-up. So if the patients were further out from surgery, they did better because there seems to be progressive improvement in the fibrosis. And if they underwent gastric bypass, they did better than the ones who underwent sleeve gastrectomy. Now, the effect of bariatric surgery then on NAFL and NASH is that there's an immediate improvement in steatosis. There are effects on inflammation, necrosis, and fibrosis, but those are less clear. The study I just showed you was very clear, but there are a number of other studies that are less clear. Weight loss and other metabolic improvements after surgery definitely appear to provide hope of a benefit. And there are no large or well-controlled studies other than the smaller one that I just showed you. The first very well-controlled studies in a substantial population are ongoing at this point. The effects of surgery to prevent progression to cirrhosis or hepatocellular carcinoma, which really are the bad outcomes that we worry most about as far as the liver is concerned, it's not clear yet. There's no study that shows that those hard outcomes are in fact prevented by bariatric surgery, at least not yet. And finally, the mechanism of benefit, whether it's weight loss alone that's doing this or weight loss independent metabolic effects of the surgery, such as have been seen for diabetes, where in diabetes, you see the improvement in diabetes is partially due to weight loss and partially due to weight loss independent effects of the surgery. But that differentiation for fatty liver disease is not yet known. Now I want to turn to the first medication that I think has the promise of having a substantial benefit for patients with NASH, and that's semaglutide 2.4 milligrams. There were 320 participants in this study with stage 2 to 3 fibrosis, so nobody with stage 4 fibrosis or cirrhosis. It was a 72-week treatment period with either semaglutide or placebo. The primary outcome was NASH resolution without worsening of fibrosis, which is the outcome that the regulators are interested in. And what you see here is if you look at placebo, 17% of patients who received the placebo achieved the primary outcome. That seems pretty high, except you have to recognize that this is based on two sequential liver biopsies, one at the beginning and one at the end of the study. And there's a lot of heterogeneity across the liver in terms of the degree of fibrosis, the degree of inflammation and cell injury at different parts of the liver. So some of that 17% is probably randomness. But if you look at the highest dose of semaglutide, 0.4 milligrams per day, which is the equivalent of 2.4 milligrams per week, you see that 60%, nearly 60% of patients achieved complete remission of their NASH without worsening of the fibrosis. So that's highly statistically significant, it's highly clinically relevant, and phase 3 trials of this treatment for NASH are underway right now. There's a second primary outcome, which is improvement in fibrosis without worsening of NASH, sort of the flip of the first primary outcome. And for the second primary outcome, which is for this one-year study, an improvement in fibrosis without worsening of NASH, the semaglutide had no benefit over the placebo. So the semaglutide improves the NASH, at least in this study, without worsening fibrosis, but it doesn't have a major effect to improve the fibrosis itself. So when we think about the AGA algorithm for evaluating and managing NAFLD and NASH, if you talk about the treatment, if the patient's low risk, then lifestyle intervention to improve the obesity and to improve the diabetes and potentially improve the fatty liver disease is always a good idea. But obesity treatment per se is optional. Pharmacotherapy is not recommended, and anything else that would reduce cardiovascular risk is also a good idea. Diabetes care is standard of care. For patients with indeterminate risk, we would use lifestyle, we would use obesity treatment for sure. We would use pharmacotherapy directed at NASH, whether it be pioglitazone, vitamin E, or more recently, semaglutide. We, of course, would continue to try to reduce cardiovascular risk in every way possible. And in the case of diabetes care, standard of care, but we'd prefer medications with efficacy in NASH, such as semaglutide. And there'll be others coming up. For high-risk individuals, we want to do everything. We want to institute lifestyle therapy. We want to institute obesity therapy. We want to institute pharmacotherapy specifically for NASH. We want to institute cardiovascular risk reduction modalities. And of course, once again, we prefer medications for diabetes, or we prefer the regimen to include medications that have proven efficacy for NASH. Now, the future opportunities, of course, are widespread. There are interventions directed at preventing or treating the complications of NASH, including fibrosis. So there are anti-fibrotic agents being tested. There are studies of agents to prevent the progression toward hepatocellular carcinoma. There are agents that are looking at other metabolic effects so as to reduce the cardiovascular risk, specifically in this group of patients. And all of those are being developed now, but none of them has demonstrated efficacy. Some of them are very early in development, and we just have to watch this space and look over the next 10 years to see what comes forward. But there are many unanswered questions about fatty liver disease, and I just want to give you a few of them now. Where in the NASH progression pathway is the sweet spot for intervention? Right now, the best interventions are really early on when we're dealing with the obesity and the fatty liver itself, rather than the later stages like fibrosis and inflammation. Do different subgroups of NAFLD patients respond differently to each type of therapy? We assume yes, but we don't know how to sort that out yet. Can later stage liver disease be reversed or only slowed or halted? There's some evidence, as I've mentioned, that bariatric surgery in some patients can reverse fibrosis as long as it doesn't get to the cirrhosis level. So even in that study I showed you, F3 patients can see their fibrosis improved. How much weight loss is needed? I said more than 7 to 10%. But we don't really know that. It looks like the more weight loss you achieve, the more the improvement is going to occur. Did drugs or surgery induce improvement in liver disease independent of weight loss? As I indicated earlier, we don't know yet. It's attractive to hypothesize that, but we just simply don't know. And to what degree do anti-obesity and anti-diabetes treatments improve for the cardiovascular outcomes of NAFLD? Or are they just simply improving the liver outcomes? Well, we know most of the therapies that we use today, whether medical or surgical, also improve diabetes, also improve cardiovascular risk independent of fatty liver disease. So sorting that out is also challenging. Are these effects dependent upon the stage of liver disease? We don't know. And does improvement in any particular component of liver injury correlate with the cardiovascular benefits? We don't know that either. These are all good subjects for ongoing research. Excuse me. So I'll leave you with a final comment. NAFLD and NASH were first described only as recently as 1980, just 40 years ago. 40 years later, fatty liver disease has become a global epidemic, as I showed you at the beginning of this talk. Reducing its clinical impact is a critical component in the fight against chronic metabolic disease. And for most of this audience that focuses on metabolic disease, endocrinology, and diabetes, incorporating the evaluation for fatty liver disease and its treatment into your practice is what you'll be doing in the future. So I look forward to having you embrace this, work closely with hepatologists and primary care providers, excuse me, so that we can get coordinated care that improves the lives of all of these patients. Thank you very much.
Okay, Dr. Nasreen, we have one question for you from the attendee. And he's asking Atorva 40 plus azithromycin versus Atorva 80. Any studies comparing the two dosages?
Yes, there were, of course, no large head-to-head clinical trials, but there are some few observational data, and there are some, pharma-based sort of studies looking at comparing them. Like, for example, there was a study. I mean, I can see if I can share my screen and show that. So this is the Ballantyne study. The Ballantyne study, they looked at the Ballantyne trial, they looked at the efficacy of ezetimibe in combination with atorva or simva in patients not currently on lipid-lowering therapy. And if you look at this slide specifically, when they compare the addition of ezetimibe with atorva, so these are the green bars, compared with the atorva, which is the atorva monotherapy, which is the gray bar. So when you compare, according to the question, this is the 80 milligram alone atorva, and if you compare it with the atorva combination with ezetimibe, you can see that there is a similar sort of efficacy in LDL lowering, maybe even slightly better for the combination of ezetimibe and atorva. These are the particular dose that he or she asked about. In clinical practice, we do see that sometimes you see really significant differences, occasionally probably the same, but this is most likely what is translated even into clinical practice.
Thank you, Dr. Nasreen. Somebody is asking about also, one of the attendees asking why we are mixing guidelines, for example, algorithm and calculator by HA and risk factor by ESC. So he's asking about mixing guidelines and risk factor calculators.
I'm not quite sure what he or she means by mixing guidelines, but the guidelines are very clear. So, for example, when the slides shown regarding the European guidelines, it particularly talks about the score risk. So they use the score risk calculator, while the ACC use their pooled risk calculator. So each guideline have their own sort of risk calculation. Like, for example, the National Lipid Association, the IAS, they recommend the Framingham risk scoring. We recommended for the region, for this region in the Middle East, the Framingham in our previous paper. And I don't want to talk about the new paper, which is going to be released, but inshallah, hopefully we will see in our new publication on the new updated guidelines. But no, clearly each guideline has their own sort of risk score calculation.
Thank you, Dr. Nasreen. And in that line also, which calculator is more accurate, AHA calculator or score?
Yeah, that's a $1 million question that always physicians ask. Unfortunately, I mean, most of these risk calculators that we have, you name them, I mean, the AHA, the Framingham, the SCORE, Reynolds, all of those, they were not, unfortunately, validated in our region. So we don't have a validation in this particular region, but we try to sort of some risk calculators that might suit our region. So looking at the ethnicity that is mentioned in the Framingham, it gives you that option that you can apply it to this region. And that's why probably was our sort of recommendation. You can go with the Framingham risk for this region.
Again, regarding the risk and guidelines, American Heart Association guidelines, they put people with the risk of 7.5 to 20% will be treated after.
Do you have any question or?
With reviewing risk estimates and risk enhancers? What's the risk estimates? Asking specifically about risk estimates.
Yeah, the risk estimates and the risk enhancers are depending on several factors. So we look at, for example, the age of the patient, family history, smoking history. These are sort of the risk estimates, primarily family history, premature cardiovascular disease. And the risk enhancers are like, for example, looking at the biomarkers such as the CRP level, looking at the LP(a) level, looking at the NKL-brachial index level, and also the coronary calcium scoring.
We have one question from Dr. Khalid Al-Waidi.
Thank you, Dr. Khalid, for your talk.
He's asking about treatment for high triglyceride in end-stage renal disease. Dr. Khalid,
yes.
high triglyceride and end-stage renal disease.
Yes, Dr. Abdullah. So thank you very much. Yeah, do you hear me?
Yes, you are clear. Please go ahead.
Yes.
High triglyceride and end-stage renal disease.
So we know that end-stage renal disease, or actually patients with chronic kidney disease, they are already a high risk for cardiovascular disease. And when we talk about the triglyceride, now we have to differentiate. Is it really a patient with a very high triglyceride, more than 500, that is a risk of pancreatitis? Or do you mean that a triglyceride between 150 and 500? And then we talk about more risk of cardiovascular disease. So if it was for more of cardiovascular disease, then those patients at high risk, they should be started first with the statin, optimize the statin. And as Dr. Nasreen highlighted, we have to choose the right statin and right dose for those patients. Ezetimibe has been shown very well in SHARP trial that can be used in patients with chronic kidney disease. It reduces also the cardiovascular benefits. And then patient on statin and they still have high triglyceride between 150 to 500. Yes, we can treat them. So we have to optimize the diet, and then we can actually use either the fibrate or omega-3. But now most of the studies would really encourage omega-3. It's really safer. Fenofibrate, we have to be careful about the interaction with the medications and those with patients with high creatinine. If the question was really targeted for very severe hypertriglyceridemia, more than 500, and this is the risk of more of acute pancreatitis, so then yes, those patients, they have really to be treated very well, and we should really start with the diet, with the low-fat diet. Medium chain fatty acids can be used actually to lower the triglyceride. Omega-3 and fenofibrate, they can also be used as well as the statin. The only thing that we really have to be careful about the interaction with those medications. Now, for the statin and high risk, we have also to be really to differentiate. Is this patient was already on statin and now from chronic kidney disease heading toward end-stage renal disease, then yes, we would continue statin. However, if the patient wasn't really on statin from before and now he has end-stage renal disease and already on hemodialysis, then the evidence, it is not really conclusive whether to start him or not to start him on statin.
Dr. Khalid, what is the level of like triglyceride when it goes pancreatitis? Which level?
Yeah, it's more than 500 milligram per deciliter. There is the risk, but actually when it is already more than 1,000, that's the highest risk. But on the guidelines, you would see that when we categorize whether it was the European, American, or the endocrinology guidelines, they categorize 150 to 500 and those with above 500. So more than 500, they are really at risk of pancreatitis.
Can I add a question here of Professor Reyes here, or maybe Khalid will help us. What about plasma exchange? Where does that fit in your clinical practice?
Yes, that's really an excellent question.
Nobody talked about it today.
Yes, so the plasma exchange, I tell you, the most commonly used that we would see is really the LDL apheresis. So the LDL apheresis or lipid apheresis is really mainly used for patients with homozygous familial hypercholesterolemia and patients with heterozygous severely not controlled with the usual medications. If you see the LDL apheresis is really mainly for LDL and some part of the VLDL. So yes, it can reduce the triglyceride. However, it's only around 20%. This is from our experience from the lipid apheresis unit. However, with the plasma exchange, many people, they have used it in the acute scenarios of patients with severe hypertriglyceridemia and acute pancreatitis. So either they use the hemodialysis or the plasma exchange, but it is really temporarily. But what we have really seen from practice, a patient with a very high triglyceride, usually when they present with acute pancreatitis, so usually by surgeons, they are nil by mouth, so they are MBO. And then if you start them with a very low fat diet from the beginning, and then you would see within few days that really it would go down. In patients with diabetes, of course, if it is really poorly diagnosed and poorly controlled diabetes, then usually the endocrinologist, they would start with the insulin, and then the amount you start, the moment you start the insulin, actually you would see the lowering of the triglyceride.
Questions for Dr. Nasreen. Thank you, Khalid. What is the indication of imaging without established atherosclerosis vascular disease? So use of imaging.
Yeah, that's a very commonly asked question. And some of the guidelines were actually very particular about that. They explained that in detail. So for example, if you have a patient without established cardiovascular disease, you might need considering imaging studies, for example, in high-risk patients, like, for example, FH patients. Now, the idea of screening these patients is to look at any occult or early cardiovascular disease in these patients to set your target. So if you can remember the groups that I showed you, we said that if your FH has some evidence of even occult, cardiovascular disease, the target of the LDL would be different. We should be aiming really low, like below 1.4 millimole versus FH without any evidence of occult vascular disease. So in these high-risk categories, you may want to consider imaging. The second thing is that patient who comes like the puzzle for you in the clinic with a persistent LDL that is not 190 and above, that is straight away you go with treatment, but it's in that category or level that you're not confused, you don't know whether to treat or not. So 160 and above, despite lifestyle intervention and everything. And you are sort of reluctant to see if you want to put this patient on a lifetime, statin therapy, and the patients would argue with you even. You just tell them statin, they would start arguing about lifetime statin therapy. So you could consider these biomarkers like the CRPs and LP(a) and ApoB levels. And in addition, the value of coronary calcium scoring is very much talked about now, because when you do the coronary calcium scoring, which is a CT imaging, and you receive a zero-like score, it's sort of a zero score is a very, very reassuring for you that this patient is not at a very high cardiovascular risk. And I can see Professor Ray joining us now.
Do you have any question for Professor Ray, Dr. Nasreen? Yeah. Any question for him, I think?
Yeah, maybe he can also elaborate on the indications for imaging without established atherosclerotic cardiovascular disease.
Yeah, so the main thing I think we think about here is if you've already made the decision to treat, then you don't need the imaging. It's in those people with intermediate risk where you can do one of two things. You can either say, okay, well, we could, for example, you're going to cross the threshold. So if every risk factor stays the same and I just change age, and in 5 years' time, you're effectively going to be on treatment, why wait 5 years? So I tend to use imaging much more. There are a few patients who are completely against medication, and it helps to reclassify those individuals correctly. It helps visualization as well. And one of the most useful things about imaging, whether using ultrasound, particularly carotid, particularly CAT scan, is percentile for age and sex. That is really useful amongst younger people, because it means that basically if I do nothing, and I'm in the 95th percentile, then for my sex, there are only 5 people with a worse heart than me right now, and that's not going to change. And I will still be in the top 5, and that's not the good 5 to be in. So that's kind of how I use imaging, is for those types of patients. The other thing is you can use is for progression of disease. You know, if you've got people on what you think is appropriate treatment, CAT scan doesn't really help there. But there you might use you might use, for example, CT coronary angiography or carotid ultrasound to assess progression of disease. Some people will progress a bit more than others, and then you can be more aggressive or less aggressive with treatment.
Professor Ray, they are asking about what's the minimum starting dose of statin in a diabetic patient for a primary prevention with no contraindications?
Yeah, I think today we would probably use rosuvastatin at a dose of 10 milligrams or atorvastatin at a dose of 20 milligrams. And the rationale is that you're probably getting people to over 40% reduction in LDL with those starting regimens, and which would basically put you into that right in the middle of that moderate intensity bracket. But if you've got long duration of diabetes, if you've got additional risk factors, if you've got microvascular disease, then we are aiming for a 50% reduction. So, and that was one of the things that was done very well in the UK, because, you know, GPs were using very low doses of weak first generation statins. And because of the safety of these drugs, that basically the starting dose at a policy level was 20 milligrams of atorvastatin or 10 milligrams of rosuva. So we never see anybody on lower doses.
Another question.
Yes, I want to go back to hypertriglyceridemia, because severe hypertriglyceridemia is a very common entity in our
disconnected. Somebody is asking also about patients with hypertension accompanied by high serum CRP, level of statin drugs to avoid cardiovascular disease risk.
Yeah, so I think that, you know, in terms of hypertension, so if you look at the ESC guidelines, there's extreme elevations of blood pressure, which would put you into a high risk group. If your systolic's above 180, for example, puts you in an extreme, it puts you in a high risk group. So you should be aiming for 70 in those people. Most people won't have extremes. They will have maybe the blood pressure of 150. And we here in that situation, we need to think about global risk. So if you take 8 variables, age, sex, smoking, lipids, blood pressure, and so forth, you get a 10-year risk. And what CRP is, a bit like imaging, a bit like LPA, is a risk enhancer, because what it's trying to do, the more variables you have, the better your precision is. So again, if, for example, a patient was considered to be intermediate risk and you might delay treatment, if you basically had a high CRP, that would push them into a higher risk group, and therefore that would suggest you might want to treat them a bit earlier.
Thank you. Dr. Walid,
I'm coming back. Sorry, I had cut out. So coming back to severe hypertriglyceridemia, as I said, it is a very common problem in our area, where you actually give the patient all medications. And there are even some doctors, I see them referred to us, they are using fibrates in double doses. And still triglycerides is not controlled. Now, what are the options for patients who are already on a statin, a fibrate? Is doubling the dose of fibrate is an option? Is going more than 4 grams of omega-3 is also an option? And what's the role of the new medications like evenocumab? Then there's a very good study lately with a few numbers where actually it helps severe hypertriglyceridemia. So where is the evidence and where to go with these very difficult to control hypertriglyceridemia? Dr. Ray or Dr. Khalid can join.
So I think my approach, and I'll let Khalid add his bit, is that what is it that you're trying to prevent? I mean, if your triglycerides are above 10, so 20, 30, 40, I mean, I had a cancer patient who, after post-chemotherapy, had triglycerides of over 100. And, with him, for example, the worry would be pancreatitis. And so for those people, you often need combinations of treatment. So fibrates work very, very well and very quickly. We often need 3 grams of fish oils in these people. If there's an acute situation, you think about things like apheresis or plasmapheresis in those individuals. But for most people, we need to think about a dietary component. So the commonest thing in your region will probably be diabetes, and importantly, poor control of diabetes. And the other thing will be obesity, and there's obviously a dietary component. You've really got to focus initially on, I cannot sort of reiterate this enough, there's a lot of this that will improve with weight loss and with really quite aggressive carbohydrate restrictions. So what you're then left with is the risk of atherosclerotic cardiovascular disease. So your triglycerides are carried in particles that will also carry cholesterol. So if you look at the discordance between LDL and non-HDL, because you've got more ApoB containing lipoproteins, that's actually quite high. But that actually also helps us because these people will have this atherogenic dyslipidemia and a low HDL usually because there's an inverse relationship. The global risk is high. So this area, there is no, if you like, clear evidence of one treatment over another. If you believe reduce it, you would say, okay, if high dose EPA was available, then I would use that. There are some concerns about if the benefit is exactly 25% or more modest because of the control group, but I suspect that there is some benefit, but not as much. It won't change the triglycerides. Probably you're not worried about pancreatitis, you're worried about risk. I am a lot more comfortable with reducing atherogenic lipoproteins and by having more LDL receptors. Therefore, in these individuals, if I want to achieve non-HDL goals, if I want to achieve ApoB goals, essentially the addition, you could add in ezetimibe, but the addition of a PCSK9 directed therapy gives you huge reductions. So I think I wouldn't use an anti-PTL3. The costs will be prohibitive. Also, we will potentially be testing that patient group. I think we also need to wait for the results of the prominent trial as well. So prevent extremes of pancreatitis, then, and that's very aggressive, triglyceride directed lowering. The triglyceride is the thing you want to stop. Below a certain level, you're thinking about it as a marker of ASCVD risk, and your approach is different.
Thank you, Professor Ray. We have a specific question about familial hypercholesterolemia. They're asking about genetic studies, is it required? And the second about treatment of in a pregnancy and the choice in a pregnancy.
Khaled, do you want to take that? Or Nasreen or anybody?
For FH, they're asking, familial. So FH, they are asking about genetic studies and pregnancy treatment.
Yeah.
Anyone.
Yes, so for the FH, actually for the genetic study now, what we are doing, it depends if the family has been screened. So what we are doing now for any patient with a high probability of FH after we do the Dutch lipid criteria network. So yes, we do already screen currently in Oman, and in the Gulf actually, we have done also the Gulf FH study. So we do screen for the genetic causes. And once we know the genetic cause, then the family, we can use the cascade screening. So we just can look for that mutation. And I think it's really very important in our area now actually to do the genetic testing, especially if we are highly suspecting an FH. You know that we have a very high rate of consanguinity in our area. So it's really very important. And by knowing actually the patient FH, as Professor Kosekre in his presentation, he said if the earlier you detect those patients, the earlier you can start them. And in our region, actually, it applies what he has presented, that it is really underdiagnosed and undertreated. And we have seen many patients with FH, heterozygous FH, at the age of 40, 45, not yet diagnosed. So personally, I really encourage to do the genetic testing for FH in our region. For the patient in pregnancy, you know that we don't give the usual medications, that is the statin and the ezetimibe. In Oman, for pregnant, we have the LDL apheresis, and actually any patient with known homozygous FH who was, she's already on LDL apheresis, we really continued, and we did actually, we published one paper in one homozygous FH pregnant. It was her 4th pregnancy. She was the age of 40. So we said, no, she is a very high risk, then we have to continue the LDL apheresis, and we continued until the week 36 weeks of gestation. It was very, very safe. However, it was multidisciplinary approach. We have actually the cardiovascular surgeon, we have the high risk obstetrician, the lipidologist, together treating those individuals. So that's really the treatment what we use. But then I think Prof. Ray can also comment on PCSK9 in pregnancy.
So for homozygous FH, essentially with all of these therapies, you're using clinical discretion. So I know that, for example, we've seen people around the world essentially after the first trimester, potentially now, because their cholesterol levels are so high and they've got a history of atherosclerotic cardiovascular disease, the homozygous patients actually using MABs. These are large drugs and they are less likely to cross the placenta. So basically, with that in mind, having explained risks to patients, that has been something that's been done. For heterozygous FH, going back to something that Khalid said, it's absolutely important to get the genetics right. And the reason is it's so easy, the costs are coming down. The more we use it, the more the costs will come down. It's a genetic disease. Your whole thought process and management will change considerably. At the moment, we are getting the 1800 variations for FH. What we should be doing is any patient with an elevated cholesterol is looking at autosomal dominant familial hypercholesterolemia, and also the polygenic score, and also LPA, because you're going to find a mixture of these three. Now, your approach is very different. Telling a patient that they've got FH means that you can start thinking about their kids earlier. And if you find their kids earlier, you don't need 4 or 5 drugs. We generally need more drugs later on because we've missed half of their lives already. That's the problem. So you can start with cheaper, commonly available, they've all been tested in kids, and move forward. And if needed, add in other things. The thing about women in particular is we know there's a period of time that they will not be exposed to statins because they're trying to conceive or they're breastfeeding. And that was one of the questions that was asked. So what you're buying is a legacy effect of early treatment to basically not worry during those 2 years. And if somebody wants to have multiple pregnancies, for example, with good counseling, you can say, stop the breastfeeding. When you're ready, put you back onto statins. Should you become pregnant, we stop it immediately. But before you actively start, let me know, and then we'll make sure we stop the medications a good month or so before. So it's just basically good communication, in that regard.
Yeah, and may I add something about the genetic testing? And I think it's very important. It's gaining a lot of interest right now, especially in this region, given the high consanguinity rate. It's very important to consider that. And having the Gulf FH registry right now with the excellent pool of data that we are gathering from our patients, we are reaching now to this phase 3 of the study of the registry, where we're going to be doing the genetic testing. And it's very important to understand sort of the prevalent genetic mutations pertaining to FH. And like Professor Ray said, this is like the future for, target specific therapies in the near future. So let's say I would know that this particular sort of genetic mutation that I have, and you would have sort of a directed therapy in the future. So for the children, for the new generations to come, even though it's not a must, keeping in mind some of you are in clinical practice, you might have difficulty in accessing genetic labs, or it might be sort of a financial burden for some of the patients, not covered by insurance or not covered by the government. All these factors need to keep into consideration, but having the genetic testing would add to the confirmation sort of the diagnosis and for the future perspective of therapy.
If I can add as well, I mean, so most of my useful ideas I get from seeing patients and clinical problems and dilemmas. And, you know, recently there were at least 2 patients who were in their 20s. And, you know, we've got into the habit of doing quite a lot of genetic testing, and certainly they were below the threshold, but it was just their family history and everything else. And even though their LDL was below 4.9, and I've been surprised, there are at least 2 with LDLs of about 4.2, but with an LDL receptor mutation, you know, that's been picked up. And this is the impact of age. So, I mean, everybody here on the screen at the moment is involved with the FH Studies collaboration, and we'll have the genetic data cleaned, hopefully by the end of this year. So one of the things I'm hoping that we will do is actually be able to reclassify, because one of the things I'm not happy with, and I think is wrong, is basically the Dutch lipid network criteria has to be recalibrated for age and gender. That was great when it was done. The reason I say that is if you look at our data for women and men, women, by virtue of the fact that there are other factors as well that may be protective, will have less cardiovascular disease. So think about this. So if I have a man with FH, genotype positive, I could potentially have their child, their offspring, with lower cholesterol levels, you know, because they're in their 20s. If I just go on cholesterol and don't genotype that patient's got a 50% chance of being a carrier and actually being affected later on in life. Because of the inherent nature of lifespan, gender, and protection, that person may, you know, end up developing cardiovascular disease later in life. So that thinking, that trigger of could this be FH may well be missed, and cholesterol levels have crept up. And that person's had 3 children. She's passed on those genes, and let's say they're all male. So now in that situation, because I've missed her, I'm going to miss the chance in 3 grandchildren. And that is why genetic testing for hypercholesterolemia is absolutely essential. You know, we can get to not 0 risk, but we can actually get to almost 100% prediction if we actually just follow this through. We need one approach for those people alive and around that we've missed. They're walking around in their 40s, 50s, and we need a different approach for those yet to be born or those that are early in their life course.
Yes. Great. Great discussion. And I think this is needed, the family planning and family trees, and this is need lots of support, especially I think from governments, because the tests are very expensive, as Dr. Nasreen said. I think we're going to conclude our session today. Thank you, Dr. Ray, Khalid, and Nasreen, for your interesting and very excellent session. And we're sorry to miss Dr. Kaplan. So we're going to move on to the next session. Thank you for being with us. Thank Dr. Abdullah, my co-chair, and thank you for involving us tonight, and see you later.
Okay, good evening, ladies and gentlemen. Over the next 15 minutes, I'm going really to discuss another important aspect in cardiovascular disease prevention and reappraisal of the available evidence. These are my disclosures, my disclaimer, and this is the outline of my presentation. So I'll start by quick introduction, reviewing the data in relation to cardiovascular disease, and then I'll review the existing cardiovascular outcome studies, totality of the evidence in relation to all emerging therapies. And then I'll specifically home on pioglitazone in terms of its efficacy, in terms of cardiovascular disease prevention, before I conclude the presentation. So from the epidemiological aspects, if we look at, this is the data from the risk factor collaboration group, we can see to the left that a man who's aged 40 with a newly diagnosed type 2 diabetes and without any cardiovascular disease at baseline, they will, the years of life lost will be approximately 6 to 7 years. Half of it is thanks to cardiovascular disease. And if we look to the right, women are not immune. They have, again, the same risk of cardiovascular disease. And we know very well, and we understood it now, that by the time women develop type 2 diabetes, they will lose the protection which is conferred by their gender. And therefore, it's very important that they are subjected to the same intensive preventive measures as their men, as men. And this is the data from the Swedish registry, and what it shows is really controlling 5 risk factors. These are blood pressure, lipids, HbA1c, albuminuria, and smoking. And we can see that as we control more risk factors, if you go from bottom to top, the more risk factors you control, the less is the risk of, in this setting, myocardial infarction. And if you control all the 5 risk factors, then really we render the risk similar to somebody without diabetes. So that's something which came from the Swedish registry, underscoring the importance of stringent control of all risk factors. What's worrying, however, is that although we are seeing decrease over the years when it comes to trends, decrease in mortality, cardiovascular disease, cardiovascular death, but the gap between people without diabetes in red and people with diabetes in blue remains wide. If anything, if we look to the far right, this will give us the impression that the gap is getting wider. Again, really raising the question about the level of intervention that we are offering our patients and the need for really more therapies with which will reduce the cardiovascular risk. Now let's look at the totality of the evidence. And if you look at the data from DPP-4 inhibitors, we all know that they don't reduce cardiovascular risk. So we have the data from saxagliptin, allogliptin, sitagliptin, and linagliptin. Linagliptin was in the cardiovascular outcome trials was compared to a placebo and was compared to glamipiride. Both of these studies showed cardiovascular neutrality. And then if we move to SGLT2 inhibitors, we saw from the data from the MPREG reduction in the MACE, with the similar thing we saw with the in the Canvas program, but we didn't see it really with the in the DECLARE TIMI, largely reflecting the fact that the biggest proportion of patients in this study, 60% were primary prevention, and reduction in MACE was not evident in those populations. And then if we look at the data from articulofloxacin, again, we saw that although it had a population similar to the MPREG, there was no reduction in the 3-point MACE, again raising the question as to whether SGLT2 inhibitors are not the same. But having said that, also reinforcing maybe the notion that their main effect is on heart failure and progression of kidney disease. And we know very well from the data that their effect in terms of modulation of atherosclerosis is at best minimal. And then if we look at the GLP receptor agonist therapy, again, pooled data indicate cardiovascular benefit. However, that does not apply to all the agents. So we saw positive studies with sustained 6 with semaglutide, with liraglutide, as well as with glutide. But what we also learned from the limited data is that when it came to secondary prevention, these therapies are do reduce the 3-point MACE, but although the studies really were not powered to look at primary prevention, when you pull the data, you will find that they don't have benefit in terms of 3-point MACE reduction in subjects without cardiovascular disease at baseline. This data did not apply to dulaglutide, where benefit was seen in a large cohort of a primary prevention population. So let's look at pioglitazone now in its efficacy data. We know that the two fundamental defects in type 2 are insulin resistance and beta cell dysfunction. And when it comes to insulin sensitizers, they exert their effect on the adipose tissues, on the muscle, and on the liver. At the level of the fat cells, they reduce lipolysis and enhance insulin-stimulated glucose transport. At the level of the muscle, they increase glucose uptake thanks to reduction in the lipolysis and the free fatty acids. And then at the level of the liver, they decrease gluconeogenesis, and because of that, they decrease the hepatic glucose hepatic glucose production. And if we look at and this is really a schema to look at the way the pioglitazone works. So primarily on PPAR gamma receptors at the adipose tissues. So they enhance the differentiation of the pre-adipocytes. They increase the free fatty acid intake, and because of that, they decrease the free fatty acids, and this results in improved glucose output uptake at the level of the liver, and this results in glucose lowering. They also have a direct effect on the liver, and they decrease the gluconeogenesis, which translates again into a reduction in glucose level. And then at the level of the adipose tissues, they increase the free fatty acid uptake, lipogenesis, and the adipose tissue proliferation and the subcutaneous tissue, and they also increase the glucose uptake. Efficacy-wise, they are very efficacious, and the data are showing HbA1c reduction in the magnitude of 1% or greater in most of the studies. So they're one of really the most efficacious therapies when it comes to glucose reduction. When it comes to the lipid panel, obviously they improve the atherogenic lipoprotein phenotype, so they decrease triglyceride, increase HDL, and this probably one of the mechanisms by which they exert their benefit. They also reduce systolic and diastolic blood pressure, and this has been replicated in many studies. Now let's look at the cardiovascular outcome trials with pioglitazone. We'll start with the famous trial, the proactive study, included more than 5,000 patients in 19 European countries. Patients randomized to pioglitazone or control groups. The primary composite endpoint was beside the 3-point MACE. It was also including some subjective endpoints which are no longer really included because they are so subjective. So amputation, revascularization were included, and this may have really skewed the data, as I'll show you in a few minutes. So patients with type 2 diabetes were included, in who have suboptimal glycemic control. Established cardiovascular disease, which is defined as one or more of the following: an event in the past, or an intervention including stent or CABG, ACS, or classic symptoms of peripheral vascular disease or amputation related to peripheral vascular disease. As I pointed out, their endpoints, the primary endpoint was not the classic that we see with the rest of the cardiovascular outcome trials. And I think people learned an important lesson at that time when they included subjective endpoints such as leg amputation. A surgeon may decide to amputate, another conservative surgeon may decide not to amputate. So that's really subjective. On contrast to a myocardial infarction is a myocardial infarction. So there are no two ways around it. So when it came to the primary endpoint of the composite of the 3-point MACE plus major amputation plus leg vascularization, there was 10% relative risk reduction, which did not achieve a statistical significance. But if we look 3D at the 3-point MACE, and this is really the outcome which is now examined in all cardiovascular outcome trials, GLP receptor agonists, SGLT2 inhibitors, and DB4 inhibitors, we can see that pioglitazone resulted in, and I must say, obviously, this is a nominal p-value, but there was 16% relative risk reduction in the 3-point MACE with a p-value of 0.027. And this effect was maintained throughout the study. Patient in pioglitazone, they had a reduced hard endpoints compared to the control groups. Sub-analysis was done to look at the impact of treatment with pioglitazone on in patients with pre-existing or previous myocardial infarction. And what we saw is that when we look at the fatal and non-fatal MI, there was significant risk reduction of 28% in subject who sustained a previous MI. And we look at the ACS, where there was 37% relative risk reduction with a nominal p-value of 0.035. Another sub-analysis was done looking at the strokes, and again, in people with previous stroke, and we saw a 47% relative risk reduction in subsequent stroke with a p-value of 0.008. So in patients with a previous MI, there was a reduction in subsequent MIs with a relative risk reduction of 28%. There was also 48% relative risk reduction in subsequent stroke in patients who had a previous stroke. Data which is indeed very impressive. A number of factors which were advanced that brought about the benefit, including really anti-inflammation, increase adiponectin, decrease in intermittent thickness, improvement in blood pressure, lipids, and albumin, urea, and reduction in the visceral fat. There was increase in heart failure, so there was an imbalance. However, when investigators looked at fatal heart failure, there was no imbalance and no difference in fatal heart failure. There was a suggestion that perhaps there may be an increase in bladder cancer, but when they excluded the events which were observed in the first year, there was no significant difference in bladder cancer, but the FDA mandated a 10-year observational data, and I'm going to share that with you shortly. Pioglitazone was also looked at in patients with insulin resistance, including patients with prediabetes in the IRIS, a more recent IRIS study in patients who sustained a previous ischemic stroke or TIA. And what the investigators demonstrated, a 24% relative risk reduction in fatal, non-fatal strokes and fatal and non-fatal MI in this group of insulin-resistant patients. Beside having significant reduction in the primary endpoint, it's worth noting that there was a significant reduction in the risk of diabetes in these pre-diabetic cohort. Bone fracture was noted, similar to the what has been seen previously, and the suggestion with this regard and the recommendations, obviously, patients at high risk, including women, mainly women who have osteoporosis, established osteoporosis, should avoid these agents, and one really should carry on with the screening in the usual manner recommended by the guidelines. With heart failure, this study excluded patients with heart failure at enrollment, and with that, there was no really increase in the risk of heart failure in the IRIS study. So the IRIS study really confirmed what we knew before from the data of the proactive study in terms of reduction in major cardiovascular events. Barry 2D study, again, although it was negative study, but when it came to revascularization in the whole cohort, there was a reduction, as you can see there, 20% versus 25% in the controls. And when you look at the CABG stratum, again, there was a reduction in revascularization in the group who received pioglitazone. Again, consistent with the findings from
Dr. Tariq, for the time, please. Thank you.
Okay, from the proactive study. And finally, this is the registry from the Kaiser Permanente. And again, that registry showed that there was no increase in the risk of bladder cancer. And this was very reassuring indeed. Positive effect on all parameters of NASH. Because of time, I'm not going to go into details of that, but pioglitazone improved really all the outcomes of NASH. So, ladies and gentlemen, to conclude the presentation, insulin resistance is linked both epidemiologically and pathophysiologically with cardiovascular disease. In the IRIS, pioglitazone reduced the risk of fatal and non-fatal MI in patients with insulin resistance. Pioglitazone is the only oral glucose-lowering agent to reduce atherosclerotic events. Pioglitazone is also the only drug to prevent diabetes and improve atherosclerotic cardiovascular disease in the same trial. Pioglitazone appears to have potent beneficial effect in NASH, including histological changes. There are, of course, some concerns with regard to weight gain, which is limited, but obviously it can be reduced by giving a smaller dose. The water retention, heart failure, so we should avoid in patients with heart failure, bone fracture. So again, clinical acumen dictate avoiding it in patients with established atherosclerosis. And when it came to bladder cancer, the proof really has been questioned. And therefore, based on this, the role of this drug needs really reappraisal and reassessment in the treatment of patients with type 2 diabetes, especially in those with cardiovascular disease. Thank you very much for your attention. I cannot see any questions in the box. So if there are no questions, I'll hand over to the next speaker. Thank you.
Thank you very much, Dr. Tariq.
Dear colleagues, greetings from Hamburg, Germany, and it's an honor for me to speak at the annual Congress of Gulf Association of Endocrinology and Diabetes. The topic is clinical manifestation and burden of HPP disease. So what you can see here is the burden of disease of HPP. You can see femur fracture, you see a pseudofracture of the femur. You see a patient who has problems with the mobility because of muscle weakness and muscle pain, and also tooth loss and teeth loss is a very big problem in HPP, also like joint pain and joint calcification. So this burden of disease is caused by mutation in the alkaline phosphatase gene, and we will talk about the pathophysiology of HPP right now. So the normal mineralization is done by alkaline phosphatase, and you can see in the upper right corner that the normal mineralization process is going on here, where you see the black mineral deposits on the collagen fibers. The disturbed mineralization, you can see it here, leads to an increase of osteoid. And osteoid makes the bone softer and prone for fractures. The normal physiology of alkaline phosphatase is to cleave the specific substrates like pyrophosphate, inorganic pyrophosphate. But if a mutation in the alkaline phosphatase gene leads to a impairment of the enzyme, then specific substrates accumulate in the body like inorganic pyrophosphate. And the consequence of the substrate accumulation is a impaired mineralization, as inorganic pyrophosphate reduces also the calcium phosphate integration and is a direct inhibitor of mineralization. Also, the muscle and joint pain is caused by the pyrophosphate accumulation, and also nephrocalcinosis occurs in HPP. So these are the systemic consequences of a low alkaline phosphatase. Elevated PLP, which is not able to cross the blood-brain barrier in its phosphorylated form, leads to an intracellular deficiency in the CNS and can lead to seizures. The increase of inorganic pyrophosphate blocks normal mineralization of bone and teeth and can also lead to respiratory symptoms because of a softening of the thorax. PEA is just a diagnostic marker for HPP and does not lead to any symptoms. So hypophosphatasia can be separated in different forms. A recent classification done by Mornay in 2021 separates three forms: a severe form, a moderate form, and a mild form with an incidence of 1 to 508. The older classification knows 5 forms: the perinatal, infantile, childhood, adult, and odontohypophosphatasia form of HPP. All forms together or have muscle, bone, and joint pain, impaired bone and teeth mineralization. And there are more than 400 known mutations in the ALPL gene. So in our cohort, we have seen patients with specific biochemical and clinical characteristics. And we have seen that more than 40% have a history of peripheral fractures, and more than 16% have a history also of spine fractures. But also cephalgia and tooth loss was very common within 1/3 of the patients. If you take a look into the bone microarchitecture of HPP patients, you can find specific alterations of bone quality. Using HRPQCT technique, we found that HPP patients with fractures have a thinner trabeculae, have a thinner corticalis, and also the trabecular mineralization is impaired. But furthermore, a very interesting finding was that the PLP level is a hallmark criterion for the severeness of the illness. So the higher the PLP level is, the more fractures the patient have and the more HPP symptoms the patients have. So PLP is a very important marker for HPP together with alkaline phosphatase. So low alkaline phosphatase in hypophosphatasia is also a hallmark criterion, and if adults have a AP level lower than 40 units per liter, they are suspicious for HPP. But one has to take into account that there are differences in the AP level between male and female, and also differences in the different age groups. So for example, a 10-year-old boy with an AP level of 120 is suspicious for HPP. But there are also other causes of low AP levels, like Wilson's disease or celiac disease, or also starvation. And of course, a treatment with anti-resorptive drugs like denosumab or bisphosphonate can lead to a low LP level. So we want to look at the clinical manifestations of HPP. So in the childhood form, for example, you can see knock knees and also tooth loss, soft skull, and also chest deformities are a rachitic kind of bone disease. In the adult patients, there are muscle symptoms, muscle weakness, muscle pain, but also joint pain, which can come or which can be caused by chondrous calcinosis or calcification of tendons near the joint areas, like here at the elbow, for example, in the MRI and X-ray to be seen. Catherine Bergseth from Seattle has also checked her patients for the clinical characteristics, and she found that more than 40% had muscle and bone pain, more than 50% had a fracture history, and also chondral calcinosis and dental problems were seen very often. So as you can see, hypophosphatasia is not only a bone disease, it is a systemic disease, and teeth are affected, joints are affected, muscle are affected, bone and kidneys, and also the nervous system. Here's an example of the hypomineralization of the teeth. In the upper row, you can see the adult patients with the transparent teeth here, which resembles the mineralization defect of the teeth. And a hallmark criterion of pediatric onset is the loss of deciduous teeth before the age of 5, as you can see in the lower row. HPP can also be misdiagnosed, for example, as gout or pseudo-gout, but it can lead to severe arthritis, which can look like this in the upper photo here. And we want also to take a specific look at the diagnostic management of HPP, because this is very important. So as I said, a low AP level is very important to have a patient diagnosed for HPP. But if the patient has low AP, he also has to show elevated PLP levels so that the diagnosis goes into the direction of hypophosphatasia. And the ALP gene test is the proof of the disease. And if you have proven the disease, then the imaging techniques like MRI are very important, because if a patient has pain in the knees, for example, the MRI shows clearly, for example, bone edema or stress fracture much earlier than X-ray does. Also, bone densitometry and sonography are important imaging techniques in hypophosphatasia. Hypophosphatasia management is teamwork. You have to work together with other specialties like orthodontics, neurologists, neurosurgeons, and also eye specialists. And if you have diagnosed HPP, clinical and laboratory monitoring is essential, and also to check if in very severe cases enzyme therapy may be necessary. So to see the burden of HPP, we take a look at a patient which recovered the mineralization, or where we could show that the bone mineralization recovered under enzyme replacement therapy and that the quality of bone improved during treatment. This female patient was diagnosed for HPP at the age of 2 years, and then in 2006 she had a tibia fracture. And the problem was that the fracture, which was conservatively treated, did not heal. So a fracture healing disorder with a non-union was the status. And here you can see the teeth of the at this photo, 25-year-old female. And the leading symptoms were pain in both tibia, also general muscle and bone, joint pain, and muscle weakness. So here you see the problem, the bowing of the tibia, the pseudofracture, and we did the correction osteosynthesis in 2015. But the problem was that the bone did not heal, and furthermore, she developed pain in the opposite leg at the proximal tibia and also at the talus in the operate leg. And the MRI showed a beginning stress fracture and a bone edema in the proximal tibia, and the CT showed osteolytic cavities in the proximal tibia metaphysis, which is a sign for very high fracture risk. So this is why we decided to start her on an enzyme replacement therapy. But here you see the lab report before the start of the treatment: low AP, low bone ALP, and elevated PLP levels are classical laboratory signs for this HPP disease. And this is a magnification of the bone healing problem of the tibia and also the fibula, which had a non-union after intramedullary stabilization. So we started her on aspartame alpha, which is an enzyme replacement therapy with 1 milligram per kilogram body weight 6 times a week. And you see just after 3 days that the PLP level dropped significantly. And the follow-up showed that the PLP levels stayed low in the normal range, which shows the effect of the enzyme replacement therapy, and also the muscle function improved, the grip strength increased, and also the performance in the chair rising test increased in the patient under enzyme replacement therapy. Also, the bone edema and the beginning stress fractures vanished, as you can see here in the MRI of the left proximal tibia, and also the ankle joint, the talus on the right. The bone edema and stress fractures are gone. So if you take a closer look at the bone quality here in the histologic pictures, you can see here in the middle picture, this is the baseline picture of the bone quality, showing an increased level of osteoid, which makes the bone softer and prone to fractures. And after 2 years enzyme replacement, you see a significantly decreased area of osteoid, and the bone mineralization has improved significantly. Also, the bone problem was solved because we could see a healing of the fibula and tibia during enzyme replacement therapy. And this is the physiology behind those processes. It's a restoring of mineralization and a start of remodeling, because the problem in HPP is that inorganic pyrophosphate blocks mineralization, and the enzyme replacement therapy leads to an increase in mineralization because the PLP and also pyrophosphate levels drop, and then the osteoclasts can reattach to the mineralized surface and can start remodeling. So this is a simplified scheme here. HPP leads to increase of osteoid and leads to a disturbance of remodeling, and enzyme replacement therapy increases mineralization and decreases osteoid volume so that the osteoclasts can initiate remodeling and bone healing. So coming to the end, I will sum up that HPP is a systemic inheritable metabolic disorder which can cause severe impairment and is a potentially life-threatening disease. HPP is frequently misdiagnosed because of the clinical symptoms, which can be similar to rheumatoid arthritis, fibromyalgia, arthritis, or also osteomalacia, or even osteoporosis. So the low AP level, which is age-specific, is easy to confirm using routine blood tests, but nevertheless, age-specific reference values are often lacking. An early and correct diagnosis is an important requirement for a good clinical management, and possible enzyme replacement therapy for children to treat the bone manifestation of the disease in severe cases is available. So thank you very much for your attention and have a nice day.
Okay, good evening, everybody. It's my duty to give you a talk in relation to metformin extended release, glucophage XR. This lecture is sponsored by Merck. And as we know, pre-diabetes and diabetes worldwide are extremely common. Here in Dubai, the prevalence of type 2 diabetes is somewhere between the range of 15 to 20%. With respect to pre-diabetes in adults, we're talking somewhere between 15 and 25%. And quite worryingly, in the youth who are overweight or obese, the range is also about 5 to 20%. We know that most of the people we see with prediabetes and type 2 have got associated obesity, and we generally use the term diabesity. We know that prediabetes and type 2 diabetes are both major risk factors for cardiovascular disease and also microvascular complications. And we also know that we need individualized, patient-centered strategies to really address the public health pandemic, really, of prediabetes and type 2 diabetes. Now, the guidelines from the American Diabetes Association have clearly focused, like all professional groups, on patient-centered care, shared decision-making, individualized treatment strategies and goals, and the use of lifestyle measures, including medical nutrition therapy and exercise, right from the get-go. In addition, they also recommend that metformin should be the first-line therapy that in the majority of our patients should be used really from diagnosis. The reason why metformin was chosen to be used right from the initial diagnosis is based on the clinical effectiveness, the real-world effectiveness of this agent, the great safety tolerability profile, and extensive clinical experience. These metformin drug has been used since the 1950s in Europe and since the early 1990s in the US. What do we know about metformin? It's an insulin sensitizer in as much as it decreases hepatic glucose production, reducing gluconeogenesis, and decreasing that fasting glucose. And it also works peripherally to improve insulin-mediated glucose uptake in predominantly skeletal muscle, but also adipocytes. We also know more recently that it has an incretin effect, increasing GLP-1 levels to about the same degree that DPP-4 inhibitors actually increase GLP-1 levels. With respect to both efficacy, which is what you see in clinical studies, and effectiveness, which is what you see in the real world, it's ideal really to try and use the maximum tolerated dose, usually up to about 2,000 milligrams per day. If that is achieved, then you can anticipate having very robust reductions in both fasting glucose and also HbA1c of the order of 1 to 2%. There's some other beneficial effects. One, you don't really get any weight gain, and you can actually get modest weight loss. And in one of the big diabetes, pre-diabetes studies, over 15 years, there was about 2.5 to 4 kilogram weight loss. So that's very encouraging. You also don't get hypoglycemia, and there's many other putative benefits, including cardiovascular disease reduction, which was seen in the UK PDS study. And the results showed both a reduction in myocardial infarction, any diabetes-related endpoint, including death, and all-cause mortality. And this was seen in the specific cohorts that were overweight. And that was defined as a BMI of 25, or in those days, way back when, it was 120%. With respect to that study, the UK PDS, this is just drilling down a little bit more on the initial intervention results after 20 years, and also the kind of observational study, which was a further 10 years. And you can see that the metformin group in those overweight population really had tremendous effects, which were very durable. And all of the results in the observational study were highly statistically significant. And we have this kind of dose effect study from the late and great Alan Garber, which showed that the higher the dose, the better the glycemic reduction. And if we can try and achieve that dose of 2,000 milligrams a day, then we can expect that 2% A1C reduction. And this is just a study which was observational in just over 3,000 patients who had newly diagnosed type 2 diabetes. And when you look at the overall cohort, you can see that 7 out of 10 of them got an A1C below 7%. And if you look even in that group which had a very high baseline A1C greater than 9, 60% actually got below 7% in addition to lifestyle treatment. And if we look at other oral agents, which are the usual methodology of initiating treatment in type 2 diabetes, you can see that both metformin and sulfonylureas have got by far the best glucose lowering capacity. The advantage for metformin over SUs is that it's much more durable. As I've just shown you, the results over many years with respect to weight loss and also some of those complications is really excellent. If you look at TZDs, which are not widely used these days, you can anticipate up to about 1.4% A1C reduction. SGLT2s, it really depends on the baseline kidney function, and DPP-4 inhibitors, as we know, you're really going to get probably about a 0.5% A1C reduction. What about the adverse effects of metformin? So we know that we have to be somewhat careful in people with chronic kidney disease, and this is a very common association of diabetes. And when we get to the stage of an eGFR less than 45, then we really need to be careful if we're going to initiate it. And we also need to be careful with the dose. So we have to decrease the dose usually to about 500 milligrams or something like that. Once the eGFR gets below 30, then strictly speaking, it's contraindicated. The major concern historically has always been the risk of lactic acidosis, and this is very rare. And if the metformin is properly prescribed and there's really no other complicating factors like acute kidney injury or cardiorespiratory failure, then this really shouldn't happen. With respect to B12 deficiency, this occurs possibly in about 7% or thereabouts. And it's a good idea to check the levels every 2 or 3 years, but especially if the patient has got neuropathy or unexplained anemia. The major baggage associated with biguanide agents, of which metformin is one, is the gastrointestinal side effects. And this occurs in somewhere between 15 and 20% of patients. And when using the immediate release formulation, about 10% of patients can never tolerate it. One way that we can risk mitigate that is by starting low and going slow. So starting with 500 of the immediate release formulation with the main meal, and then after a week or so, depending on tolerability, increasing to 1,000, and then eventually 1,500, and then up to 2,000. Alternatively, we can use the metformin extended release formulation, Glucophage XR, which has got a much lower risk of GI side effects. In addition, if one of your patients is on the immediate release metformin formulation and has GI side effects, then you can switch to metformin XR. The reason why the extended release formulation has got such a good GI profile is that you get delayed absorption, but while still maintaining excellent systemic exposure to metformin. The way that it does that is by this gel shield technology, where the outer polymer swells due to hydration once it's in the gut, and the metformin must penetrate that outer gel to be released. And you can see the profile in blue of immediate release formulation, which is given twice a day, usually. Sometimes it's given 3 times a day. But on this particular pharmacokinetic study, you can see that the XR formulation in red, you get a much higher Cmax, but the area under the curve is exactly the same as you would get with the twice daily immediate release formulation. And therefore you can anticipate getting the same efficacy and effectiveness with respect to reducing glucose measurements, whether it's fasting or A1C, but you also get less side effects. And you can see here on the left in red that you get a 50% decrease in GI side effects in metformin naive patients in the first year of therapy. And you can see particularly troublesome is diarrhea, and you get a 75% reduction when you use the extended release formulation in comparison with the immediate release formulation. Now, how do we use it? In metformin naive patients, again, you would go low and go slow, and you would build up gradually to about 1,500 milligrams a day or 2,000 milligrams a day. And that is for the pre-diabetes indication. With respect to diabetes, I've already mentioned that if you can get people to 2,000 milligrams a day, then that would give the maximum benefit. And if your patient is already on immediate release metformin, then you can actually easily convert to once daily administration of the extended release formulation. And there's various different combinations, which you can see there, which equates to the immediate release dose. And we give it with the main meal of the day. Let's just turn now to pre-diabetes. So I've really said that the gold standard treatment from the get-go is metformin if it's not contraindicated and it's tolerated. With respect to pre-diabetes, you can see that we know that our patients are overweight, obese, many of them, they have associated insulin resistance, and you get this so-called Starling law of the pancreas, whereby in order to compensate for the increased insulin resistance, you get increased beta cell secretion, but eventually over time that fails, and then that leads to perturbations in the glucose levels. And initially, you get a postprandial increase in glucose, and that is due to the loss of the first phase insulin secretion. And you can see initially it will go through the pre-diabetic threshold and eventually type 2 diabetes threshold. And then thereafter, you get increases in fasting glucose typically, again, going through the pre-diabetes category and then potentially convert into type 2 diabetes. And what we know about insulin resistance and associated overweight obesity, especially central adiposity, is that this is a key pathophysiological association of the metabolic syndrome. And the metabolic syndrome are really this aggregation of risk factors in a given individual, which can lead to increased cardiovascular disease, as well as type 2 diabetes. Not only do you have increased macrovascular risk in this association, but you get increased non-alcoholic fatty liver disease, and cancer also is much more prevalent, and maybe between 10 and 12 different cancers are strongly associated with overweight obesity and the metabolic syndrome and type 2 diabetes. The risk for microvascular disease really is all about glucose. So I guess what was surprising is that in the diabetes prevention program and many other studies subsequently, is that even in that pre-diabetic range, there was an increased risk of microvascular disease, which is very, very tightly associated with glucose increases. And what we can see in the box on the left-hand side is that if we want to reduce these complications, then we really need to kind of intervene early on in the natural history. And you can see that red line is the kind of time between the diagnosis of prediabetes by IFG category through to when it transforms into type 2 diabetes. And it can take 5-10 years, sometimes quicker and sometimes longer. So that gives you time to intervene with appropriate lifestyle, but also with metformin, as I will share with you. Now, just going back to that microvascular risk in prediabetes, in this study, you can see polyneuropathy occurs in about 7.4% of normal glucose tolerance individuals and is higher in both IGT and IFG category. When you think about diabetic retinopathy, this is uniquely related to diabetes. It's not seen in any other disease state. And you see exactly the same sort of pattern. About 10% of people with prediabetes have got microvascular complications. 10 years ago now, I worked at the Joslin Diabetes Center, and I just said, look, in an ideal world, these high-risk people with both metabolic syndrome, prediabetes, should have an intervention to stop progression to full-blown diabetes and all those various complications that I mentioned. At that time, just 11 years ago, 57 million people in the US had prediabetes, and you can see just a year ago, that has increased to 90 million, or 1 in 3 adults. So this is a huge public health problem, as I mentioned. When we follow people with prediabetes, about 5 to 15% will annually convert to diabetes. Certain groups, especially those with previous gestational diabetes, those patients with both IGT and IFG, those with a positive family history of diabetes, and those who have a high pre-diabetic range A1C or fasting glucose, so maybe between 6.1 and 6.4% A1C, and 110 to 125 IFG, have a much higher likelihood of converting. The DPP study was performed at the NIH in the US. I was working at the NIH in Phoenix at the time. And this study was compared to placebo, and it had 2 active groups. One was intensive lifestyle, which was really focusing on diet and weight loss, about 7%, and increasing exercise, 150 minutes a week, compared with metformin 850 BID. And you can see that the best reduction was with intensive lifestyle, but there was a statistically good decrease in the metformin group compared to the placebo arm. And this study has now been again followed in an observational way for 15 years. And the reductions are still there, but they're not quite so great. And the difference between the lifestyle group and metformin are not so wide. So that's kind of interesting. And it's interesting because when you drill down a bit, even in that initial study, you can see that some people with prediabetes, IGT category, actually had even better reductions in conversion rate. So those who were obese, those women with a history of gestational diabetes, those with the high fasting glucose, as I mentioned, and the younger all did much better with metformin compared to the group overall. And if you look at a meta-analysis across most of the studies which have been published with respect to the role of metformin in prediabetes, there's about a 40% reduction. So that's really pretty encouraging. And again, I wrote this paper with a colleague from the NIH, Rich Prattley, and we said even 10 years ago that metformin should be considered first because of its favorable overall profile. And now we know that glucophage XR is the only approved medication for the prevention of diabetes globally. And it's been really supported by many professional groups, such as the one in the NICE in the UK, as well as the Emirate Diabetes Society here in the UAE. And you can see that the way that they really approach it is that you diagnose prediabetes, you intervene with lifestyle. If after 6 months you really don't get any benefit, then metformin should be added to the treatment. And just to conclude, so metformin is the current gold standard treatment for both monotherapy and combination therapy of type 2 diabetes, and that's supported by all the professional groups really around the world. You really need to up-titrate the dose to get to the treatment target, which is between 1,500 and 2,000 milligrams per day. And with that dose, you're going to have a low risk of side effects, and you're going to get a durable glycemic effect. And metformin, even when you add additional treatment, should be continued if the patient is tolerating it and no contraindications of a kind of evolved, like the kidney function, for example, has got worse. Glucophage XR provides once daily dosing, so that translates into better patient adherence and persistence, and reduction in GI side effects. And really this molecule is evolving, so the effect on cancer and all sorts of different putative benefits are really being explored as we speak. And glucophage XR is the only approved medication for the prevention of type 2 diabetes, exactly the same dose as diabetes. And this is why we kind of framed it as this diabetes continuum. We start it in the pre-diabetes phase and continue it through the natural history of diabetes. If the patient converts, then we can really improve adherence and tolerability because we're keeping it simple. And we can also get that legacy effect and metabolic memory. And I thank you, and I'll hand back to the conference chair. Thank you.
Right, so good evening, ladies and gentlemen. Welcome to this exciting session of Meet the Expert. We've lined up two great speakers for you, starting with a man who needs no introduction, Professor Andrew Bolton. I think most of you knows Professor Bolton, who is currently the IDF president, and as well as he's the president of Euradia. He is the past president of EASD. Professor Bolton graduated from Newcastle upon Tyne, and subsequently he trained in Sheffield and Miami prior to accepting appointment at Manchester University. He authored more than 550 high-indexed peer-reviewed manuscripts. His impact on diabetes, specifically diabetic foot disease and diabetic renal disease, is beyond me describing it, because everybody knows his imprint in this, and his interest in education as well is well known. He was the founding chairman of the Diabetic Food Study Group, as well as his previous previously the chairman of the postgraduate education, and then the honorary secretary of and the program chair of the ESD. Professor Bolton work in diabetes has been well recognized throughout the world. He received the ADA Roger Pecoraro lectureship, as well the Camillo Dolgi prize from ESD. He also received ADA Harold Rifkin Award for Distinguished International Service in Diabetes. And in 2012, he received the Georgetown Distinguished Achievement Award for Diabetic limb salvage. In 2015, he was recognized in Japan, in Nagoya in Japan, where he gave the lecture on diabetic complication at the Japan Society for Diabetes. And in 2017, he was the Banting Memorial Lecturer in Diabetes UK, and he also received the International Diabetes Endocrinologist Award of the Year from the American Association of Clinical Endocrinology. We are so privileged and very lucky to have him to talk to us about a very topical thing about diabetes and COVID-19. The floor is yours, Professor. Thank you.
Well, thank you very much for your generous introduction, Dr. Ismail. It's a pleasure to be with you the third day running at this conference, and I see that there's still a large number of people attending, which is very impressive on a Saturday evening. So I'll just start to remind you, not that you need reminding, about the global epidemic of diabetes. I can tell you that the next IDF Atlas will be launched in a couple of months, and sadly, the figures are going to be even higher, although I can't give you the actual figures because it's embargoed. But there are now more than 500 million people with diabetes across the world. And it's very high, particularly in countries who are listening to this session tonight. For example, my good friend Abdul Basit from Karachi showed that the prevalence of diabetes in adults in Pakistan is now above 26%, which is very worrying. And I fear that the same is probably true in India. An older study here from Egypt showing the prevalence of diabetes above 15.5% some 5 or 6 years ago. So we have a major problem. These data will soon be surpassed, as I said, by the 2021 IDF Atlas, but the predicted rises are very worrying, particularly, for example, in your region, Middle East and North Africa, and also in Sub-Saharan Africa. So we have a major problem. And even more so during the COVID pandemic, as I will show you, we really need to encourage good glycemic control, because those who do badly are those who don't have good glycemic control when they present with COVID infections, and those who have complications. This is my good friend and editor of Diabetes Care, Matt Riddle, and colleagues writing on really the world lessons for those with diabetes from the pandemic. This was written towards the end of last year. Diabetes, they concluded, was not shown to increase the likelihood of infection, but the progression to more severe disease was likely. Diabetes 2 to 3 times more common in those requiring intensive care treatment. And as I've already said, diabetes itself, obesity, late complications, and ethnicity are additive risk factors. So we need to continue to support vulnerable people, including those listed above. So I gave one of the Best of ADA meetings, that's the ADA in earlier this year, lectures on the year in review. And I was able to listen to these lectures, excellent lectures, and I've borrowed some of the slides with permission to talk firstly about the coronavirus and the beta cell. And this is from the lecture given by Maureen Gannon, a basic scientist working in experimental diabetes. So she started by reviewing a number of papers, and this one here was published last year from Xu Chen's group. All these groups are Americans, and they used a human pluripotent stem cell-based platform to look at, does the virus actually infect the beta cell? So these authors actually showed that beta cells can be infected, and there was increased expression of ACE protein receptor, And those infected beta cells generated cytokines. But of course, this was a cellular model and not from human pancreas. At about the same time, Al Power's group in cell metabolism couldn't actually confirm those findings. And this was using sections from human pancreas. So this was actually human pancreas, and they could not find increased expression of the A2 in tissue sections. And a subsequent study from Mark Atkinson's group in Florida supported the data from Al Power's group. And they showed that ACE2 protein receptor was not expressed in beta cells, but was expressed, for example, in the pancreatic ducts and the microvasculature. But then another paper, a follow-up paper by, again, Shubin Chen's group, again from the USA, this time in his group, this was from human pancreas, from autopsies. So they were able to detect the antigen in samples of beta cells and suggested that this leads to beta cell transdifferentiation and inflammation. So I would say now that the jury is out on whether there is a direct infection of the beta cells. And I would draw you to this nice review in Nature towards the end of last year, really discussing the evidence. And they were leaning to the fact that coronavirus might indeed trigger diabetes by these mechanisms. Now, it was then my good friend Will Cefalu, who used to be editor of Diabetes Care, and I'm a senior associate editor on there, so I've worked with Will and Matt Riddle, and Will is now director of NIDDK at the NIH in Washington. So he talked about translational advances, and I'm going to return to COVID and his discussion there. But of course, he started by remembering that this is 100 years since the discovery of insulin. And indeed, it was this month, November 1921, that the first dogs to receive insulin were shown they actually survived. And of course, there have been a lot of important discoveries in the second half of the last century. Many of you will remember the early studies of HbA1c, and this was only been available really for the last 40 years. In my first diabetic clinics, all we had was urinalysis and a random blood sugar. And then, of course, we had the DCCT, and this is looking at the US studies, of course. And then we had the DPP, you've heard of in the last talk. Of course, the studies from Finland, and Jaakko Toimalito and colleagues preceded this, but showed very similar results. And most recently, we have potential treatments to prevent those at very high risk going on to develop type 1 diabetes. But he also discussed COVID-19 and diabetes. And I'll just talk about one paper from the UK that he reviewed. And this was post-COVID syndromes in individuals admitted to hospital with COVID-19. This was a retrospective cohort study from last year, published this year. So in this study, this was at all NHS hospitals in England. The authors quantified rates of organ-specific dysfunction in those individuals with COVID-19 after discharge from hospital and compared with a matched control group from the general population. So this was a large number of patients, but again, a retrospective cohort review, so that has its limitations. But nearly 87,000 people in hospital during the study period in 2020. About 10,000 of those were admitted to ICU and 76,000 were not. And of course, they were looking at people post-discharge, so they had to exclude, obviously, people who didn't survive, and there were other reasons for exclusions. But it's still a large cohort that was reviewed, just under 48,000 patients. And what they showed here was, if you look at those with diabetes, they were much more likely to have adverse events after discharge, but more interestingly, perhaps, those without diabetes were more likely to develop diabetes as a new onset event. So this study suggested that post-discharge event rates were greatest for those with diabetes and other people with major adverse cardiovascular event history. Compared to similar individuals from the general population, those discharged COVID patients had elevated rates of diabetes, cardiovascular disease, and liver disease. This cannot show cause because it's a retrospective study, but they do suggest that there might be a significant statistical association that warrants further investigation. So let's look at some of the studies over the last year. And here's a study from NHS England that was published in May, online, May last year. And this was a large study, a population cohort study of persons with diabetes registered in primary care in the UK. And the prevalence of diabetes amongst these 61 million individuals was 5%, 1 in 20. Of course, the vast majority were type 2. But of the 23,800 COVID-related deaths until May last year, 1 in 3 occurred in people with diabetes. 31% of all deaths were in those with type 2 diabetes and 1.5% in those with type 1. And there are the crude mortality rates, as you see, much higher compared with those without diabetes. Then they adjusted for age, sex, ethnicity, and deprivation and location. The odds of dying were still much statistically increased in people with both type 1 and type 2 diabetes. So further adjustment did attenuate somewhat, but still highly significantly increased risk. So diabetes shown clearly in this study, independently associated with an increased risk of in-hospital death. A study from New York published in the BMJ around the same time. This was a retrospective electronic medical record chart review, 6 weeks from March, which was corresponded to the first lockdown in the UK. Of 1,000 patients seen at Columbia Hospital in New York, 850 were admitted and 236 required ICU treatment.
As you can see,
obesity and hypertension were common, especially in those going to ICU. So these are the same in the USA and in the UK, adverse outcomes related, of course, to ICU admissions and other comorbidities. There were some nice reviews by Liz Selvin, who is an epidemiologist at Johns Hopkins in Baltimore, in diabetes care towards the end of last year. And some questions were asked. First of all, is diabetes itself a risk factor for, sorry, that should be for, not or, COVID-19? Certain infections, of course, we know are more common in diabetes, but she couldn't conclude that diabetes itself was a direct risk factor for COVID-19 infection, as pointed out by Riddle in the paper I reviewed earlier. But inequities in healthcare, poverty, poor housing, ethnicity, etc., might contribute to this perception. In the same paper, she asked, does diabetes independently contribute to poorer outcomes in hospital? Of course, diabetes occurs in older people and more likely to have comorbidities. And they said, she concluded that there's no definite evidence to support that diabetes itself leads to poorer outcomes, but other associated factors, obesity, hypertension, cardiovascular disease, renal complications, may be driving worse outcomes, hence the higher mortality in diabetes. And she also questioned the role of obesity. And she concluded there was indeed evidence that obesity is an important risk factor for progression and death. This may relate to ventilation, the obese patient, of course, with reduced residual lung capacity. Obesity may play a direct role via inflammatory pathways or biological effects, for example, on epicardial adipose tissue. We don't know. What about the lessons for people with diabetes or for diabetes? And this is a review by Partha Carr from the UK. And he said we need to have parity of focus on all types of diabetes, and we mustn't forget diabetes during this pandemic, because these patients are undoubtedly, if they're hospitalized, of risk of poorer outcomes for the reasons we've discussed. Here is Fiona Godley, editor of the British Medical Journal, writing here in about the middle of last year, that they're saying that the pandemic has led to a neglect of many conditions. Cancer care and heart disease were brought out, but sadly not diabetes. And we certainly need, and I'm sure everywhere in the world, and the Emirates will be no exception, to really tackle the backlog of non-COVID treatments, and positive improvements must be maintained. Reduced bureaucracy has been thrust upon us because we had to act fast, video consultations and so on. Again, evidence came from studies, and sadly we in the UK cannot be proud of our record with COVID, one of the highest numbers per 100,000 in the developed world of cases, although our vaccination rates are now very high. And I'm pleased to say that I got my third shot of the booster just this week. But here was a trial of dexamethasone in severely ill ICU patients treated in the UK. And its potential could be used in managing the cytokine storm that occurs, we know, with severe COVID infection. And in those patients requiring oxygen or ventilation, this is a randomized trial of dexamethasone 6 milligrams daily for 10 days versus standard of care. A large number of centers. 2,000 patients approximately received dexamethasone, 4,000 standard of care. But for those on ventilators treated with dexamethasone, the death rate reduced from 40 to 28%. From those on oxygen and not on the ventilator, 25 to 20%. So look at this, the number needed to treat, so save one life, approximately 8. On oxygen, 20. And this is not an expensive drug. It costs the equivalent of about, what, 20, 25 dirhams a day, which is very low considering some of the drugs that are being used. And I couldn't help to be amused listening to our good friends Trump and Johnson asking if this drug was actually yet available in our countries, which entertained me a little. But I have to say those two gentlemen don't often entertain me. So here are some more recent studies. And in diabetes care, we've run a number of issues this year with bringing papers together on the COVID-19 and diabetes. Here's a study of early glycemic control after hospital admission in people with COVID-19. 548 patients, of whom just under 1 in 5 had diabetes, looking at daily fasting blood glucoses. 39% developed ARDS, 11% died. Those with higher mean fasting blood glucose were older in this week 1, longer inpatient stay, and an increased risk of severe illness and death. And higher blood glucose fluctuation was associated again with more severe disease and death. This is a smaller study because this was looking at continuous glucose monitoring. 35 patients with COVID-19 diabetes were monitored with CGM. And these authors looked at time in range, time above and time below range. And the time above range was associated with adverse outcomes, and time above, below range and higher coefficient of variation or fluctuation were also associated with poorer outcomes. Many lessons here. And here's a study looking at diabetes in obese overweight, again looking at the risk of adverse outcomes in COVID. 7,000 plus hospitalized patients with a multinational study, 65% were overweight or obese. The overweight were more likely to need oxygen and ventilation, but no increase in mortality. Diabetes, no increased risk of adverse outcome over BMI-related risk. But overweight, therefore, as well as obesity and diabetes, are associated with the need for respiratory support, but not in this study for mortality. Here's a national study, again, in one of these issues of diabetes care this year, looking at patients in the UK requiring critical care management. 19,000 admitted to intensive care. Again, 18% rather, type 2 diabetes with a 26% mortality. Type 2 diabetes in this study a risk factor for mortality and also associated with diabetes with younger age. So there are many threats to people with diabetes during this pandemic. Those who have had to shield, and this is a miserable existence during our lockdowns, people with diabetes were told, really stay at home. This leads to poorer diet, difficulties with exercise, poorer glycemic control. But not only that, the psychological impact is immense. These people became frightened of coming to hospitals, and therefore attendances at hospital-based clinics fell rapidly. So worried was I about this that I moved all my patients with diabetic complications that I see, mainly foot and neuropathy, away to a community clinic. And that increased the attendance at the clinics from about 50% to nearly 100%. So there's this psychological impact which adversely affects glycemic control, and poorer glycemic control leads to poorer outcome. We fear that there might be a tsunami of complications after this is over because of the poor control during this period of time. But we must also embrace the opportunities, the expansion of telemedicine, Digital education programs are available. Patients can look at these online. Improvement in inpatient diabetes services have been thrust upon us and redesigned. So there are threats. During the lockdowns, we had cancellation of all routine outpatient clinics. There might be problems with access to medicine and supply chains. Suspension of all routine investigations. We weren't allowed, even with patients with foot ulcers, to do a routine foot x-ray, for example. Suspension of all non-emergency surgery occurred during the lockdowns we have had, and transplant surgery, which is so important for those people with end-stage renal disease. The best treatment for diabetic nephropathy is prevention. The second best, if you've got it, is transplantation. So we could say there is a threat here of a double whammy. First of all, clinical research may swing back to infectious diseases and a loss of income for major diabetes associations, because people are more likely to give to cancer, to infectious diseases, to studies into COVID and so on. But also clinical diabetes care has been suffering throughout the pandemic, and this fear of hospital clinics leading to poor attendance. So there are threats and potential solutions, collaboration between stakeholders of major interests in non-communicable diseases, pharma partners. Increased global awareness of diabetes is so important as a life-threatening condition. And the message to our politicians, wherever we are, whatever nation we is that diabetes is so important and so potentially preventable if screened for in high-risk populations. So I'll end there and remind you again that we have our IDF Virtual Congress this December. Please do register and join it. We have a dedicated stream on COVID-19 and diabetes. We also have the launch on the first day of the IDF 10th edition of the Atlas and a symposium to celebrate 100 years of insulin. So with that, I say shukran, thank you very much.
Thank you very much, Professor Bolton, for this very informative and very nice presentation that carried many points to ponder about. Well, I'm sure this will generate many questions in the Q&A session. I'll be grateful if you could stick around for this session. Thank you very much. We'll now move to the second session. Professor Jason Gill, I think he's well known to me because of he'll be quite wondering because of BBC Two Horizon. He's sort of a TV celebrity in UK. Professor Gill is a cardiometabolic health professor in the Institute of Cardiovascular and Metabolic Science in the University of Glasgow in Scotland. He is professor of cardiometabolic health, and his interests centers around multidisciplinary approaches in research, leading a very active research group trying to investigate the effect of lifestyle on the prevention and management of vascular and metabolic diseases. His work includes studies into epidemiology of lifestyle and cardiometabolic diseases, risk, particularly why certain populations, certain ethnic groups are at high risk of cardiac disease. He was quite influential in the UK physical activity guidelines, NICE guidelines, SIGN guidelines as well. Being the past chair of the association, the British Association of Sport and Exercise Science, I'm sure he's well placed to talk to us about physical activity and health. How much is needed, and does one size fit all? Professor Gill, the floor is yours. I'm intrigued to hear.
Thank you for such a lovely introduction. I'm just going to try and share my screen. Are you seeing my screen now?
Absolutely. Fine.
Brilliant. Thank you very much. I'm delighted to be here to talk about one of my favorite topics, which is physical activity. And I've titled my talk "Physical Activity and Health: How much is needed and does one size fit all?" So we start off with the question: how much physical activity do we need to do? But I think when people ask that question, what they're often really asking is this question: how little physical activity can we get away with? And to do that, we need to look at the dose-response relationship for physical activity and risk of adverse health outcomes. So this is a slide with real data. I've taken the numbers off, showing data from a number of epidemiological studies, looking at risk of mortality on the y-axis and the amount of physical activity people do on the x-axis. And what you can see here is one of my roles is as writing physical activity guidelines. Where do you draw the line on that graph? There's no obvious single best amount of activity to do. And the point where we draw the line is about there. And that's the real data behind it. So what we've got here is risk of mortality and the amount of physical activity you do. And a few things to bear in mind is there's no minimum threshold for benefit. So from doing nothing to doing something, you actually get the biggest bang for your buck in terms of improving physical activity. And if you're up at this part of the dose-response relationship, if you're doing an hour of running a day and moving to 2 hours per day, you actually get a much smaller benefit. And so the guidelines are set at this level, about 150 minutes or more of moderate to vigorous physical activity per week. And that amount of physical activity gives you a hazard ratio for mortality of about 0.7, so about a 30% lower mortality risk. And that's what's reflected in physical activity guidelines around the world. I was involved in putting together the UK physical activity guidelines on the right. On the left are the World Health Organization guidelines, which came out last year. The numbers are actually exactly the same. It's the same underlying data people are looking at. But there are 3 components to the guideline, and I'm just going to talk about them briefly. So the first is undertaking at least 150 to 300 minutes per week of moderate intensity physical activity, or half the amount of vigorous. So 75 minutes to 150 minutes. So what does that mean? So broadly, moderate intensity physical activities are activities of 3 to 6 METs. 1 MET is resting metabolic rate. So if you're working at 3 MET, you're expending energy at 3 times the rate that you would expend it at rest. That is broadly equivalent to walking at a comfortable pace, so 4 kilometers an hour, 2.5 miles an hour or faster. And the broad rule of thumb for moderate intensity physical activity is if you're walking alongside with your friend, you can chat to them and hold a conversation, but you'd struggle to sing a song. Vigorous intensity activities are higher intensities, so more than 6 METs, more than 6 times resting metabolic rate, and you get to these intensities by walking uphill and running and things like that. And basically it's characterized by you'd struggle to hold a fluid conversation when you're working vigorously. So that's the part of the physical activity guidelines that most people know. What most people are less aware of is there's actually 2 other bits. So the first is doing muscle strengthening activities on at least 2 days of the week. And the third is to limit the amount of time you spend sitting down. And in my session yesterday, I talked about sitting down or sedentary behavior. So I'm not going to cover it today, but I'm going to talk about the aerobic activity and the muscle strengthening activity components of the guidelines now. So one of the things that we need to think about when we think about how much activity we need to do is how the data were collected. And what you find in the vast majority of the epidemiological data, like the first slide I showed you, looking at the dose-response relationship between physical activity and risk of adverse health outcomes such as mortality or type 2 diabetes or cardiovascular disease, were based on questionnaire, self-reported questionnaire data for people's physical activity levels. So you ask people in a moderately sophisticated way how physically active you are, and then people are followed up over time to look at their risk of adverse health outcomes. And what you find is if you ask people how physically active they are, you find that in the UK and US and a number of high-income countries, that about half of the population meet that component of the physical activity guidelines. But there's another way you can work out how physically active people are, and that's by using a device like an accelerometer. We all have them. So my watch at the moment counts my steps, so it can measure my body's movements. And you can get slightly more sophisticated devices that are accelerometer devices than the ones you'd buy in the shop, and you can use them to measure how much people are moving. And if you do that, what you find is less than 10% of the population meet guidelines. So half the population say they meet the guidelines, but when you actually directly measure how much physical activity people do, About 10% do. So the question is this a really big problem? So it might not be as big a problem as you might initially think. And I'm going to show you this with some data from a brilliant research fellow working with me called Carlos Celis Morales. So this is some work that he did in his PhD quite a long time ago. And what Carlos did in just over 300 people was he asked them how physically active they were using a questionnaire called the IPAC. This is the International Physical Activity Questionnaire. It's a well-used questionnaire. Don't worry about the units. Basically, as you move along, more is higher. And measured their physical activity using an accelerometer device. And these are all the points. And what you would see is if people did the amount of activity they said they did, all the points would lie along this line, this 45-degree line. And what you find is they don't. They lie on a lower line. But it's not that people over-report how much they do. They report doing more than they actually do. But there's also scatter here. So what we've got here is, it's not that everybody's over-reporting by a consistent amount. People are over-reporting by an inconsistent amount. And the knock-on effect of that is something called regression dilution bias. So it means that the ability to detect a relationship between physical activity and risk of health outcomes is diminished. And we can see this here from these data. So what we've got here is your plasma triglyceride concentration and the amount of physical activity you're doing on the x-axis. So people are divided into quartiles of physical activity. Q1 is the least active 25%, Q4 the most active 25%. And if we divide them into these quartiles of physical activity based on accelerometer measured physical activity, we get this nice dose response relationship in that the more activity you do, the lower your triglycerides, which is absolutely consistent with what we see in the lab when we do this under controlled conditions. However, when you measure physical activity by self-reported questionnaire, we don't see this relationship at all. There's no statistically significant relationship between the two. So what we find is that when we don't measure physical activity well, we diminish the apparent association between physical activity and health outcomes. So if we go back to the original data, what we see from the epidemiology from a questionnaire-based physical activity, 150 minutes per week of moderate intensity physical activity associated with a 30% lower risk of mortality, hazard ratio 0.7. And you get to the lowest possible risk of mortality doing about 500 minutes per week. And there you've got a hazard ratio of about 0.6, so a 40% lower risk. Now, in recent years, there have been data which come out which have used accelerometers to measure people's actual physical activity and looked at the association with risk of mortality. So this is a meta-analysis which was published in the BMJ in 2019 with Ulf Eklund as the lead author. And what you've got on the x-axis here is the amount of physical activity, accelerometer measured in minutes per day. Y-axis is mortality hazard ratio. And what we see here is to get to a hazard ratio of 0.7, this 30% lower risk. It's only 5 minutes per day or 35 minutes per week. And then if we look at the point where you get to the lowest possible risk, and here, this doesn't really go up. If you look at the 95% confidence intervals, it's consistent with it just staying flat. What we see is there's only about 20 minutes per day. And the reduction in risk is about 60%. So what we're seeing when you measure physical activity using an accelerometer is the amount you need to do to get a benefit is lower, and the magnitude of the benefit is higher than we do when we look at self-report. And if we look at all our evidence and physical activity guidelines, they're generally based on self-report. And this is something I wrote a commentary on last year in Nature Medicine. It's worth a read. It's only 2 pages long. But what one of the conclusions was the benefit in terms of lowering risk of mortality for an extra minute of accelerometer measured physical activity was equivalent to about 2.5 minutes of self-reported physical activity. So the benefits of activity may be greater, and the levels at which they occur may be lower than we previously thought. And I'm going to show you an example of this. I talked about this study briefly yesterday. This is a study that we did with colleagues throughout Europe called Eurofit. And what we did in this particular study is we try to get around this issue that men generally don't engage with lifestyle intervention. If you look at most of the large lifestyle intervention trials, the majority of participants are women. Men seem to be less bothered, and particularly men at lower socioeconomic status, the lower socioeconomic classes seem to be less bothered. But one of the things that often men do is they love football, and they've got a really, really strong affinity to the football club that they've supported since they were a child. So what we did is we leveraged this by taking top-level football clubs throughout Europe. So clubs like Manchester City and Arsenal and Everton and Porto and Benfica and PSV Eindhoven. So 15 clubs throughout Europe. And what we did is we recruited football fans who supported the clubs, and we trained the coaches of the clubs to deliver a lifestyle intervention. We did a one-year intervention in about 1,113 men randomized to either the intervention or not. So this is some of the men, sort of they managed to go to the clubs where they support, and these are the men doing some of the activities. We took a bunch of measurements in them, and what we found is when you looked at the amount of objectively measured physical activity that they did, and how much it changed over 12 months, it only changed by about 6 minutes, which is a little bit disappointing. It was a €6 million project, and we changed physical activity by 6 minutes a day. What we did though is we changed their self-reported physical activity by about 32 minutes per day. So a clear thing is, people are not very good at reporting how physically active they are. They're not very good at all. You have to measure it. But the key thing was, even though we changed physical activity by only about 6 minutes per day, when we properly measured it using an accelerometer, it was enough to cause about a 2.6 kilogram reduction in body weight, a 1.2 millimeter reduction in systolic and diastolic blood pressure, reduction in insulin and insulin resistance, reduction in triglyceride, reduction in liver enzymes. So although the amount of physical activity was relatively small, it was enough to produce a reasonable amount of metabolic benefit. So the amount of objectively measured physical activity needed for substantial health benefits may be less large than we think, maybe only 5 to 10 minutes per day, but there are larger benefits of doing more. Now, the key thing here is this can change how we prescribe physical activity, because telling somebody that's not very active they need to do 30 minutes a day can seem daunting. But if we tell people you might only need to do 7 or 8 minutes a day, and you could do this by walking for 2 or 3 minutes, 3 or 4 times throughout the day, as long as you walk reasonably briskly, and that's enough, you might be more likely to get people to do it. So I think evidence such as the work from the accelerometer with the epidemiology and trials like Eurofit might change the way that we try and prescribe physical activity for inactive people going forward. And I think that's something to watch this space for. The next thing, which is really the forgotten part of the physical activity guidelines, is muscle strengthening activities. Most people can recall 30 minutes of physical activity a day, 150 minutes per week, but almost 0 people say that you need to do muscle strengthening activities twice a week. Why do we need to do muscle strengthening activities? Well, one is it helps with our physical function. We peak in muscle strength in our sort of early to mid 20s, and then it starts to decline. And if you're not very strong, you get to a point where as you get older, your strength falls below a capacity threshold, so you're not able to pick up the shopping, you're not able to get out of a chair, you can't cross the road fast enough before the man changes from green to red. Whereas if you're a bit stronger, you can actually follow this green line, so you can actually keep function later in life. So that's the obvious reason why it's important to do strength training. The other thing that might be less obvious is there seems to be a metabolic benefit as well. So this is data from the Nurses' Health and Nurses' Health 2 study. And what we've got on the y-axis is relative risk of type 2 diabetes and amounts of muscle strengthening activities. So none here, up to 150 minutes per week, and moderate to vigorous aerobic activities here. And we see that doing more muscle strengthening activities and doing more aerobic activities are both associated with lower risk of developing type 2 diabetes. And there's also evidence in people who have type 2 diabetes and from randomized controlled trials, which shows that doing a combination of aerobic activity and resistance activity gives a bigger reduction in HbA1c than doing either aerobic or resistance activity on its own, and that's when the total volume is fixed. So you're doing the same total amount of activity, but you're splitting it between aerobic and resistance. You seem to get a bigger reduction in HbA1c than doing either aerobic or resistance on its own. So it seems that aerobic and resistance exercise work via slightly different mechanisms, so you get an additive effect if you do them together. The other thing that you might not be aware of is strength is a really, really important predictor of future health outcomes. So this is some data. Again, this is Carlos Celis Morales is the first author from UK Biobank, which is a large epidemiological study of 500,000 people throughout the UK. And one of the things that these people did is that grip strength measured by this hand grip dynamometer that you can see the picture of there. So grip strength in itself is probably not the most important thing, but it's easy to measure in large numbers of people. But we know that grip strength correlates really well with strength in other parts of the body. So for example, people that have strong grip strength also have strong leg strength. So it's a measure of overall muscular strength. And what we find is that for every 5 kilogram lower grip strength, and to put this into perspective, I think men on average had grip strength about 35 kilograms, women about 25. You get about a 20% increase in risk of mortality in women, 16% men, and you also get increases in risk of basically every single potential class of mortality. So not being strong is a strong factor which influences risk of mortality. And what you find is if you take a risk score, so if you take an office-based risk score for 10-year risk of cardiovascular disease or all-cause mortality, taking into account age, smoking, BMI, sex, blood pressure, and diabetes, and you add in grip strength on top of that, you improve prediction. So the C-index increases by about the same amount as adding in HDL to your measurement. So you actually get additional predictive power by adding into grip strength into the model over and above what we already measure normally. So the thing is, right, 50% of the population meet the guidelines for muscle strengthening activity, but only about 25% of the population meet the guideline for muscle. So 50% for aerobic, only about 25% for muscle strengthening activities. So the question is, how little muscle strengthening activity can you get away with? And this is something that we looked at slightly in a BBC program that was out. I think it was the start of this year. The links there, you might still be able to see it. But basically, it's looking at work that we're currently doing in Glasgow, trying to say what's the minimum amount of resistance exercise that you need to do to get a strength benefit. And if we show that, we can potentially use that to see whether you get a metabolic benefit from that small amount of activity. And what we're doing is basing this on the idea that if you look at all the meta-analysis data for muscle strengthening activities and improvements in strength and muscle size, what you find is doing more gives you a bigger benefit, but it's not linear. The biggest benefit you get is going from 0 sessions to 1 session a week. So you get about 70% of the benefit in muscular strength of doing 4 sessions a week of resistance exercise with the first session that you do. And then if you look at sets of exercise, so often if you do exercise, you might do 3 sets of 10 reps or something like that. You get most of the benefit from the first set that you do as well. The caveat with this is the set needs to be done to the point of fatigue. So if you're doing exercise like this, you do them until you can't lift the weight again. And if you do that, it actually doesn't matter how heavy the weight is within reason. So you do a heavier weight fewer times or a lighter weight more times, as long as you take it to the point where the muscle is fatigued and you can't do another rep, you get the same adaptation. So what we've done is say, well, we can get a bunch of exercises. And if you take, you've got about 6 major muscle groups in this body that you're interested in looking at. So you have shoulders, shoulders, chest, back, core, sort of your glutes and your legs. What you can do is 1 exercise per week on each of those muscle groups. So let's say, for example, you chest and press ups. So you do press ups until you can't do any more press ups. And if you're not strong enough to do them on your feet, you do them on the knees or against the counter, which will take less than a minute in most people. If you can do a minute of press ups, you're very strong. So you can do that throughout the week, 1 minute per muscle group per week, to the point of fatigue. And what we're doing at the moment is doing a study to see how much it changes strength. And if we see that, then it's something that you could potentially apply to people in the real world, because doing a minute per day, you don't need to get changed. You can do it sort of just after you brush your teeth. It's not a big deal. So what we're trying to do is make resistance exercise a little bit more achievable to people, because often people think that going to the gym is something that they really don't want to do. Muscle strengthening is important for health. Low strength is an important risk factor for adverse health outcomes, and 1 set per week per major muscle group might be enough. Okay, I'm going to shift tack slightly to talk about fitness. So what I've talked so far, I've talked about strength, which is a biological trait, but physical activity is a behavior. So it's how much your behavior of moving your muscles to do work. There's a related biological trait called cardiorespiratory fitness, which is your body's ability to use oxygen. It's often measured as your VO2 max, or maximal oxygen uptake. So someone who's fit cardiorespiratory can run fast for long periods of time. So if you're fast at running a 10K or running a marathon, you've got a high level of cardiorespiratory fitness. You improve your fitness by doing more physical activity, but there's an important genetic component to fitness. So about half of your VO2 max is explained by heritable factors. So how well you chose your parents influences how fit you're likely to be. And so a question is, what's more important for health? Is it how much physical activity you do, so this behavior of being physically active, or your level of cardiorespiratory fitness? So it turns out fitness is important in itself. So this is a study that was done by Ulrich Wisloff and Lauren Koch. And what they did in this particular study was they took rats and they ran them on a treadmill, and they measured how good they were at running. And they took the rats that were really good at running, and they bred them generation on generation on generation. So by 13 or 14 generations in, you've got these super rats that are really have high capacity. And then at the other end, you take the rats that were not very good at running and you breed them generation on generation on generation. So at the end, you get rats that got picked last in PE. These are the rats that are not very physically able. And what you find is if you look at risk of mortality, the low capacity rats in orange lived for about 7 months shorter. And this is a long time in a rat which has a life expectancy of 2 years than the high capacity rats. So a higher level of fitness, being bred for a higher level of fitness, increased life expectancy. Turns out the same thing happens in humans too. So this is data from a fantastic study called the Copenhagen Male Study. And what they did in just over 5,000 men in the 1970s, in middle age, I think their mean age was about 48 when they did this, was do a fitness test. And then they followed them up for 46 years, so nearly half a century. And they looked at their risk of mortality. And what you can see here, this is the cumulative incidence of mortality. And so the fittest men are in blue at the bottom and the least fit men are in red at the top. And you've got a difference in life expectancy of about 4.9 years between the fittest and the least fit men. So fitness in itself seems to be important. Now, one of the things that we did a few years ago was look in UK Biobank to see whether there was any interaction between how fit you are and how physically active you are in terms of risk of mortality. So what in UK Biobank, about 70,000 of the participants undertook a fitness test, and we categorized them as having high, moderate, or low levels of fitness based on tertiles for age and sex. So, but you took people in 5-year bands, males and females, and said, so if you're a man aged 50 to 54, are you in the top, middle, or bottom third of the population? We did that across the, and then what we've also got here is Q5 to Q1. So Q5 are the most active 20% of the population, and Q1 are the least active. And what we see is if you take people who are in the bottom third of the population for fitness, if they are inactive, they've got a high risk of mortality. But even if their fitness is low, if they are active in the top 20% of the population, their risk of mortality is the same as people who have a high level of fitness. But when you take people that are highly fit, it doesn't matter how active they are. They're at low risk, even if they're inactive. So if you are genetically lucky enough to be naturally fit, it seems that you can probably get away with being inactive. Of course, a lot of people, once they become inactive, will move to these other categories. But if you can stay in this category here, you're likely to be protected. And we see the same story when we look at grip strength. So we can look at people's top, middle, and bottom third of the population for grip strength. The people who are not strong and not active are at high risk. But when they become active, if they are active, their risk is the same as somebody that's strong. Whereas people that are strong, it's pretty flat apart from if they're in the bottom 20% of the population. They seem to be able to get away with being less active and seem to have low risk irrespective. So the benefits of physical activity on health outcomes are the greatest in people who have low fitness or low strength. And people with high fitness or high strength appear to be protected even if they're inactive. So the corollary of this is we need to get inactive people with low fitness and strength rather than all inactive people to become more active for public health. And this can be a challenge because people generally like doing things that they're good at. And people that have a low level of fitness or a low level of strength are probably less good at physically active type things. So they might enjoy them less. So there is the real challenge in what we need to do really to improve public health is to get the people who probably like being active the least to become more active if we're going to try and reduce improve public health. I'm just going to do a couple of quick slides on physical activity and obesity to finish off. So the first thing is there is a relationship between how physically active you are measured by an accelerometer and whatever index of adiposity you like. So this instance is BMI. This is data from the UK Biobank in both men and women. The people who report, who have more measured physical activity using an accelerometer have a lower BMI than people with less physical activity. But one of the questions here is that's cross-sectional. And so is it that physical inactivity is leading to obesity, or is it that obesity is leading to physical inactivity? And we can't tell those from those cross-sectional data. So we were able to investigate this to some extent using data from the Navigator trial. And what happened in the Navigator trial is people had measurements of physical activity at serial times, and they also had measurements of weight at serial times. So we could actually, by looking at the time series, work out whether whether weight influenced step count in the future, and whether change in weight increased step count, and similarly whether step count influenced weight later on. And what we found, long story short, is the relationship was bidirectional. So physical activity or changes in, was associated with changes in weight, but it was relatively small. So a 2,000 step difference in step count per day, which is equivalent to walking about 20 minutes more, was associated with about a 60-gram difference in weight at follow-up. And a 10-kilogram difference in weight was associated with people doing less physical activity by about 220 steps, about 2 minutes less moderate to vigorous physical activity. So it appears that this relationship is bidirectional, but it's weak in both directions. So being physically inactive leads to an increase in body weight, being heavier leads to a decrease in physical inactivity, but the relationship is relatively weak in both parts. So final couple of slides. Is the relationship between physical activity and adiposity the same for everyone? So again, this is some data that we did from UK Biobank, and what we did is we came up with a genetic profile risk score for obesity based on 93 SNPs. So we took each SNP and looked which version they had, which are related to body weight, weighted them depending on what the effect they had was, and we divided people into quartiles for the genetic risk score for obesity. And then within that, we looked at how much physical activity they did. This is objectively measured physical activity. This is, I'll show you a slightly simpler version of the data here. So basically, if you are in the top 25% of the population for genetic risk versus the bottom 25%, you're about 4 kilograms heavier. So we see this dose-response relationship. The more obesity genes you have, the heavier you are. But what you can do is say, if you take someone with a high genetic risk of obesity in the bottom third of the population for weight, sorry, bottom third of the population for physical activity versus the top, they're about 7 kilograms lighter. But if you take someone with a low genetic risk of obesity and in the bottom versus the top, they're about 5 kilograms difference in weight. So what you find is the benefits of being more physically active on body weight are actually greatest in the people who have the highest genetic risk. So it's not that if you've got a genetic risk of obesity, people go, well, look, there's nothing I can do, doc. It's my genes. They're making me fat and I can't do anything about it. What the data actually shows is the exact opposite, that if you've got genes which predispose you to obesity, how much physical activity you do seems to have a bigger association with your body weight than somebody who is lucky enough not to have genes which predispose them to obesity. I'll just finish off now by thanking all the people I've worked with over the years. So thank you very much, and I'll be delighted to take some questions in the discussion.
Prof. Gale, thank you very much for this fantastic presentation. And I have to say, I did enjoy that session in BBC Horizon, very much so. And actually, my patients enjoy it when I direct them to do the 1 minute exercise strength and exercise sessions, and it's very, very empowering to patients. So I can't thank you enough. It was really nice presentation. So the floor is open for questions. While we're waiting, I can't see any questions. Can I start, Prof. Bolton? As you rightly said, we're expecting a tsunami of diabetes complication after the easing off of the lockdown and hopefully returning back to normality. So I'm asking you, as the IDF president right now, do you think the IDF have to take a leading role in shaping the worldwide response to this? Because obviously we don't know what has been kept for 2 years from the specialist care, really. So what do you think, and how do you see the IDF response to this tsunami, or expected tsunami of diabetes complications? Prof.
Well, thank you very much. That's a very important question. We have 260 member associations across the world, and we're working with them, but also the important is to get the message through to the health payers, the governments, the health departments, that diabetes is a serious condition. The prevalence is going to be even higher in the next atlas. The number of patients across the world, as I say, will be well over 500 million, and this is always an underestimate. So the most important message to governments at large is that diabetes is a very expensive disease. The complications are very expensive, but there is great potential for prevention early on by screening high-risk people. And as the last speaker in his very entertaining talk talked about the involvement in exercise, and this is so important. So screening and taking important diabetes as a serious condition. Why do people have a prostate check or a mammography? Because they're frightened of cancer. Why do people take a statin? They don't feel any better, but they're frightened of heart disease. But diabetes touches sugar. My grandmother had it, she was 90. So we've got to remove that sort of public opinion that diabetes is not a serious disease. And that's what we're working on. But having listened to the last talk, I'll make 3 comments. First of all, I felt very guilty. I thought I'd check my phone. I've done 11,000 steps, so I felt less guilty. But another study for Jason, being a church bell ringer or a campanologist, I'll be swinging heavy bells tomorrow morning. And that would be a great study. People always like new studies, but for muscle strengthening. And thirdly, delighted you looked at Manchester City supporters and not Celtic United.
I think we'll probably take another question. Let me see if we have any. Jason, we don't have any question, but I have one for you, if that's all right. I think your efforts, your involvement with the public through TV and other venues is quite important. So how do you see the impact of of popularizing exercise and the science behind exercise. Would that have a positive impact on people uptake of exercise? And just to take it a step further, has this been measured? Has your group, have you measured the impact of popularizing exercise and the science behind exercise? Have you done that before?
So that's a very interesting point. So the short answer is we haven't measured the effects of this. I mean, it's something I think is important because well, there's two things. One is I'm interested in the popularization of science, and the science of physical activity and diet is something that people can relate to. And you can actually sneak it in. You can sneak in quite a lot of science into a popular program. And one of the things that I've been doing this for a long time, I started off, I kind of wanted to do the very straight down the line science programs. And then what some of the producers told me, well, if you do those, 1 million people will watch, because not very many people want to watch science programs. So if you can try and make it more entertaining and do these stunts, right, you'll get 3 or 4 million people to watch, and you kind of sneak the science in. So I've become more comfortable on doing things which are things that are really outside my comfort zone as I'm a proper scientist, I guess, to try to which actually gets more. So one example is we did a program on diabetes remission, where what we did is we essentially, it was called Diabetes, the Fast Fix. It was a 2-part series on ITV. And what we did, and we didn't have to do it this way, and I was pushing against it, but I'm glad we overruled, is that with Direct, they kind of put people on an 800-calorie diet for a number of weeks, and half the people got into remission. So we replicated that, but we did a sort of a Big Brother house, where we got 5 people into the house, and they kind of went these diets, and you saw how they interacted, and they got a little crabby. And then what happens, we got 3 out of 5 of them into, well, remission over the time period. But what happened is loads of people watched. It was the most watched TV program at the time. And Diabetes UK had more people get in contact with them after that program than they ever had before. And all these people that weren't aware, it was published in the Lancet, scientists knew about it, people with diabetes didn't. And so I think these sorts of things are quite important. But what we have to do with these is be very careful that what we present actually reflects the truth of the science. And sometimes you get slightly wacky people doing things which aren't reflected in science. So what I try to do on these programs is make sure you do things in a stunt, but there's always a study behind, so you kind of know what the real answer should be. So I think that's quite important, and it's something that I take quite seriously, even though it looks like it's fun.
Thank you very much. I have a question for you, Prof. Bolton. So the question says, what's the best treatment agent for diabetes in case of COVID-19, either in hospital or for outpatients?
Well, for patients who are at risk of developing COVID, which is all of us, if you have diabetes, the good control is however it can be achieved if you're an outpatient living at home. So it doesn't matter what medications you use, it's the achieving stable, reasonable glycemic control. In hospital, it's different. And I think most people in hospital, we now strive to get good control early on because of the data I've shared with you, especially those with time above range and so on. So it's usually insulin. And obviously in ICU, it's often insulin infusion.
Right, great. It has been a fantastic session. It remains for me to thank our both speakers, Professor Bolton, Professor Jason Gill, for the fantastic contribution to this year's GAED's meeting, and thank all of you for your attendance, and we'll hand over to the next session. Thank you very much.
My name is Dr. Isa Al-Dafiri. I am consultant adult endocrinology from Riyadh. It gives me great pleasure tonight to introduce Dr. Francis Hayes, who is Associate Clinical Chief of Endocrinology at Mass General Hospital, Associate Professor of Medicine, Harvard Medical School in the US. Dr. Francis is the Associate Clinical Chief of Endocrinology at Mass General Hospital, Boston, and Associate Professor of Medicine at Harvard Medical School, and a Fellow of the Royal College of Physicians of Ireland. She attended medical school at University College at Dublin, Ireland, and completed her residency in internal medicine and fellowship in endocrinology there. Her clinical and research interests include male hypogonadism, a topic on which she has lectured and published widely, as well as Turner syndrome for which she is a co-director of the clinical at Massimo General Hospitals. Dr. Francis will talk to us tonight on her expertise in male hypogonadism. Dr. Heiss.
Terrific. It's a real pleasure to join you this evening, and greetings from Boston. So I'm going to talk about certain aspects of male hypogonadism in the next 30 minutes, beginning just with a basic definition so we're all clear about what we're talking about. And the definition that I use was the one put forward by the Endocrine Society Clinical Practice Guidelines, namely a clinical syndrome resulting from failure of the testes to produce physiologic levels of testosterone due to disruption of one or more levels of the hypothalamic pituitary gonadal axis.
Yeah, tamam.
So you should be all very familiar with the classification that I'm not going to go through in any great detail, but just to briefly describe the defect in primary hypogonadism is in the testis. So there's a compensatory increase in gonadotropins, and it can be congenital or acquired. And in the past, we thought of this as a cause of sterility, but increasingly now we are able to extract sperm from the testis through advances in andrology, microdissection testicular sperm extraction, so that sterility is no longer an inevitable part of primary gonadal failure. I wanted to focus just a little bit on Klinefelter syndrome for a number of reasons. It's very common. It's got an incidence of about 1 in 500. And the other important issue is that in addition to hypogonadism, the presence of that second X chromosome is associated with multiple extragonadal features, including a metabolic profile, metabolic syndrome and type 2 diabetes, an increased risk of certain malignancies, including extragonadal germ cell tumors and breast cancer, and then importantly, some learning challenges, ADHD, and an increased risk of depression and anxiety. Secondary causes then can be congenital or acquired, and we focus a lot in our unit in Boston on the genetic causes, normosmic hypogonadotropic hypogonadism, or when it's associated with inability to smell, Kalman syndrome. There can also be combined pituitary hormone deficiencies resulting from mutations in genes that are important for anterior pituitary development. And the big distinction here from primary gonadal failure is the ability to restore fertility by administration of either gonadotropins or pulsatile GnRH. The last 2 decades have seen an explosion in the number of genes that have been implicated in hypogonadotropic hypogonadism. So between 1991 and 2018, 43 genes had been reported to be pathogenic. So as clinicians, it's often challenging to know what genetic testing should be performed when you have a patient with hypogonadotropic hypogonadism in your clinic. And this was one algorithm that incorporates the presence or absence of anosmia and whether the inheritance appears to be sporadic or familial. And this can guide the type of genetic testing that one might do. So for instance, if you had a patient where the mode of inheritance clearly appeared to be X-linked, then the gene of choice to test would be what was formerly called Cal1 and is now called anosmin-1. If the inheritance was consistent with a recessive mode, then the prokinetisin family, ProK2 and ProKR2, would be, for instance, common genes to check. Sometimes there can be overlap. So this sort of distinction between absence of smell and normal sense of smell may be artificial. So that there are some genes, particularly those in the FGF pathway, that can be implicated in both Kalman syndrome and normosmic hypogonadotropic hypogonadism. And finally, for those that have a normal sense of smell and a recessive mode of inheritance, we think of mutations in GnRH1 or its receptor, or KIS1 and its receptor. But it's also becoming clear that it may not be a simple monogenic disorder. And data from our group has shown that there is evidence of oligogenicity, so mutations in more than one gene within a kindred. And this can explain some of the phenotypic heterogeneity that we see. In terms of acquired causes, the one I wanted to focus on is the functional causes. So we're all very familiar with the impact of weight loss on the reproductive axis in women, but it hasn't received the same attention as in the male until relatively recently. And 2 years ago in JCM, we published a paper on functional hypogonadism in a group of young, healthy men who had symptoms of hypogonadism in the setting of excessive exercise. So they were typically exercising for more than 10 hours a week, or they lost more than 10% of their body weight. And they were brought into the Clinical Research Center for frequent blood sampling for LH. And some of them had an apulsatile pattern. So really you can see that there's no pulses of LH, which should normally be secreted every 2 hours. Others had this what we call sleep-entrained pulse pattern. And that meant that the pulses that were present occurred during sleep, shown here in the bar, the hatched bar. And this is the type of pattern that we see typically at puberty. And then others appeared to have, for all intents and purposes, a normal pattern of LH secretion, yet all 3 subjects that are shown here had low testosterone levels. And I'm showing you an example of one patient who at baseline had a low testosterone, so 225 nanograms per deciliter. His BMI was within the normal range, but he was a very muscular individual with low body fat and low leptin levels. And you can see that when his weight increased, so his BMI went up to 27.9, the number of LH pulses went from 3 to 8, and his testosterone level went from 225 to 442. So this is an example where correction of an underlying abnormality rather than testosterone replacement is the optimal treatment for hypogonadism. I'm sure all of you are aware that in the decade between 2000 and 2010, there has been a marked increase, so about a 4-fold increase in testosterone prescribing. What's also striking is that the increase is largely within the United States, whereas our counterparts in the United Kingdom are much more conservative in their use of testosterone. And to try and understand the basis for this increase, it's important to appreciate some of the key dates in androgen prescribing practices. So testosterone was first isolated back in 1935, and for many decades, the only method of giving testosterone was a deep intramuscular injection of testosterone esters and N-theta cypionate. In 1997, the FDA approved direct-to-consumer advertising for prescription meds, including testosterone. And then in 2000, the first testosterone gel was approved. And that same year, the lay press really featured a number of articles on the purported benefits of testosterone in boosting sexual function and body composition. Whereas at the same time in the more scientific literature, caution was being advised that the benefits attributed to testosterone were really not supported by clinical data at that time. And so when we think of the indications for androgen therapy, nobody would have any problem with using testosterone for men with classical hypogonadism. And that would be patients with conditions like Klinefelter syndrome or Kalman syndrome. There's also a role for using testosterone in boys with delayed puberty because of the negative psychological consequences that can arise from lagging behind peers, and also to ensure that they achieve their peak bone mass. Our pediatric colleagues use testosterone briefly in boys with micropenis. But the areas of controversy are the use of testosterone in the aging male and the use of testosterone to treat hypogonadism that's associated with comorbidity, and that's mainly obesity and chronic disease. It may seem very obvious to say that there's really no indication to give testosterone to men with normal testosterone levels, but this is happening at many men's health clinics, certainly across the United States. And this is really supplementation as opposed to replacement. And while I mentioned in the introduction the classification into primary and secondary hypogonadism, aging is an example of a condition that can cause dual defects in the HPG axis. So at the level of the hypothalamus, there's a reduction in GnRH secretion with aging. And at the level of the testis, there's a decrease in Leydig cell number and responsiveness to LH. So the net effect of this is that total testosterone levels decline by almost 2% per year from the fourth decade. But unlike menopause, where estrogen levels inevitably decline significantly, for many men as they age, while testosterone levels may decline, they can remain within the normal range. And some of the best data on the prevalence of hypogonadism with aging come from the European Male Aging Study led by Fred Wu, a large community-based study of men aged 40 to 80. And you can see that overall the prevalence is just 2%, so hardly an epidemic. That prevalence increases with age, it increases with increasing BMI, and it increases with additional comorbidities. And I think a useful statistic to have when counseling patients is that a 5 kilogram per meter squared in BMI is associated with a decline in testosterone that's comparable to about 10 years of aging. And while unfortunately there's nothing that we can do to reverse the aging process, there are certainly many ways at which we can address BMI, as we heard in the previous talk by Dr. Gill. So what are some of the challenges that we face in diagnosing hypogonadism? At the very basic level, there's still debate as to the threshold testosterone level to make the diagnosis, and if that threshold is the same for all target tissues. There's also considerable variability in testosterone due to circadian rhythms, medications, comorbidity, and assay methodology. And an important factor to remember is that about a third of men with low testosterone levels will have normal levels on repeat testing. And there's really a greater likelihood that comorbid illness is contributing to non-specific symptoms of hypogonadism in older men. So I mentioned that aging causes dual defects in the HPG axis. So can many other conditions, including hemochromatosis, alcoholism, glucocorticoid therapy. Kalman syndrome can have defects in the testis as well as the hypothalamus, and then adrenal hypoplasia congenita. So the European Male Aging Study was very useful in trying to see what the predominant level of the defect in aging actually is. And so in this graph here, you can see 4 quartiles divided by testosterone and LH. And so in the European Male Aging Study cohort, the vast majority, so about 3/4, had normal testosterone levels and normal LH, so they were eugonadal. The next most common was secondary hypogonadism, so about 12%. And then the third most was an entity that they described as compensated hypogonadism, where the testosterone level was maintained within the normal range, but only by increasing levels of LH, so analogous to compensated hypothyroidism. And then the smallest cohort had primary hypogonadism. Now, when they looked at the percentage of each of these categories across decades, they found that, as you'd expect, the fraction of eugonadal men decreased as you went from the 40 to 49-year-olds to those in the 70 to 79-year-old. But there was really no change in the prevalence of secondary hypogonadism with aging. What did increase as men got older was both primary and compensated hypogonadism. So when you see secondary hypogonadism in older men, it's usually the impact of the comorbid illnesses that they accumulate as they get older, as opposed to aging per se. And in the United States, the Food and Drug Administration, they published restrictions on the indications for testosterone use back in 2015. Saying that these products are approved only for men who have low testosterone levels caused by certain medical conditions, and that the benefit and safety hasn't been established for the treatment of low testosterone levels due to aging. Most of the data that we have on the impact of testosterone in middle-aged and older men with no clear cause for their hypogonadism other than age comes from the testosterone trials, for which there was a nice review published by Peter Snyder in Endocrine Reviews. And the summary from these placebo-controlled trials of testosterone were that there were a number of benefits, so improvements in sexual function, bone density and strength, mood, and anemia. There was sort of disappointingly no effect on cognition or overall vitality. And then there was some negative effects, and that was an increase in the coronary artery plaque volume. There was no increase in cardiovascular or prostate adverse events, but this study was really not powered to assess this risk. And while bone density improved, there was no data on fractures. So how do we diagnose androgen deficiency in men? Well, the Endocrine Society put forward these clinical practice guidelines that were updated in 2018, recommending that the diagnosis be made when you've got consistent symptoms and signs and unequivocally low total testosterone levels. And the symptoms and signs really vary depending on what the age at presentation is. So in neonates, there can be clues to the presence of hypogonadism. If you see unilateral cryptorchidism, microphallus, and both of these conditions point to a problem in the third trimester of pregnancy. In contrast, if you see hypospadias, where the urethra is opening up on the undersurface of the penis as opposed to the tip, that indicates a problem in the first trimester of pregnancy. More commonly, we diagnose hypogonadism when there's failure to develop secondary sexual characteristics, and there may be evidence of gynecomastia or unicoidal proportions. One of the challenges when you see a 16-year-old who has not gone through puberty is to determine if this represents constitutional delay or true hypogonadotropic hypogonadism. Factors that can be helpful include a family history. Obviously, if there is sibling with Kallmann syndrome, that makes that condition more likely. Short stature would favor constitutional delay. And the history may be helpful if there's history of anosmia, cryptorchidism, or microphallus. If there are anomalies on physical exam, like synkinesia, which is mirror movements, some midline defects like cleft lip or palate, or digital anomalies, all of those would favor congenital hypogonadotropic hypogonadism. But often the diagnosis could only be made with the passage of time. But more recently, there has been a new test that's helped to identify those boys who have pubertal delay to determine whether this is likely to be just delayed or permanent hypogonadism. And the test is the LH response to kisspeptin. And so they had a group of 16 girls and boys with no evidence of puberty. And if the LH response to kisspeptin was 0.8 or above, it identified those adolescents who would go on to enter puberty at a later stage. By contrast, if the LH response was less than 0.4, on follow-up, those boys and girls did not progress through puberty. So the LH response to kisspeptin was superior to the LH response to GnRH or inhibin in predicting the onset of puberty. In adult patients, hypogonadism can present with fatigue, changes in body composition, sexual function, and sometimes a metabolic phenotype. So the second component of the diagnosis is to demonstrate unequivocally low testosterone levels. And as you know, testosterone, there are different fractions we can measure. There is the total, which is everything in the circulation, both the free and protein bound. The free testosterone, which is just about 2%, which is not bound to SHBG or albumin. And then the bioavailable, which is a combination of the free and the albumin bound. And the recommendation is to measure testosterone in the morning because there is significant diurnal changes, although these become attenuated with age, and to use a reliable assay. In the recent iteration of the guidelines, there's also a recommendation to measure testosterone fasting. And this was based on data that we published showing that testosterone decreases significantly after an oral glucose load. And that in as many as 15% of men, testosterone levels which were normal at baseline fell to the hypogonadal range after glucose. And this was true in men who had normal, impaired, and diabetic glucose tolerance. Another important thing to remember when you're making the diagnosis is to always confirm it by repeated measurements, no matter how low the level is. And this was a young, healthy volunteer that came into our clinical research center. And you can see that he has pulses of LH sort of intermittently over that 24 hours. And he starts off with a testosterone level. So this was drawn from a pool over 6 hours. It's in the mid-normal range, as you would expect in a young, healthy male. But then after this long pause in LH secretion, his testosterone drops to 91. That then sends a strong signal to the hypothalamus and the pituitary to start secreting again. And this results in the testosterone levels being restored to the normal range. So if you were to pool the entire 24 hours, you would have a normal testosterone. But if you were to sample the patient just at this point, you could be misled into thinking that he had hypogonadotropic hypogonadism. If the total testosterone is low normal and altered SHBG levels are suspected, then it's important to measure the free or the bioavailable. And there are a number of factors that can influence SHBG. The factors that are particularly important for increasing it are age, anticonvulsants that are enzyme inducers, hyperthyroidism, HIV, and liver disease. And factors that decrease SHBG in clinical practice, the most important ones are insulin. So in patients with obesity or type 2 diabetes, SHBG is low, and hypothyroidism. And when you're measuring free testosterone, the gold standard is equilibrium dialysis, but it's not always available in clinical labs because it's labor intensive and expensive. The next best option is to use a calculated free testosterone, which is calculated from measurements of total testosterone, SHBG, and albumin, and correlates strongly with the free testosterone measures by equilibrium dialysis. What is not recommended is to use the RIA for free testosterone. And increasingly, it's becoming recognized that free testosterone is probably the most biologically active form of testosterone. And these are, again, data from the European Male Aging Study. And what they did in this particular study was to stratify their population into 4 different groups, depending on what their total testosterone and calculated free testosterone levels were. So about 80% had normal total and normal calculated free T. And then if you look at the other 3 parameters, the low total testosterone and the low calculated free testosterone, you can see that about 10% of their population met these criteria. And these were the men who tended to have a lot of comorbidities and be obese. And they had some of the typical symptoms that you would associate with hypogonadism. When they looked at patients who had a low calculated free testosterone, but a normal total, they saw that same constellation of symptoms. So changes in body composition and sexual function and bone mass. But when they looked at the smaller group of patients who had a low total testosterone, but a normal calculated free testosterone, they did not see the same typical symptoms of hypogonadism. So no changes in bone density, they didn't see the sexual symptoms or the changes in energy. And so these data would suggest that if you have a low total but a normal free testosterone, that you may not benefit from testosterone replacement. So the typical algorithm then for diagnosing hypogonadism would be to get 2 morning total fasting testosterone levels. And then you want to classify the level of the defect. If gonadotropins are high, you obtain a karyotype. If they're low, then you need to exclude functional causes, including weight loss and medications. You want to make sure that the defect is limited to the gonadotropins. So you can do anterior pituitary testing and rule out hyperprolactinemia and hemochromatosis. And then the indications for pituitary imaging are a total testosterone of less than 150, elevated prolactin, the presence of other pituitary hormone deficiencies or neurological symptoms. Many times people will wonder, what is the cutoff testosterone for diagnosing hypogonadism? And if you have an assay that is harmonized to the CDC standard, then the lower limit of normal for healthy, non-obese young men is 264 nanograms per deciliter. So what do you do if you can't find a cause for low testosterone? And I would say, first of all, make sure that you have repeated morning fasting measurements and that you're using a reliable assay. Make sure that you've performed a comprehensive evaluation that was not done during an acute illness. And then importantly, consider non-pharmacologic approaches. And chief among those is weight loss. And this shows the impact of weight loss, whether it's by simple diet and exercise in the open circles or bariatric surgery in the closed circles. And you can see that there is a significant relationship between the percent of body weight that's lost and the increase in total testosterone that ensues. But it's also important to appreciate that there are differential effects of weight loss on total and free testosterone levels. So here you're looking at the percent weight change and the percent change in either total testosterone or free testosterone. And you can see that if you lose about 5% of your body weight, you will see a significant increase in total testosterone. But to see a significant increase in free testosterone, you have to lose about 15% of your body weight. So a much more significant degree of weight loss. So to conclude, I would say that the diagnosis of hypogonadism should only be made when the symptoms and signs are accompanied by consistently low testosterone levels measured by a reliable assay. Comprehensive evaluation should always be performed before initiating treatment. A low testosterone is not a diagnosis. The major increase in testosterone use in the past few decades has been in men with functional hypogonadism, which may be reversible without having to use testosterone replacement. The diagnosis of hypogonadism should be reviewed periodically because there is a potential for reversibility. And this is true even in patients that have genetic causes such as Kalman syndrome. The benefit-risk ratio of testosterone replacement in older men is still uncertain, particularly with regard to cardiovascular disease. And as physicians, I think we should go back to first principles and that motto of Hippocrates, primum non nocere, which is first, do no harm. And so to optimize the benefits and minimize the risks of testosterone replacement, it's important to have careful patient selection. In future, this may be informed by pharmacogenetics. To carefully monitor patients and make sure that testosterone levels are maintained within the normal range. And until we have a better idea of long-term safety, treatment should be discontinued if side effects develop, if symptoms do not improve, or if the inciting factor, whether that be obesity or opiate use, has resolved. So I'd like to thank you very much again for the invitation to speak at this conference. And I'm not sure if we have any time for questions, but I would be happy to take them if we do.
Thank you very much, Professor Francis, for this excellent review of this topic. Thank you very much.
Okay, my pleasure. Thank you again for the invitation.
Thank you very much, Professor Frances Hayes, for her excellent talk and outstanding talk. What a nice topic to conclude with this annual Congress for the Gulf Association of Clinical Endocrinology. We would like to thank you all for your participation in this Congress. Hope you have enjoyed it and you had a fruitful really days from the beginning, the day one until now. There were lots of fruitful sessions and I hope you learned as much as we did from all our eminent international and regional speakers. I would like to thank them all for their participation and outstanding presentations and talks, and would like to thank the chairs of the sessions for their outstanding chairing skills. And with that, we come to the final part of today's and to this Congress. And first of all, I just want to keep you updated with important matters. First of all, for all those of you who registered for the Congress, you will have an access to all the talks, the plenary sessions, the tracks, the records will be available within 1 week from today, and it will be accessible for almost a month from the date it's available. So you can have access to that. But of course, special access for our members of the association. Because you are members, you can access these records at any time. But for those of you registered for the Congress, you can have access up to 1 month. Now, there was a problem with one of the sessions today, the lipid track session. And Professor Lee Kaplan, unfortunately, was not able, he had difficulty to connect with us. It was some technical defaults from his side. So he's going to be recording his talk, and his talk is going to be available in the lipid track on the day 3, as the program is showing, once you have a chance to visit the program again later on our website. We also need to notify you and inform you about the CME. CME will be available hopefully in 2 to 3 weeks. and this will be given by the Dubai Health Authority. And as soon as we will receive the CME hours, it will be distributed to you through your via your emails. But kindly, you need to fill up the evaluation forms or the survey form. You can find it on the Congress platform to the left. Under the section that it says survey, you can see the evaluation form over there. Please, we need your evaluation. It's very important for us, and we do learn a lot for future activities. We would like to apologize for any technical difficulties that you may have encountered on the platform or logging in. Our technical team were trying their best to sort things out, and that's unfortunately the drawback of having a virtual events. So hopefully we will be physical next year, and we don't have to go through all these technical difficulties. Great. So now it was a really fascinating 3 days, a very intense learning. Thank you very much, Dr. Nasser Al-Juhani, the chair of the scientific committee, and all members of the scientific committee for putting this excellent program. Thank you for our dear colleague, pediatric endocrinologist, for joining us in this Congress, and special thanks to Dr. Asma Deeb for being part of the scientific committee. We're so grateful for that. We would like to thank the pharmaceutical companies for their sponsorship and being with us. And of course, we would like to thank the event organizing Amber for organizing this event. Now, before we go to the closing remarks by our President-elect, Dr. Nasser Al-Juhani, I would like tonight to announce a very important winners of 2 important prizes here. So the first category that we're gonna announce today is the Ibn Sina Distinguished Service Award. Now, Ibn Sina Distinguished Service Award is a very unique and high standard award that we used to give it to distinguished colleagues in the field of endocrinology and diabetes in the region. And this award was established by the people from the region here. And it started back when we were originally a Gulf chapter. And we wanted to continue on with the legacy. It's very important to distinguish all these hardworking physicians in the field. And I am proud and grateful that we will be continuing giving this prestigious award to our distinguished colleagues in the field. So, and with great pleasure, tonight I would like to announce the 3 winners. We usually select 3 winners for the award every year. And we always try to be fair among the countries. So to start with, we have a winner from the Kingdom of Saudi Arabia, Professor Nasser Al-Daghri, and I will leave the platform to my colleague, Dr. Yusuf Al-Saleh, who is the immediate past president and a board member with us. He's gonna introduce the award to Professor Nasser Al-Daghri, and the floor is yours, Dr. Yusuf. Tfadal.
Thank you very much, Nasreen. Good evening, everybody. I do thank you all for attending this Congress and wish you all the best. Now, it takes me or gives me a great pleasure really to talk about Nasser. Professor Al-Daghri obtained his bachelor degree and master in biochemistry at King Saud University in Riyadh, and his PhD in clinical biochemistry at Birmingham University in UK back in 2003. He's a great scientist. Nasser is a great scientist and a great researcher. He authored more than 400 papers. One of the people who published a huge number of papers, not only in the Gulf region, but also all over the Middle East and maybe in the world. And a couple of years ago, the Stanford University has included his name in the list of the world's top 2% scientists. He's the Dean of the College of Science at King Saud University in Riyadh, and he just finished 2 terms as a Dean. He served as the chair of the biomarkers, the chair for biomarkers of chronic disease. This was in the past Prince Mut'ab chair for biomarkers of osteoporosis. He is the founder of the chair, published several papers as such. He's a fellow at the University of Warwick in Coventry in UK, a member of the WHO Collaborating Center for Public Health Aspects of Musculoskeletal Health and Aging. He published tremendously in the aspects of diabetes, hypertension, metabolic syndrome, and vitamin D. And personally, looking at the magnitude and the quality of his papers, I don't think there is somebody in the Arab world who published on vitamin D more than Nasser al-Daghiri. Not only that, he's one of the highly cited people, more than 1,000 citations for Nasser, and actually, sorry, 10,000 citations for Nasser so far. And one of the remarkable achievements he had, winning many Arab awards in the field of metabolic syndrome, diabetes, hypertension, and the micromolecules. He's very interested in proteomic research. He published a lot in epidemiology of vitamin D in school children and in adults in the Kingdom of Saudi Arabia. And it needless to say that one of the most distinguished persons in the kingdom is Professor Nasser al-Daghiri. We are really honored, pleased, and really happy to see him awarded by our prestigious association, the Gulf Association of Endocrinology and Diabetes. His CV is really so extensive. I might spend a lot of time talking about him, but to give the chance to our dear colleagues, I will stop at this stage. One small point to mention, he mentored several postgraduate students in the college. Many people across the kingdom are so grateful to Nasser for his mentorship, his great educational contribution to science in the Kingdom of Saudi Arabia and the Gulf. Professor Nasser al-Daghiri, with great honor, I deliver this distinguished award, Ibn Sina Distinguished Service Award, to you, and thank you for being with us tonight.
Thank you very much, Yusuf, for this one. I appreciate this one, and Assalamu alaikum wa rahmatullahi wa barakatuh. I'm deeply humbled and surprised by the honor given to me by Gulf Association Endocrinology and Diabetes, to the President, the Scientific Committee, the organizer member, and the guest of this great assembly, my colleagues. Thank you with all my heart. For more than a decade, and me and my team in KSU have really worked hard to provide basic and clinical research so that physicians like you will be informed for the advanced and major chronic disease affecting our region, and ultimately translate our finding, enhancing your practice and providing medical care. While this award is a symbol and acknowledgement of that hard work, the main prize, of course, to see an overall improvement in the quality of life of the people we serve. It is our responsibility to achieve that goal every day. My vision of creating world laboratory and research facility will not be possible without the help of my colleagues in the lab and the global readers in the field, the highly cited scientists, experts from ESCO, IOF, WHO, SOS, and Gulf Association Endocrinology and Diabetes, with whom I've shared common goal of serving the larger community through the academia. At this stage in my life, my mission now is to ensure that the next generation of experts in our region will continue and improve what we have started. Let us continue to inspire them by being responsible role models and acknowledging their effort by giving prestige award such as the one you have given me tonight. Again, I wish to thank you everyone for this wonderful honor. Thank you very much indeed, all of you. And thank you, Dr. Yusuf, for this nice presentation. Thank you very much indeed. Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum assalam. Congratulations, Professor Nasser Daghri. Excellent and outstanding achievements. Well deserved, well deserved. It's our honor and pleasure to hand you this award. We're going to move to our next winner of the Ibn Sina Distinguished Service Award. And I'm so delighted and it's our honor and so grateful to present this award to Professor Salim Bishia. Professor Salim Ghani al Tarif, very well known in the region. I will leave the floor to our board member, Dr. Bashar Effendi, to introduce and present the award to Professor Salim. Dr. Bashar, tafadhal.
Assalamu alaikum. Good evening. It's my privilege to introduce my dear friend Salim Bishaya for this prestigious award. We first met actually in Tunisia during the Arab Congress of Endocrinology in 2002. And 4 years later, he moved to the UAE. And here I got to know him very well, and we worked together on many projects. Salim qualified from the Medical School of Tripoli in 1981. Then he received his training in Glasgow under the sponsorship of the Royal College of Physicians from 1982 to 1986. This led his admission to the membership of MRCP in both Ireland and the UK in 1987. Following this, he trained as a registrar at Leicester under the supervision of Professor Felix Burden, 1987 to 1989, where he developed interest in diabetes, cultural issues in diabetes care, Ramadan, and diabetic food. He then moved to London for fellowship at St. Mary's Hospital Medical School on the consequences of hypoglycism, which was the subject of his thesis later on, under the mentorship of Professor Desmond Johnston. And of course, as expected, this resulted in many publications in very high impact journals. Dr. Bishaya worked as a consultant in diabetes and endocrinology at Harlow in Essex, UK for 10 years before moving to Sheikh Khalifa Medical City in Abu Dhabi, where he worked for 13 years. And then he moved to Mediclinic Airport Road in Abu Dhabi for 2 years. And now he works at Yas Clinic Khalifa City in Abu Dhabi. In addition, he has been an adjunct professor at Dubai Medical College for Girls since 2018. Professor Bishaya was a founding member and a past president of the Gulf chapter of ACE. And he also served as a treasurer of the Libyan Association of Diabetes and Endocrinology for about 5 or 6 years. As we all know, Salim is very passionate about publishing and writing, and his work on advancing the cause of regional research and publishing always. He was an editor-in-chief for the Ibn Sina Journal for 7-8 years. And recently he was appointed as the editor-in-chief for our journal, the Journal of Diabetes and Endocrine Practice, our official journal. It's really my great pleasure to present Dr. Salim Bishia to have this prestigious award. Dr. Salim.
Assalamu alaikum. Good evening, ladies and gentlemen, and all colleagues and friends. I'm really deeply touched and immensely honored by the selection to receive the Ibn Sina Distinguished Service Award from the Gulf Association of Endocrinology and Diabetes for this year. I dedicate this award to my parents, my wife, my family, for lifelong inspiration and support. I dedicate it also to my mentors and teachers, past, present, and future, and also to my students and patients. I have actually, over the last 15 years or so, enjoyed working very much with many of you here in this audience and outside this audience in patients' care, education, and research in all capacities. And I'm really proud to be nominated to rank amongst the recipients of this award that has been in the first few years amongst the forefathers of clinical endocrinology in the Gulf. And I'm really proud to be aligned with them, having achieved this in such short time. I'm really very grateful for the nomination and the selection by the association, and I thank you very much.
Congratulations, Professor Salem, well deserved. Alf Mabruk. We move to the third winner of the Ibn Sina Distinguished Service Award, and our third winner is Professor Mahmoud Zarai. And again, Professor Mahmoud Zarai, very well-known figure in the diabetes and endocrinology field in the region. I will leave the platform to Dr. Tariq Al-Had to present the award to Professor Mahmoud Zarai. Fadal, Dr. Tariq.
Thank you very much, Nasreen. Ladies and gentlemen, it takes me special pleasure actually to welcome Dr. Mahmoud Zarai as an awardee of this very distinguished service award. And I feel that he has deserved it very well through his unprecedented accomplishment and achievements. Dr. Mahmoud Zarai qualified from Jordanian University Medical School, and then after he obtained the Jordanian Board of Medicine, he moved to Qatar, where actually he was amongst the first actually recipients of the Arab Board degree at the time in 1989. Following that, he moved to US, where he underwent a 2-year residency program, culminated in him getting his Board of Medicine. And then he moved further to Mysore Medical University, where he actually got his fellowship in endocrinology and diabetes in 1996. Mahmoud moved back to Qatar in 1996 in the same year, and from 1997 he was appointed as the head section of endocrinology as part of Department of Medicine. And he has been actually chief of the section since then. And during his tenure, which spanned over 2 decades, Mahmoud has actually contributed a lot. You can imagine from only 3 physicians in the section, now the section is one of the largest actually in the Gulf region, with over 40 consultants and senior consultants. Not only that, Mahmoud has expanded the service together with others to encompass actually from only 1 diabetes center in Hamad General Hospital to around 4 diabetes centers between several allied hospitals as part of the Hamad Medical Corporation. Dr. Mahmoud, he actually masterminded and actually was an advocate for training and education for the allied healthcare professional. And in 2002, he started the Diabetes Educators Training Program. And that began with a single actually candidate, and now the number rocketing to 40. He also helped to set up an excellent system for diabetes retinopathy screening. And further, he also established the first podiatric clinic actually in the diabetes center at the Hamad General Hospital, which actually then propagated to be a fully fledged actually podiatry department, now occupying a whole floor in a new building in the new Hamad General Hospital premises. Dr. Zarai has been very active, not only locally, but regionally. He was among the founding fathers of the AS Gulf chapter, and he served as one of the board of directors for several years. He has been very active in supporting Qatar Diabetes Association and he has been serving as the head of its scientific committee, planning its meetings and its all educational activities through the years. Mahmoud also has been very proactive in setting up many research projects, and he's quite actually, you know, has an impressive record of over 70 papers in peer-reviewed journals. I had great pleasure actually of working with him, and it takes me special pleasure actually to award this very distinguished service award to Mahmoud. Mahmoud, the floor is yours.
Bismillah ar-Rahman ar-Rahim. Good evenings, my colleagues, ladies and gentlemen. Thank you, dear Tariq, for this really nice and comprehensive introduction. I am honored and privileged to be nominated by my colleagues in the Gulf Association of Endocrinology and Diabetes to receive this prestigious award. As my colleague, Dr. Tariq, just mentioned, I worked collaboratively with my colleagues in Qatar and in the region to improve the clinical care and the multidisciplinary team for our patients. It's my pleasure to announce something related to allied health professionals. As you know, the one example of them is diabetes educators. As you know, we don't have really a training program for diabetes educators. Our team worked together in association with College of North Atlantic to establish a training program for diabetes educators. Initially, we made it like a 6 months course, then 1 year diploma. And from this year onward, it will be 2 years master degree in health education. So our colleagues, if are most welcome to send their diabetes educator trainee if they wish to come to join our program. This opportunity is available, and I know in the region we don't have such program. So it's my pleasure to work with my colleagues in Qatar and in the region to establish different societies. One of them was the Gulf Group for Study of Diabetes and the Gulf Association for Endocrinology and Diabetes. I am grateful to my colleagues for this nomination to have this award, and such awards will really encourage our colleagues, junior and senior colleagues, to provide excellent service for patient care, research, and education. Thank you all for the nomination, and good night.
Thank you, Professor Mahmoud. Alf Mabruk, congratulations, well deserved. Big congratulations again to all our winners of the Ibn Sina Distinguished Service Award. Great achievements, outstanding performance in the region, and we hope to see your continuous performance and achievements in the region. Thank you very much. And now we will move on to the abstract and poster winners. So, and I know that those who submitted their work, they are now eagerly waiting to see the results of the evaluations of the abstract. So just to brief you that we have received about 111 submissions, 22 were rejected and 89 accepted. And out of those, there were 5 oral presentations. I hope for those of you who are attending tonight, you had the chance to attend the oral presentations, fascinating presentations from the researchers given at the beginning of the day today during the Congress. Would like to thank them all for their hard work. And also we had 84 posters, 63 of them were like fully completed posters and presented in the exhibition, poster exhibition area and room. Hope all of you had the chance to pay a visit and look at these posters and the excellent work by the researchers. And with that, we would like to announce the winners. We'll start announcing the winners of the oral presentations, oral abstract presentations for today. So I would like to congratulate our winners. First place, Dr. Ahmad Burma, for the presentation and the research paper on the prevalence of diabetic peripheral neuropathy in the Arabian Gulf region. Congratulations, Dr. Ahmad. And the second winner, Dr. Georgios Ponirakis, for the paper on risk factors associated with progression of diabetic neuropathy. Congratulations. And the third place for Dr. Walid Kaplan for his paper on short stature assessment and referral in the Gulf region. Congratulations, Dr. Walid. Congratulations for all the winners of the oral abstract presentations. Excellent work. Very grateful to have your papers presented in our Congress. We move on now to the winners of the poster presentations. And we can see there was some competition and some of the papers achieved sort of equal marking. And that's why we can see that repeated ranking. So the first place goes to Dr. Ghada Al-Khatib. Congratulations. This was for the poster on circulating interleukin-17 alpha and IFN and gamma levels in cirrhotic hepatitis C virus infected patients with autoimmune thyroiditis. Well done, Dr. Ghada. And the first place repeated is for Dr. Abdullah Al-Jabiri. Congratulations for his poster on toxic multinodular goiter, epidemiological, clinical, biochemical, and radiological features. And the third place repeated goes to Dr. Salem Bishaya, and another winning prize tonight. Management of thyroid nodules, a survey of perceptions and practices of physicians from the Middle East and Africa. And the third place repeated for Dr. Omar Al-Husni for his poster on hyperprolactinemia, epidemiological, clinical, biochemical, and radiological features. Congratulations for all the winners. Excellent work. Well deserved. Thank you very much for presenting your posters at our annual Congress. And hope and good luck for the rest of the researchers who submitted their work and paper. And we encourage you to submit your research abstracts and other work, hopefully with our next upcoming annual Congress next year, inshallah. And with that, I think I would like to finally thank the abstract reviewers, led by the head of the abstract committee, Dr. Khalid Al-Dahmani. And we had our abstract committee from the board, Dr. Bashar Effendi, Dr. Tariq Al-Had, Dr. Wa'am Hussein. And I would like to, Dr. Thamer Al-Isa, and also would like to thank our external reviewers with the abstract committee, Dr. Huda Azzuddin, Dr. Ali Al-Qarni, Dr. Mu'abbar Al-Mahrazi, Dr. Awad Al-Shahrani, Dr. Muhammad Suleiman, and Dr. Muhammad Al-Lamki. Thank you very much for your time and efforts with us. Truly appreciated. Thank you. And with that, I would like to again thank you all for attending this annual Congress for the Gulf Association of Endocrinology and Diabetes, the voice of endocrinologists in the region. And I hope you had really an informative and fruitful experience over the last 3 days. Thank you very much. As I said earlier, you can get the recording for the talks, the plenaries, and all the tracks on demand will be available 1 week from today, and it's going to be available for a period of a month. But of course, the members will have access all the time, along with the access to the webinars. Thank you very much. It was a pleasure having you all with us over the past 3 days. I would leave the floor now to Dr. Nasser Al-Juhani, our president-elect, president-to-be for the Gulf Association of Endocrinology and Diabetes. Dr. Nasser, the floor is yours.
Thank you, Dr. Nasreen, for this introduction. Good evening, ladies and gentlemen, dear colleagues and friends. My name is Nasser Al-Juhani from Saudi Arabia, Jeddah. Really, I am very honored and delighted to deliver the concluding remark in the last day of annual virtual Gulf Association of Endocrinology and Diabetes Congress, which was running for the past 3 days. It was really very rich program, and we'll recognize the speaker. First of all, really, I want to thank all the GAED Board of Directors and Advisory Board for their support, trust, and tremendous effort to make this event happen. Now that we come to the end of this Congress, I would like to express my warmest thanks to the Scientific Committee, as well as the Abstract Committee, for their dedications and meticulous work. And also special thanks for pharmaceutical companies for their support. And also don't forget Amber, our event organizer, the special thank for Mr. Rafat for his endless effort. Lastly, I would like to thank all the Congress participants, our eminent speakers, and the chairs for their contribution. Also, those who different committees and those who send abstract. Also, I want to assure you that we will follow the same Gulf Association of Endocrinology and Diabetes mission and vision to ensure optimal care and the highest standard of practice for patients with endocrine disease, diabetes, and related metabolic disorders in the Arabian Gulf countries. Before I conclude, really, I want to have 2 small announcements. The first one, the next year annual Congress for the Gulf Association of Endocrinology and Diabetes will be conducted in October in Saudi Arabia. The second announcement, tomorrow will be the meeting of the General Assembly for the Gulf Association of Endocrinology and Diabetes. Emails will be sent tonight to all active members in the association. Thank you again, and goodbye, and see you in the future events.